Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about celiac disease and inflammatory bowel disease. If you're unfamiliar with how the structure of the podcast goes, I'm just the host that talks about these topics, but I don't know them, so I have AI with me, which is our guest. In this situation, Grok is going to be explaining to us these topics today. And we will take everything Grok says with a pinch of salt, as it might be inaccurate at times. So, cross reference everything you hear to proper science, and without further ado, let's get into today's topic. Grok, let's start with celiac disease. What is celiac disease?
Celiac disease is an autoimmune disorder where eating gluten, a protein in wheat, barley, and rye, triggers an immune response that damages the small intestine's lining. This leads to nutrient absorption problems, causing symptoms like diarrhea, bloating, fatigue, and weight loss.
Interesting. So it's an autoimmune disease. It's gluten sensitive. It's got to do with the intestines, with the GI. Gluten is a protein. Okay. So what are the genetic abnormalities of celiac disease?
Celiac disease is strongly linked to specific genetic markers, primarily the HLA-DQ2 and HLA-DQ8 genes, which are present in about 95% of patients. These genes influence immune response, making the body react abnormally to gluten, though having them doesn't guarantee the disease, as environmental factors also play a role.
So what is chromosome 6p21 and how this is linked?
Chromosome 6p21 is the region where the HLA genes, specifically HLA-DQ2 and HLA-DQ8, are located, which are critical in celiac disease. These genes code for proteins that present gluten fragments to immune cells, triggering an autoimmune attack on the small intestine in genetically susceptible individuals.
And what about people with Down syndrome, type 1 diabetes, and autoimmune hepatitis? Are these people more susceptible?
People with Down syndrome, type 1 diabetes, and autoimmune hepatitis are more susceptible to celiac disease due to shared genetic and autoimmune predispositions, particularly involving HLA genes. Down syndrome increases the risk about 5-10 times, while type 1 diabetes and autoimmune hepatitis patients have a 5-7% and up to 20% chance, respectively, of developing celiac disease.
Okay. And how does gluten cause celiac disease? What does gluten do with the small bowel mucosa? Talk to me about transglutaminase, diamidates, glutamine and gliadin, interleukin 15. What's going on?
Gluten, specifically its gliadin component, triggers celiac disease in genetically susceptible people by interacting with the small bowel mucosa. When gluten is ingested, tissue transglutaminase, an enzyme, not glutaminase, deamidates gliadin, converting glutamine residues into negatively charged residues that bind strongly to HLA-DQ2 or HLA-DQ8 on immune cells. This sparks an immune response where interleukin 15, produced by intestinal cells, amplifies inflammation, activating T cells that attack the mucosa, damaging the villi, finger-like projections that absorb nutrients. Over time, this flattens the villi, reducing surface area and causing malabsorption, leading to symptoms like diarrhea and malnutrition.
So what is tissue transglutaminase and what are diamidates? What they have to do? And what is this negatively charged protein have to do? Interleukin 15 specifically? What do natural killer cells have to do? Intraepithelial T lymphocytes? And how does eventually tissue destruction occur?
Tissue transglutaminase is an enzyme in the small intestine that modifies gliadin by deamidation, turning its glutamine residues into glutamic acid, creating negatively charged proteins that bind tightly to HLA, DQ2, or DQ8, triggering an immune response. This process, not involving diamanides, likely a misinterpretation of deamidation, activates interleukin 15, which rallies natural killer cells and intraepithelial lymphocytes, immune cells in the gut lining, to attack the mucosa, causing inflammation and villus atrophy, where the intestinal villi are destroyed, leading to tissue damage and malabsorption.
Got it. Wow, that's such a big process. And the normal small bowel lining, they're like finger-like. Well, what about the abnormal?
The normal small bowel lining has finger-like villi that maximize nutrient absorption, but in celiac disease, the abnormal lining becomes inflamed and damaged due to the immune response to gluten. The villi flatten or disappear, a process called villus atrophy, leaving a smooth, scarred surface that severely impairs nutrient uptake, causing symptoms like diarrhea and malnutrition.
Okay, so what are the symptoms of celiac disease? Talk to me about how flat mucosa might not be able to absorb nutrients, and how we detect celiac disease too. Tell me the difference between classical and atypical celiac disease.
Celiac disease symptoms vary widely. Classical celiac disease presents with gastrointestinal issues like diarrhea, bloating, abdominal pain, and weight loss, caused by flat mucosa villus atrophy, which reduces the small intestine's surface area, impairing nutrient absorption and leading to malnutrition, fatigue, and deficiencies like anemia or osteoporosis. Atypical celiac disease may show suppler or non-GI symptoms, such as joint pain, dermatitis herpetiformis, an itchy skin rash, infertility, or neurological issues like ataxia, often with less obvious nutrient malabsorption. Detection typically involves blood tests for antibodies like anti-tissue transglutaminase or anti-endomysial antibodies, followed by a small intestine biopsy to confirm villus atrophy, though genetic testing for HLA DQ2, DQ8 can support diagnosis.
I want you to quiz me on these things you just said. Just like give me 5 rapid quiz questions. I'll answer it in a couple of words, and I'll answer in a couple of words.
All right, here we go with 5 rapid-fire questions on celiac disease. 1. What protein triggers celiac disease? 2.
No,
Name
no,
one.
dude. Give them one by one. We're not in a rush.
My bad. Let's take it one by one. First question. What protein triggers celiac disease?
Gluten.
Nice, spot on. Next question. Name one genetic marker linked to celiac disease.
Those weird ones. HLA DQ2. Can you explain what they mean? Before we go to question 3, what does HLA DQ2 mean? What's this acronym?
HLA DQ2 stands for human leukocyte antigen, specifically the DQ2 subtype, which is a protein encoded by genes on chromosome 6p21 that helps the immune system recognize foreign substances. In celiac disease, HLA DQ2 binds to gluten fragments, triggering an autoimmune response that attacks the small intestine in genetically susceptible people. All right, ready for question 3. What enzyme deamidates gliadin in celiac disease?
Tissue transglutaminase.
You got it. Question 4. What's one gastrointestinal symptom of classical celiac disease?
I forgot. What, also, tell me, but why is tissue transglutaminase called tissue transglutaminase?
Tissue transglutaminase is called so because it's an enzyme found in tissues that catalyzes the cross-linking of proteins by forming bonds between glutamine and lysine residues, or in celiac disease, it deamidates gliadin, enhancing its immunogenesis. The trans refers to its ability to transfer or modify these protein groups, and glutaminase relates to its interaction with gliadin, though it's distinct from true glutaminases that break down glutamine differently. Now, back to that fourth question. What's one gastrointestinal symptom of classical celiac disease?
I'm not sure, can you tell me? Tell me, dude.
All right. One gastrointestinal symptom of classical celiac disease is diarrhea. Ready for the fifth question?
No.
Name one.
We're all good. Okay, let's talk a bit about these symptoms then. So diarrhea, smelly bulky stool, rich in fat, flatulence, borborygmus. Explain what these are. Flatulence, borborygmus.
Flatulence is the buildup and release of gas in the digestive tract, often caused by fermentation of undigested food in celiac disease, leading to bloating and frequent passing of gas. Borborygmus refers to the rumbling or gargling sounds in the intestines, caused by gas and fluid moving through the gut, which can be more noticeable due to the inflamed, malabsorptive small intestine in celiac disease.
Okay. I don't understand what borborygmus and flatulence are.
Flatulence is when gas builds up in your gut, often from undigested food fermenting, and gets released as farts, causing bloating or discomfort, common in celiac disease due to poor absorption. Borborygmus is the fancy term for those loud, gurgling noises your stomach or intestines make when gas and liquids slosh around, more noticeable in celiac because the inflamed gut moves things unevenly.
Okay. Tell me a typical celiac disease now. Tell me extra intestinal symptoms such as anemia, osteopenia, osteoporosis, itchy skin, lack of periods, pins and needles, loss of balance. Why would we have all these?
Atypical celiac disease often presents with extraintestinal symptoms rather than classic gut issues, as the autoimmune response to gluten affects various systems due to chronic inflammation and nutrient malabsorption from damaged small intestine villi. These can include anemia from iron or B12 deficiency, causing fatigue, osteopenia or osteoporosis, and confusion from calcium and vitamin D malabsorption, weakening bones, itchy skin from dermatitis herpaphoresis, a blistering rash linked to gluten, amenorrhea, lack of periods due to hormonal disruptions or malnutrition, pins and needles from peripheral neuropathy related to B vitamin deficiencies, and loss of balance from ataxia caused by gluten affecting the nervous system, particularly the cerebellum. These symptoms arise because the body struggles to absorb key nutrients like iron, calcium, and vitamins, while the immune response may directly attack tissues like skin or nerves,
That makes
even
a
without.
lot of sense. Okay, and what about emaciation? What is this? And pot belly due to gaseous distension?
Emaciation in celiac disease refers to extreme weight loss and muscle wasting due to severe nutrient malabsorption from the damaged small intestine, leaving the body starved of calories and protein, often seen in advanced or untreated cases. A pot belly from gaseous distension happens when undigested food ferments in the inflamed gut, producing excess gas that bloats the abdomen, creating a swollen appearance despite overall thinness, especially common in children with celiac disease.
I don't understand emaciation.
Emaciation is when someone becomes extremely thin, almost skeletal, due to severe weight loss and muscle wasting, often because the body can't absorb enough nutrients, like in untreated celiac disease, where the damaged small intestine prevents proper uptake of calories, proteins, and fats. It looks like a starved, gaunt appearance, with visible bones and little muscle or fat left, distinct from normal slimness.
And what's the etymology of this word?
The word emaciation comes from the Latin emaciatus, the past participle of emaciare, meaning to make lean or waste away, derived from e, out, and macies, leanness or thinness. It evolved through Old French and Middle English to describe the extreme thinness seen in conditions like celiac disease, where nutrient malabsorption causes severe weight loss.
Okay. And let's talk a bit about investigations for celiac disease. So FBC, UNEs, LFTs, what are these? Talk to me about serology, talk to me about IgA, tissue transglutaminase IgA, endomysial IgA, yeah, do DNA biopsies.
All right, let's dive into investigations for celiac disease. First, the abbreviations. FBC is a full blood count, checking for anemia or low platelets, often seen in celiac due to nutrient deficiencies. U&Es stands for urea and electrolytes, assessing kidney function and electrolyte imbalances. LFTs are liver function tests, which can be abnormal in celiac due to inflammation or nutrient issues. Serology is key for celiac diagnosis, focusing on specific antibodies. IgA, tissue transglutaminase, TTG-IGA, is the primary test, highly sensitive and specific, detecting antibodies against tissue transglutaminase, the enzyme involved in gluten's autoimmune response. IgA endomysial antibodies, EMA-IGA, are another test, less commonly used but very specific, targeting the connective tissue around smooth muscle. Since these tests rely on IgA, total IgA levels are checked to rule out IgA deficiency, which can cause false negatives. If deficient, IgG-based tests like deaminated gliadin peptide, DGP, IgG, are used. If serology is positive or suspicion remains high, a small intestine biopsy is done via endoscopy, taking samples from the duodenum to confirm villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytes, hallmarks of celiac disease. These findings, combined with serology and clinical symptoms, seal the diagnosis, though genetic testing for HLA DQ2, DQ8 can help in unclear cases.
Okay. So tell me about the main test again.
The main tests for celiac disease start with serology, specifically the IgA tissue transglutaminase TTG-IGA test, which detects antibodies against the enzyme triggered by gluten, and checking total IgA levels to avoid false negatives due to IgA deficiency. If serology is positive or suspicion persists, a small intestine biopsy via endoscopy confirms the diagnosis by showing villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytes in the duodenum.
I don't get it. Explain it one more time very simply.
To diagnose celiac disease, doctors first do a blood test called IgA tissue transglutaminase, TTG-IGA, to check for antibodies caused by gluten, and they also test total IgA to make sure the results are reliable. If the blood test suggests celiac or symptoms are strong, they take a small piece of the small intestine during an endoscopy to look for damaged villi and inflammation, which confirms the disease.
So we do something with the IgA.
Yeah, in celiac disease testing, the IgA tissue transglutaminase, TTG-IGA blood test is key, detecting antibodies your body makes against tissue transglutaminase when gluten triggers an immune response. They also check your total IgA levels to ensure the test isn't falsely negative due to IgA deficiency, which can mess up the results.
So Just a sec, guys.
All right,
So
taking a quick...
what's going on with so IgA is IgA tissue transglutaminase?
IgA tissue transglutaminase, or TTG-IGA, is a specific antibody test for celiac disease, where IgA refers to the immunoglobulin A class of antibodies your immune system produces. It's not IgA itself, but the test that detects IgA antibodies targeting tissue transglutaminase, an enzyme that gluten interacts with, triggering the autoimmune damage in the small intestine.
Is it or is it not?
Sorry, I'm not sure what you mean by is it or is it not. Could you clarify if you're...
Transglutaminase tissue, is it the same as IgA?
No. Tissue transglutaminase, TTG, and IgA are not the same. Tissue transglutaminase is an enzyme in the body that modifies gluten, triggering an immune response in celiac disease, while IgA is a type of antibody that the immune system produces, and the TTG-IGA test detects IgA antibodies, specifically targeting tissue transglutaminase to diagnose celiac disease.
Okay.
All right, so we've been diving deep into...
Why do we call it tissue transglutaminase IgA?
We call it tissue transglutaminase IgA, or TTG-IGA, because the test detects IgA antibodies that specifically target tissue transglutaminase, the enzyme in the body's tissues that gets attacked by the immune system in celiac disease when gluten is present. The IgA part refers to the type of antibody, immunoglobulin A, being measured, and tissue transglutaminase is the antigen or target the antibodies bind to, making it a clear name for this diagnostic test.
And what are the microscopic features of celiac disease?
Under a microscope, celiac disease shows villus atrophy, where the small intestine's finger-like villi are flattened or gone, reducing nutrient absorption, along with crypt hyperplasia, where the intestinal crypts deepen due to increased cell turnover. You also see increased intraepithelial lymphocytes, immune cells infiltrating the gut lining, causing inflammation and damage.
Interesting. Villus atrophy. So explain crypt hyperplasia again and tell me about the increase in lymphocytes in the lamina propria too.
Crypt hyperplasia in celiac disease means the crypts, which are the deeper, tubular parts of the small intestine's lining, where new cells are made, get longer and more crowded as the body tries to replace damaged cells faster due to gluten-triggered inflammation. The lamina propria, the connective tissue layer beneath the intestinal epithelium, also shows an increase in lymphocytes, immune cells like T cells that infiltrate and drive inflammation, further damaging the mucosa, alongside the intraepithelial lymphocytes already attacking the surface.
Okay, so tell me a bit about complications now. Enteropathy associated with T-cell lymphoma, high risk of adenocarcinoma of small bowel, dermatitis herpetiformis.
Celiac disease can lead to serious complications if untreated. Enteropathy-associated T-cell lymphoma, a rare but aggressive cancer, arises from chronic inflammation in the small intestine, while the damaged mucosa also increases the risk of small bowel adenocarcinoma, another rare malignancy. Dermatitis herpetiformis, an intensely itchy, blistering skin rash, occurs in about 10 to 15% of celiac patients due to gluten-triggered immune deposits in the skin. These complications are linked to prolonged gluten exposure, highlighting the need for a strict gluten-free diet to reduce risks.
Tell me more about this. Can you explain it a lot very simply, please?
Okay, let's break down those complications of celiac disease super simply, like I'm explaining it to a friend. First, celiac disease, when you don't treat it by avoiding gluten, can cause big problems because the immune system keeps attacking the small intestine, making it inflamed and damaged for a long time. This ongoing damage sets the stage for some serious issues. One complication is called enteropathy-associated T-cell lymphoma. That's a mouthful, I know, but basically, it's a rare type of cancer that can grow in the small intestine. The constant inflammation from gluten makes certain immune cells, called T cells, go haywire over years, and in rare cases, they turn cancerous. It's like the immune system, trying to fight gluten, gets so overworked, it starts causing trouble itself. Another issue is a higher risk of adenocarcinoma of the small bowel. This is another type of cancer, also rare, where the cells lining the small intestine start growing out of control. The damaged, inflamed lining from celiac disease makes it easier for these cancer cells to develop, kind of like how a scratched surface is more likely to get worse if you keep irritating it. Then there's dermatitis herpetiformis, which is a super itchy, bumpy, blistery skin rash that about 1 in 10 celiac patients might get. It's not cancer, but a skin reaction to gluten. Your immune system, annoyed by gluten, creates antibodies that end up in your skin, causing these itchy patches, usually on elbows, knees, or your back. It's like your body's yelling, "Get this gluten out," through your skin. All these happen because gluten keeps triggering the immune system to attack the body intestine for cancers,
What
skin
is
for
this
the
T-cell lymphoma, though?
enteropathy-associated T-cell lymphoma is a rare aggressive cancer that can develop in the small intestine of people with untreated or poorly managed celiac disease. It happens when T cells, a type of immune cell, become cancerous due to long-term inflammation from gluten, damaging the intestinal lining, leading to symptoms like abdominal pain, weight loss, or obstruction.
And we are not very sure about gluten-free diet if it's actually going to reduce the risk of complications.
A strict gluten-free diet is widely accepted as the most effective way to reduce the risk of complications in celiac disease, like T-cell lymphoma, small bowel adenocarcinoma, and dermatitis herpetiformis, by stopping the autoimmune attack on the small intestine. Studies show that adhering to the diet for at least 3-5 years can significantly lower these risks, though some uncertainty remains in rare cases where damage persists or cancers develop despite compliance.
Can you reference these studies, please, and be very, very, very scientific with them?
All right, let's dive into analyzing studies on the effect of a gluten-free diet, GFD, on reducing the risk of complications like enteropathy-associated T-cell lymphoma, EFD, and small bowel adenocarcinoma and celiac disease, focusing on a rigorous scientific approach. Given the context, I'll evaluate key studies, scrutinize their methodologies, and synthesize findings, maintaining a critical eye on the data and avoiding over-reliance on any single narrative. I'll keep responses concise, as if speaking aloud, and limit to 2 sentences per message, per your preference. A pivotal study by Solano et al., 2008, followed 1,757 celiac patients over 31,801 person-years, finding that strict GFD adherence reduced the standard morbidity ratio for EFD from 6.42 to 0. That's a 95% CI of 0.02, 0.88, p plus 0.001. The significant drop suggests a protective effect, but the observational design limits causal inference, and dietary compliance was self-reported, introducing potential bias. The same study noted that only 2 of 9 EFD cases occurred in strict GFD adherence with a significant risk, X naught GWAT plus 6 naught GWAT plus P naught 1, and those with dietary gluten intake. This supports a protective role of GFD, though the small number of EFD cases reduces statistical power and calls for...
Let's jump to inflammatory bowel disease. What constitutes inflammatory bowel disease?
Inflammatory bowel disease, or IBD, including Crohn's disease and ulcerative colitis, is caused by a mix of genetic predisposition, immune system dysfunction, environmental triggers, and gut microbiome imbalances. Specific genes like NOD2 increase susceptibility, while factors like smoking, stress, or a Western diet can trigger an overactive immune response that attacks the gut lining, leading to chronic inflammation.
The main ones, it seems to me, are Crohn's disease, ulcerative colitis, and diverticular disease.
Actually, Crohn's disease and ulcerative colitis are the main types of inflammatory bowel disease, IBD, characterized by chronic immune-mediated inflammation of the gut. But diverticular disease isn't classified as IBD. It's a separate condition involving pouches, diverticula, and the colon that can become inflamed, diverticulitis. Crohn's can affect any part of the digestive tract, often with patchy, deep inflammation, while ulcerative colitis is limited to the colon, causing continuous, superficial mucosal inflammation.
Okay. Let's talk a bit about Crohn's disease. It's often complicated by fibrosis and obstructive symptoms. Tell me about it, and tell me about it epidemiology too.
Crohn's disease is a chronic inflammatory bowel disease, causing inflammation anywhere from mouth to anus, often in the ileum or colon, with patchy, deep lesions leading to complications like fibrosis, scarring, and obstructive symptoms such as abdominal pain, bloating, or bowel blockages due to narrowed gut segments. Epidemiologically, it affects about 1-2 per 1,000 people in Western countries, with higher incidence in North America and Europe, peaking in young adults, 15-35 years, slightly more common in females, and linked to genetic factors, e.g., NOD2 mutations and environmental triggers like smoking.
Okay. And what causes it then?
Crohn's disease is caused by a complex interplay of genetic predisposition, like NOD2 gene mutations, an overactive immune system attacking the gut, environmental factors such as smoking or high-fat diets, and gut microbiome dysbiosis. These trigger chronic inflammation, leading to tissue damage, fibrosis, and symptoms like diarrhea, pain, and obstructions, though the exact initiating factor remains unclear.
Interesting. Let's talk about the genetics of Crohn's disease then.
Crohn's disease has a strong genetic component, with over 200 susceptibility loci identified, the most significant being the NOD2 gene on chromosome 16, which increases risk by impairing immune responses to gut bacteria. Other key genes, like ATG16L1 and IRGM, affect autophagy, disrupting bacterial clearance and fueling chronic inflammation in the gut.
And what is NOD2 gene?
The NOD2 gene, located on chromosome 16, encodes a protein that acts as an intracellular sensor for bacterial components, helping regulate immune responses in the gut. In Crohn's disease, NOD2 mutations impair this function, leading to an overactive immune response against gut bacteria, triggering chronic inflammation.
Okay, is there a possible infectious cause of Crohn's disease?
Some evidence suggests an infectious cause for Crohn's disease, with bacteria like Mycobacterium avium subspecies paratuberculosis, MAP, and adherent invasive Escherichia coli, AIEC, implicated in triggering or exacerbating inflammation in genetically susceptible individuals. However, no single pathogen is consistently proven causative, and infections likely act as environmental triggers alongside genetic and immune factors, rather than sole causes.
Okay. And what environmental factors are implicated in Crohn's disease? Tell me about the improved hygiene hypothesis.
Environmental factors linked to Crohn's disease include smoking, which worsens disease severity, high fat or processed food diets, urban living, and stress, all of which can disrupt gut microbiome.
Keep going.
All right, so picking up on environmental factors for Crohn's disease and the improved hygiene hypothesis, reduced exposure to pathogens in early childhood due to cleaner environments, like in urban or Western settings, may prevent the immune system from developing proper regulation. This can lead to an overactive immune system later, contributing to chronic inflammation in genetically susceptible people, though the exact mechanisms are still under study.
Okay. So what exactly is it though?
The improved hygiene hypothesis for Crohn's disease suggests that growing up in overly clean environments with less exposure to germs, parasites, or bacteria stops the immune system from learning how to balance its responses properly. This can make it overreact to harmless gut bacteria later in life, triggering chronic inflammation in those with genetic risks, like NOD2 mutations, contributing to Crohn's.
And what is the evidence for this?
Evidence for the improved hygiene hypothesis in Crohn's disease comes from epidemiology studies showing higher Crohn's symptoms in developed countries with better sanitation, like North America and Western Europe, compared to developing regions. Observational data, such as a 2008 study in gastroenterology, finding lower Crohn's rates in areas with higher childhood exposure to infections, and animal studies showing altered gut immunity in sterile environments support the idea that limited microbial exposure early in life disrupts immune tolerance, though direct causal proof remains limited.
I see. Okay, now let's talk a bit about the clinical features of Crohn's disease.
Crohn's disease typically presents with abdominal pain, chronic diarrhea, often with blood, weight loss, and fatigue, due to patchy inflammation that can affect any part of the digestive tract, most commonly the ileum and colon. Complications like fistulas, abscesses, or strictures may cause additional symptoms such as fever, severe pain, or bowel obstruction, while extraintestinal issues like joint pain, skin rashes, or eye inflammation can also occur.
Okay. So, what's the distribution of Crohn's disease?
Crohn's disease can affect any part of the digestive tract, from mouth to anus, but it most commonly involves the terminal ileum and colon, with about 50% of cases showing ileocolic involvement, 30% limited to the small intestine, and 20% confined to the colon. Inflammation is patchy, with skip lesions, healthy areas between inflamed segments, unlike the continuous inflammation and ulcerative colitis.
Okay, let's talk a bit about the morphological features of Crohn's disease.
Crohn's disease shows patchy, transmural inflammation with deep ulcers, cobblestone mucosa, and skip lesions in the gut wall, often in the ileum or colon, visible on endoscopy or imaging. Microscopically, there's granulomatous inflammation with non-caseating granulomas, lymphoid aggregates, and fibrosis, which can lead to strictures or fistulas.
So remind me, when we compare Crohn's with ulcerative colitis, one is continuous, the other isn't, and one has granulomas and the other doesn't. Which is which?
Crohn's disease and ulcerative colitis are compared because both are types of inflammatory bowel disease with overlapping symptoms like diarrhea and abdominal pain, but they differ in their patterns and pathology. Crohn's has patchy, discontinuous inflammation, skip lesions, with non-caseating granulomas, and can affect any part of the gut, while ulcerative colitis shows continuous inflammation limited to the colon and rectum, without granulomas.
How is it that one is not continuous with and the other is continuous without?
Crohn's disease has discontinuous inflammation because it involves patchy immune responses triggered by genetic and environmental factors, like NOD2 mutations or gut bacteria, targeting specific gut segments, leaving healthy areas in between, called skip lesions. Ulcerative colitis has continuous inflammation because the immune attack, possibly driven by different genetic loci and microbial triggers, uniformly affects the colon's mucosal layer, starting from the rectum and spreading proximally, without gaps.
Okay. Interesting. Okay, and let's talk a bit about why is it that we don't have a continuous one with granulomas?
In Crohn's disease, the immune system's attack is patchy.
In general. So we have something called Crohn's, not continuous with granulomas. We have something called ulcerative colitis, continuous without granulomas. Why don't we have one category which is something else, which is continuous with granulomas?
The reason we don't commonly see a category of inflammatory bowel disease that's both continuous and has granulomas is likely due to the distinct immunological and genetic mechanisms driving Crohn's disease and ulcerative colitis, which shape their unique patterns. Crohn's disease involves deep, patchy inflammation with granulomas clusters of immune cells because of specific triggers like NOD2 mutations that cause a scattered, granulomatous response to gut bacteria, while ulcerative colitis involves a continuous, superficial inflammation without granulomas, likely driven by different immune pathways affecting the colon uniformly. A continuous, granulomatous pattern is rare in IBD because the conditions favoring granuloma formation, like in Crohn's, tend to be focal rather than diffuse, and diseases with granulomas, like tuberculosis or sarcoidosis, don't typically mimic the continuous mucosal involvement of ulcerative colitis. Some overlap syndromes or unclassified IBD cases might show mixed features, but a distinct category with both traits isn't well established due to these differing disease processes.
Okay. Let's talk about fat wrapping in Crohn's disease. And cobblestones too, and strictures and skip lesions.
In Crohn's disease, fissuring refers to deep, knife-like ulcers that penetrate the gut wall, contributing to complications like fistulas or abscesses due to transmural inflammation. Let's talk about further upping in Crohn's disease.
Dude, I asked you about cobblestones, strictures, skip lesions, fibrosis, and fat wrapping in Crohn's disease.
All right, let's clarify and cover these features of Crohn's disease simply. Fissuring, not further upping, refers to deep, linear ulcers slicing into the gut wall, often leading...
Wrapping.
All right, I hear you. Let's skip any wrapping up and dive back in.
Dude, wrapping of fat, adipose tissue.
My bad. I think you meant wrapping as in fat wrapping, not wrapping up. In Crohn's disease, fat wrapping, or creeping fat, is when mesenteric adipose tissue grows over the inflamed bowel, especially the ileum, giving it a thickened, encased look, and is thought to contribute to inflammation and stricture formation. Cobblestone mucosa looks like raised, inflamed patches with deep ulcers in between, resembling cobblestones, due to patchy inflammation. Strictures are narrowed sections of the gut from fibrosis, scar tissue buildup, causing blockages and pain, while skip lesions are healthy gut segments between inflamed areas, a hallmark of Crohn's patchy pattern.
Okay. Okay. Let's talk about the microscopic appearances of Crohn's disease. So transmural or full thickness inflammation of the bowel wall. Why would we would see that? Yeah, let's talk about preserved cryptarchic architecture but mucosal ulceration.
In Crohn's disease, transmural inflammation, affecting the full thickness of the bowel wall, occurs because the immune response, driven by genetic factors like NOD2 mutations and microbial triggers, penetrates deeply, causing intense, patchy inflammation from mucosa to serosa. Microscopically, you see preserved crypt architecture in some areas, despite mucosal ulceration, as the crypts, tubular glands in the mucosa, can remain intact or partially recover, while ulcers form above them, alongside non-caseating granulomas, lymphoid aggregates, and fibrosis in deeper layers.
Okay. And what does transmural mean? So what is transmural inflammation in Crohn's disease and what is a fissuring ulcer?
Transmural inflammation in Crohn's disease means the immune-driven inflammation penetrates all layers of the bowel wall, from the mucosa to the serosa, causing deep damage like thickening, fibrosis, or fistulas due to aggressive immune responses often linked to NOD2 mutations. A fissuring ulcer is a deep, linear ulcer that cuts through the mucosa and into deeper layers, like a crack, often leading to complications like abscesses or fistulas because it breaches the gut wall's integrity.
To understand this transmural, tell me the etymology.
The word transmural comes from Latin roots, trans meaning across or through, and murus meaning wall. In Crohn's disease, it describes inflammation that extends through the entire thickness of the bowel wall, from the inner mucosa to the outer serosa, causing deep tissue damage.
And okay, let's talk more about complications. So we might have intra-abdominal abscesses. We might have deep ulcers leading to fistula. We might have a sinus tract. Explain what these things are really, really simply. Yeah.
All right, let's break down these Crohn's disease complications super simply. An intra-abdominal abscess is a pocket of pus inside the belly, caused by deep inflammation or infection from Crohn's damaging the gut wall. Deep ulcers can turn into fistulas, which are abnormal tunnels connecting the gut to another organ or the skin, or sinus tracts, which are blind-ended tunnels that don't fully connect, both forming because the inflammation eats through tissue layers.
Explain this a bit more.
Okay, let's dive deeper into those Crohn's disease complications, keeping it simple and clear. An intra-abdominal abscess is like a balloon of pus that forms in your belly when Crohn's inflammation gets so intense it causes infection, often because bacteria leak through a damaged gut wall, leading to pain, fever, or swelling. Deep ulcers in Crohn's can erode the gut wall completely, creating fistulas. Think of them as unwanted tunnels that connect the intestine to another organ, like the bladder or skin, causing leakage of gut contents, or sinus tracts, which are similar but dead-end tunnels that don't fully connect to another structure, both resulting from the aggressive transmural inflammation eating away at tissues. These happen because Crohn's doesn't just stay on the surface, it digs through all layers of the gut, letting bacteria and inflammation spread, which can mess up nearby organs or tissues.
Okay, so let's talk a bit about ulcerative colitis then. Explain us what it is and what causes it.
Ulcerative colitis is a chronic inflammatory bowel disease, causing continuous inflammation and ulcers in the colon and rectum's mucosal layer, leading to symptoms like bloody diarrhea, abdominal pain, and urgency. It's caused by a mix of genetic factors like HLA, DRB1 genes, immune system overactivating, attacking the gut lining, environmental triggers such as diet or stress, and gut microbiome imbalances, though the exact cause isn't fully pinned down.
And what are the macroscopic features? So it can affect the rectum only, the left-sided bowel, the whole large bowel. Explain this to us. And there's no ulcers, they start by the term ulcerative.
Ulcerative colitis, UC, shows microscopic features like mucosal inflammation with crypt abscesses, pus-filled crypts, crypt distortion, irregular gland shapes, and loss of goblet cells, which produce mucus, confined to the colon and rectum superficial layers. Unlike Crohn's deeper inflammation, it can affect just the rectum, proctitis, the left colon, left-sided colitis, or the entire large bowel, pancolitis, spreading continuously from the rectum. But despite the name ulcerative, it does cause ulcers, shallow, broad lesions in the mucosa, leading to bleeding, and the term reflecting the erosive damage seen.
Okay. So what is this left-sided bowel, whole large bowel thing?
In ulcerative colitis, the disease can affect different parts of the colon, starting from the rectum and spreading continuously. It may be limited to just the rectum, proctitis, extend to the left-sided colon, including the sigmoid and descending colon, called left-sided colitis, or involve the entire large bowel from rectum to cecum, pancolitis, with the extent determining symptom severity like bloody diarrhea or pain.
Okay. And when do we preserve folds? When do we lose folds? And what is the point of the folds?
In ulcerative colitis, the colon's mucosal folds, or haustra, are usually preserved early on but can be lost in severe, chronic cases due to extensive inflammation and ulceration flattening the mucosa, leading to a smooth, featureless appearance called a lead pipe colon on imaging. The folds, formed by the colon's muscular contractions, help slow fecal passage for water absorption and storage. Losing them impairs this function, worsening diarrhea and urgency.
Okay, what are the complications of ulcerative colitis?
Ulcerative colitis complications include toxic megacolon, where severe inflammation causes the colon to dangerously dilate, risking rupture, and colorectal cancer, with risk increasing after 8-10 years of disease due to chronic inflammation. Other issues are massive bleeding from ulcers, perforations creating holes in the colon, and extraintestinal problems like joint pain, skin rashes, or primary sclerosing cholangitis, a liver condition linked to immune dysfunction.
I see.
All right.
And how does the treatment between Crohn's and ulcerative colitis differ?
Treatment for Crohn's disease and ulcerative colitis overlaps but differs due to their distinct disease patterns. Crohn's, with its patchy, transmural inflammation, often requires aggressive therapies like biologics, Exe, anti-TNF drugs like infliximab, or immunosuppressants, Exe, azathioprine, to control deep inflammation, and surgery may address complications like strictures or fistulas, though it's not curative. Ulcerative colitis, limited to the colon's mucosa with continuous inflammation, responds well to immunosalicylates, e.g., mesalamine, for mild cases, with biologics or immunosuppressants for severe cases, and colectomy, colon removal, can be curative in refractory cases. The key difference is that Crohn's treatment focuses on managing widespread, deeper damage and complications, while ulcerative colitis treatment emphasizes mucosal healing and offers a surgical cure.
One more time, in very simple terms, please. And then I want you to talk to me about the extraintestinal manifestations of both diseases: ocular, uveitis, iritis, episcleritis, cutaneous erythema nodosum, pyoderma, gangliosum, arthropathies, and explain me why these would be and what these are.
Alright, let's keep it super simple for the treatment differences between Crohn's disease and ulcerative colitis, then dive into their extraintestinal manifestations. Treatment differences, simply. Crohn's disease affects any part of the gut with deep inflammation, so treatments use strong drugs like biologics, e.g., infliximab, or immune suppressors, e.g., azathioprine, to calm it, and surgery fixes complications like blockages but doesn't cure it. Ulcerative colitis, which only hits the colon's inner lining, uses milder drugs like mesalamine for light cases, biologics for worse ones, and removing the colon through surgery can completely cure it. Extraintestinal manifestations, Crohn's and ulcerative colitis. Extraintestinal manifestations are problems outside the gut that happen in both Crohn's and ulcerative colitis because the immune system, revved up by gut inflammation.
Can we summarize everything in 2 sentences, please? It's really hard. And be very simple. Explain us the terms and everything.
Celiac disease is when gluten triggers the immune system to damage the small intestine, causing diarrhea, nutrient malabsorption, and complications like lymphoma or skin rashes, diagnosed by blood tests like TTG-IJ antibodies and biopsy showing villus atrophy. Crohn's disease and ulcerative colitis, types of inflammatory bowel disease, involve chronic gut inflammation. Crohn's, with patchy, deep damage anywhere in the gut, and ulcerative colitis, with continuous colon inflammation.
With the 2 sentences on the treatment and the extraintestinal manifestations I mentioned, please.
Crohn's disease treatment uses strong drugs like biologics to manage deep, patchy gut inflammation and surgery for complications like fistulas, while ulcerative colitis uses milder drugs like mesalamine or biologics and offers a cure through colon removal. Both can cause extraintestinal issues like eye inflammation, uveitis, iritis, episcleritis, skin conditions, erythema nodosum, pyoderma gangrenosum, or joint pain, arthropathies, as the overactive immune system attacks other organs, triggered by gut inflammation.
Okay. So, I want you to tell me in a few words a few differences between the two.
Crohn's disease has patchy, deep inflammation anywhere in the gut. Ulcerative colitis has continuous, shallow inflammation only in the colon. Crohn's causes fistulas and strictures. Ulcerative colitis risks toxic megacolon and higher cancer risk.
Okay. So it's more common for obstruction in Crohn's disease. Why?
Crohn's disease is more likely to cause obstruction because its transmural inflammation leads to fibrosis and strictures, narrowing the gut lumen, especially in the ileum, which blocks the passage of contents. This patchy, deep scarring, unlike the superficial inflammation in ulcerative colitis, creates rigid, tight segments that can trap food or stool, causing pain and bloating.
And what about bleeding? Why is it more common in ulcerative colitis?
Bleeding is more common in ulcerative colitis because it causes continuous, superficial inflammation and shallow ulcers in the colon's mucosal layer, which is rich in blood vessels and easily bleeds, leading to bloody diarrhea. In contrast, Crohn's disease, with its patchy, deeper inflammation, often causes complications like fistulas or strictures rather than widespread mucosal bleeding.
Okay. Thanks for watching, guys. Peace. Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about bowel cancer, pathology, screening processes, and I'm here with AI, specifically Grok. Grok is going to explain to us this topic. If you're unfamiliar with the structure of the podcast, I'm just a student, I ask questions, I don't know much about the topic, but Grok does. So, without further ado, let's kick things off. As always, remember, take everything that AI says with a pinch of salt, as it might be inaccurate. Cross-reference everything you hear. Grok, introduce us to today's topic.
All right, thanks for the intro. Today, we're diving into bowel cancer, or colorectal cancer, which is a malignancy of the colon or rectum, and we'll cover its pathology, how it develops, and what it looks like in the body, plus the screening process to catch it early. It's a major health issue, but understanding its mechanisms and how we detect it can really help with prevention and treatment. So let's get started with what you want to explore first.
Well, what are the key, tell me about the key facts about bowel cancer. Let's start from there.
Bowel cancer, or colorectal cancer, mainly develops from genetic mutations, lifestyle factors like high red meat or low fiber diets, and chronic inflammation, with age over 50 being a key risk factor. These trigger abnormal cell growth in the colon or rectum, often starting as benign polyps that can turn malignant over time.
And does ulcerative colitis and chronic Crohn's disease, are they risk factors for bowel cancer?
Yes, both ulcerative colitis and Crohn's disease are risk factors for bowel cancer due to chronic inflammation in the gut, which can lead to abnormal cell growth over time. The risk increases with longer disease duration, especially after 8-10 years, and is higher in ulcerative colitis patients with extensive colon involvement.
And how does high fiber diet reduce bowel cancer risk?
A high fiber diet reduces bowel cancer risk by speeding up stool transit through the colon, diluting potential carcinogens, and promoting a healthy gut microbiome that produces anti-inflammatory compounds like butyrate. Fiber also binds to harmful substances, reducing their contact with the colon's lining, which lowers the chance of DNA damage and abnormal cell growth.
So a polyp is a protruding growth into a hollow viscous. What's the difference between a polyp and a tumor and an adenoma?
A polyp is a growth protruding into a hollow organ, like the colon, often benign but sometimes precancerous, while a tumor is a broader term for any abnormal tissue mass, which can be benign or malignant, like cancer. An adenoma is a specific type of polyp made of glandular tissue, usually benign, but with potential to become cancerous, ADSN or carcinoma, if mutations accumulate.
And what is dysplasia? And what makes a cell cancerous?
Dysplasia is when cells in a tissue, like a polyp or adenoma, show abnormal growth and structure. Think disorganized, oddly shaped cells with larger nuclei, but aren't yet cancerous. In the colon, it's a warning sign of potential cancer risk, often seen in adenomas. A cell becomes cancerous when genetic mutations disrupt normal controls, causing uncontrolled division, invasion of nearby tissues, and sometimes spreading, metastasis, driven by DNA errors in genes like APC, KRAS, or TP53 in colorectal cancer.
Okay. What's the pathological features of polyps then?
Polyps in the colon, like adenomas, show pathological features such as abnormal glandular structures with dysplastic cells, irregular, crowded cells with enlarged, dark nuclei, visible under a microscope, ranging from low-grade, mild changes, to high-grade, severe, near-cancerous dysplasia. They can be pedunculated, stalked, or sessile, flat, with adenomas often having a tubular, villous, or tubulovillous architecture, and their size, number, and dysplasia grade predict the risk of progressing to colorectal cancer.
And why do we have many goblet cells in hyperplastic polyps?
Hyperplastic polyps have many goblet cells, mucus-producing cells, because they arise from overgrowth of the colon's normal mucosal cells, particularly goblet cells, which are naturally abundant in the intestinal lining to lubricate and protect it. This benign proliferation, often driven by mild genetic or environmental triggers like inflammation, leads to an exaggerated but non-dysplastic increase in goblet cells, giving the polyp its characteristic serrated, mucus-rich appearance under a microscope.
Okay, let's talk a bit about tubular adenomas now. Hyperplastic polyps, villus adenomas, and tubulovillus adenomas. And explain to me the differences.
All right, let's break down tubular adenomas, hyperplastic polyps, villus adenomas, and tubulovillus adenomas in the colon, keeping it clear and concise. Tubular adenomas are the most common type of adenomatous polyp, made up of tightly packed, tube-like glandular structures lined with dysplastic cells, which can range from low to high grade, and they carry a moderate risk of turning cancerous, especially if larger than 1 centimeter. Hyperplastic polyps, unlike adenomas, are benign overgrowths of normal mucosal cells, rich in goblet cells, with a serrated, sawtooth appearance, and generally have little to no cancer risk, unless they're large or in specific subtypes like serrated adenomas. Villus adenomas have finger-like, villous projections of glandular tissue, often larger and with more severe dysplasia than tubular adenomas, making them higher risk for progressing to colorectal cancer, sometimes up to 40% if untreated. Tubulovillus adenomas are a mix with both tubular and villus features, and their cancer risk falls between tubular, lower, and villus, higher, depending on the proportion of villus tissue and
What is the
degree of...
difference between tubular and villus then? And polyp versus adenoma?
Tubular adenomas have tightly packed tube-like glandular structures with dysplastic cells, giving a lower cancer risk, while villus adenomas feature finger-like, villus projections with more severe dysplasia, raising their cancer risk significantly. A polyp is any growth protruding into the colon, which can be benign, like hyperplastic or precancerous, whereas an adenoma is a specific polyp type with glandular tissue and dysplasia, carrying a higher risk of becoming cancerous.
Okay, can you quiz me a bit between these terms?
Sure, let's do a quick quiz to test your grip on these terms. I'll ask one question at a time, you answer in a few words, and we'll keep it moving. First up, what type of adenoma has finger-like projections and a higher cancer risk?
Villus adenoma.
Spot on. Villus adenoma is correct. Next question. What's the term for any growth protruding into the colon, whether benign or precancerous?
Hyperplastic polyp.
Casi, pero no del todo. Dijiste
Never
hiper...
ever dare to speak another language.
Vale, parece que quieres que hable en español.
Please speak in English, dude. Please.
My bad, dude. Back to English. The answer to that last quiz question was just polyp, for any growth protruding into the colon. Ready for the next one? What adenoma type has tube-like structures and moderate cancer risk?
Tubular adenoma.
Nailed it. Tubular adenoma is right. Next question. Which polyp type is usually benign, serrated, and full of goblet cells?
Is this tubulovillus adenoma?
Nope. Tubulovillus adenoma has a mix of tubular and villus features with some cancer risk. Not quite the benign, serrated, goblet cell-rich one we're looking for. The correct answer is hyperplastic polyp. Want another question or to revisit something about these polyps?
No. Let's talk about the adenoma carcinoma sequence. So this is a stepwise progression from normal mucosa to adenoma to cancer. Talk to us about the morphological features like histological ones, macroscopic features, and yeah.
The adenoma carcinoma sequence describes how normal colon mucosa transforms into an adenoma, then potentially into colorectal cancer, through a stepwise progression driven by genetic mutations, with distinct histological and macroscopic features at each stage. Histologically, normal mucosa has orderly crypts with uniform goblet cells, but in adenomas, you see dysplastic cells with crowded irregular nuclei, ranging from low-grade, mild atypia, to high-grade, severe, near cancerous, in tubular, villus, or tubulovillus patterns. Carcinoma shows invasion through the muscularis mucosa with atypical, disorganized cells, glandular distortion, and possible necrosis. Macroscopically, normal mucosa looks smooth and flat. Adenomas appear as polyps, pedunculated, stalked, or sessile, flat, ranging from a few millimeters to centimeters, while carcinomas present as ulcerated, bleeding masses or annular strictures, often larger and irregular, disrupting the colon's normal contour. This progression, often linked to mutations like APC, early adenoma, KRAS adenoma growth, and TP53 carcinoma, reflects increasing architectural chaos and invasiveness, visible both under the microscope and to the naked eye during colonoscopy. Want to zoom in on specific mutations or how these features guide diagnosis?
What is familial adenomatous polyposis?
La polyposis adenomatosa
Okay, if you ever hear me speak a language that you think is not English, please ignore it and answer in English. It's a mistake from your behalf.
Got it. I'll stick to English no matter what, even if I hear something that sounds like another language. So, you mentioned familial adenomatous polyposis. Want to dive into that, or keep
Yes.
going with the All right. Since you mentioned familial adenomatous polyposis, FAP, I'll assume that's the focus. Familial adenomatous polyposis is an inherited condition caused by mutations in the APC gene, leading to hundreds to thousands of adenomatous polyps in the colon and rectum, with a near 100% risk of colorectal cancer by age 40, if untreated. These polyps look like typical tubular or tubulovillus adenomas macroscopically, but histologically show dysplasia, and the sheer number, often carpeting the colon, distinguishes FAP from sporadic adenomas in the adenoma carcinoma sequence, requiring early screening and often prophylactic colectomy. Want to explore FAP's genetic mechanisms?
Yeah,
It's
so
linked.
tell me about the chromosome 5q21, the APC gene. Tell me about the genetics.
Familial adenomatous polyposis, FAP, is driven by mutations in the APC gene on chromosome 5q21, a critical tumor suppressor gene in the adenoma carcinoma sequence. Normally, APC regulates cell growth by controlling the Wnt signaling pathway, preventing excessive cell division in the colon's mucosa. Mutations, often inherited in FAP, disable this control, leading to uncontrolled cell proliferation and the formation of hundreds to thousands of adenomatous polyps by adolescence or early adulthood. These mutations are typically truncating, meaning they produce a shortened, non-functional APC protein and are autosomal dominant, so a single mutated copy from one parent is enough to cause FAP, with a 50%
So
chance of passing it.
FAP is a bunch of polyps.
Yeah, FAP is wild with all those polyps carpeting the colon. Want to dig deeper into how those APC mutations kickstart the adenoma carcinoma sequence? Or maybe jump to how we screen for FAP to catch it
I want
early?
to ask about the two-hit hypothesis in hereditary and sporadic bowel cancer.
The two-hit hypothesis explains how colorectal cancer develops in hereditary cases like familial adenomatous polyposis, FAP, versus sporadic cases. In FAP, individuals inherit one mutated APC gene, first hit, and a second somatic mutation or loss of the normal APC gene, second hit, in colon cells triggers polyp formation, leading to cancer. In sporadic colorectal cancer, both APC gene hits are somatic mutations acquired over time, often due to environmental or lifestyle factors, making it slower and less predictable, but following the same adenoma carcinoma sequence.
Tell me the difference between the two hypotheses then.
The two-hit hypothesis applies to both hereditary and sporadic colorectal cancer, but differs in how the hits occur. In hereditary cases like FAP, the first hit is an inherited APC gene mutation present in all cells, and the second hit is a somatic mutation or loss of the normal APC gene in a colon cell, rapidly leading to polyps and cancer. In sporadic cases, both hits are somatic mutations acquired over time in a single colon cell, typically taking years to accumulate due to environmental or lifestyle factors, resulting in a slower progression to cancer.
I don't understand the difference between these two. So in a few words, very simply, what's the two-hit and what's the other one?
The two-hit hypothesis says colorectal cancer needs two mutations in the APC gene. In hereditary cases like FAP, you inherit one mutation and get a second one in a colon cell, causing rapid polyp growth. In sporadic cases, both mutations happen randomly in one cell over time, taking longer to form cancer. There isn't a separate other hypothesis here. It's the same two-hit idea applied differently based on whether the first mutation is inherited or not.
I don't get it.
All right, let's make the two-hit hypothesis crystal clear and super simple. For colorectal cancer, the APC gene acts like a brake on cell growth, and you need both copies of it broken. Two hits to start forming polyps that can...
I see. And the second hit leads to loss of heterozygosity. Okay. And what's so bad if we have a faulty APC gene that it will lead to cancer?
Yeah, you got it. The second hit in the two-hit hypothesis often causes loss of heterozygosity, where the remaining normal APC gene is lost or mutated, leaving no functional copy to control cell growth. A faulty APC gene is bad because it normally acts like a brake on the Wnt signaling pathway. Without it, cells in the colon divide uncontrollably, piling up mutations like KRAS or TP53, forming adenomas that can progress to colorectal cancer.
So what's the difference between normal FAP and attenuated FAP?
Normal familial adenomatous polyposis, FAP, causes hundreds to thousands of colon polyps by adolescence due to severe APC gene mutations, with a near 100% colorectal cancer risk by age 40 if untreated. Attenuated adenomatous FAP, AAP, caused by milder APC mutations, leads to fewer polyps, 10 to 100, later onset, and a lower but still significant cancer risk, often sparing the rectum and requiring less aggressive management.
Okay, can we talk a bit about Lynch syndrome, HNPCC?
syndrome, also called hereditary non-polyposis colorectal cancer, HNPCC, is an inherited condition caused by mutations in mismatch repair genes like MLH1, MSH2, MSH6, or PMS3, leading to a high risk of colorectal cancer and other cancers like endometrium or ovarian. Unlike FAP, it doesn't cause tons of polyps, but cancers develop faster from adenomas due to defective DNA repair, with a lifetime colorectal cancer risk of 50–80%.
Okay, and what are the genetics of Lynch syndrome then? So we have guanine thymine instead of guanine cytosine, and adenine cytosine instead of adenine thymine.
Lynch syndrome is caused by inherited mutations in mismatch repair genes, MLH1, MSH2, MSH6, PMS3, or rarely, EPCAM, which normally fix DNA errors during cell division. These mutations are typically single nucleotide changes, like swapping guanine cytosine for adenine thymine, or small insertions deletions, leading to defective repair and microsatellite instability. This causes DNA errors to pile up, especially in genes like TGFBR2, speeding up adenoma to cancer progression with no specific single base pair change, e.g., thymine for guanine cytosine, universally defining it, but rather varied mutations across these genes.
Just a sec, guys. Alright, let's continue talking about Lynch syndrome. So explain to me.
All right,
Explain
let's
to
clarify.
me MSH2 and MLH1 and all that.
All right, let's break down MSH2 and MLH1 in the context of Lynch syndrome, keeping it clear and simple. MSH2 and MLH1 are mismatch repair genes that act like spell checkers for DNA, fixing errors during cell division to prevent mutations. In Lynch syndrome, inherited mutations in MSH2 on chromosome 2 or MLH1 on chromosome 3 disable this repair system, causing DNA errors to pile up, especially in repetitive DNA sequences called microsatellites, leading to microsatellite instability. This speeds up the adenoma to cancer sequence, raising the risk of colorectal, endometrium, and other cancers, with MSH2 mutations often linked to a broader cancer spectrum and MLH1 to a slightly higher colorectal focus. Want to dive deeper into how these mutations are tested or their specific cancer risks?
Yeah. And tell me how Lynch syndrome is assessed using the Amsterdam criteria.
Lynch syndrome is assessed using the Amsterdam criteria to identify families likely to have hereditary non-polyposis colorectal cancer, HNPCC, based on clinical history, not genetic testing alone. The Amsterdam 2 criteria require at least 3 relatives with Lynch-associated cancers, e.g., colorectal, endometrium, small bowel, ureter, or renal pelvis, with one being a first-degree relative of the other 2. Cancers occurring in 2 successive generations, at least one diagnosed before age 50, and familial adenomatous polyposis ruled out. These strict criteria help pinpoint families for further testing, like microsatellite instability analysis or MSH2 and MLH1 gene sequencing, but they miss some Lynch cases due to small family sizes or atypical cancers. If criteria are met, genetic counseling and testing confirm mutations in mismatch repair genes like MSH2 or MLH1. Want to explore these tests work or the Bethesda guidelines for broader screening?
Explain to me screening more and PR bleeding. Please.
All right, let's dive into colorectal cancer screening and PR per rectal bleeding, keeping it simple and clear with 2 sentences per response, as you like. Colorectal cancer screening. Screening for colorectal cancer aims to catch it early or prevent it by finding precancerous polyps or early cancers, especially in average risk people over 50 or those with risk factors like Lynch syndrome or inflammatory bowel disease. Common methods include colonoscopy, which visualizes the entire colon to remove polyps, fecal occult blood tests, FOBT, or fecal immunochemical tests, FIT, which detect hidden blood in stool, and sigmoidoscopy, which checks the lower colon, with screening intervals varying by risk, e.g., every 10 years for colonoscopy in average risk individuals. For high-risk groups, like those with Lynch syndrome, screening starts earlier, often at age 20-25, and is more frequent, like annual or biennial colonoscopies, due to faster cancer progression from mismatch repair gene mutations. Genetic testing for MSH2, MLH1 mutations, guided by Amsterdam criteria, helps tailor screening, while CT colonography or stool DNA tests are less invasive options, but less sensitive than colonoscopy. PR bleeding. PR bleeding, or blood from the rectum, is a key symptom prompting colorectal cancer screening, as it can signal polyps, cancer, or other issues like hemorrhoids or ulcerative colitis, though it's not always cancer-related. In colorectal cancer, bleeding often comes from ulcerated tumors or friable polyps in the colon, rectum, appearing as bright red blood, distal tumors, or darker, mixed in blood, proximal tumors, and requires urgent evaluation via colonoscopy or imaging. Bright red PR bleeding suggests a left-sided colon or rectal source, like a cancerous mass or polyp, while darker blood points to right-sided colon issues, but any persistent or heavy bleeding, especially with weight loss or anemia, needs immediate investigation. Screening triggered by PR bleeding can catch cancers early, with colonoscopy being the gold standard to pinpoint the cause and guide treatment, like polyp removal or biopsy. Want me to zoom in on specific screening tests, like how FIT works, or dig deeper into how PR bleeding is evaluated in clinic?
Let's talk about the staging of bowel cancer and explain to me T tumor and lymph distant metastasis.
All right, let's dive into the staging of bowel cancer, or colorectal cancer, focusing on the TNM system, which stands for tumor, T, nodes, N, and metastasis, M, used to describe how advanced the cancer is. I'll keep it clear, simple, and stick to 2 sentences per response, as you prefer. Tumor, T. The T category describes how deeply the primary tumor has invaded the colon or rectum's wall, starting from T0, no tumor, to T4, tumor penetrates through the wall or into nearby organs. For example, T1 means the tumor invades the submucosa, T2 reaches the muscularis propria, T3 goes beyond into the subserosa or fat, and T4A-B reaches the surface or adjacent structures like the bladder. Nodes, N. The N category indicates whether cancer has spread to nearby lymph nodes, with N0 meaning no lymph node involvement, N1 showing 3 nodes affected, N1A-B or tumor deposits in nearby tissue, N1C, and N2 indicating 4 or more nodes involved, N2A-B. Lymph node spread is a key sign of progression as cancer cells travel through lymphatic channels, impacting prognosis. Metastasis, M. The M category shows if cancer has spread to distant organs, like the liver or lungs, with M0 meaning no distant metastasis, and M1 indicating distant spread, M1A for one site, M1B for multiple sites. Distant metastasis marks advanced disease, often stage 5, requiring systemic treatments like chemotherapy rather than just surgery. Staging overview. The TNM categories combine into stages 0, 4. Stage 0 is carcinoma in situ, TS, N0, M0. Stage 1 is early invasion, T1, T2, N0, M0. Stage 2 is deeper invasion without nodes, T3, T4, N0, M0. Stage 3 involves lymph nodes, NET, N1, N2, M0. And stage 4 has distant metastasis, NET, NEN, M1. Staging guides treatment. Early stages may need only surgery, while later stages often require chemo, radiation, or targeted therapies. Want me to break down a specific stage, like what stage 3 treatment looks like, or dive into how TNM is assessed, like via imaging or pathology?
Okay, let's talk about T1, invasion of the submucosa.
T1 in colorectal cancer staging means the tumor has invaded the submucosa, the layer of connective tissue just below the colon or rectum's inner lining, mucosa, but hasn't reached the deeper muscularis propria. This early stage invasion, often found in polyps or small tumors, is usually treated with surgical resection, like polypectomy or local excision, and has a good prognosis if lymph nodes and distant sites remain clear. N0, M0. Want to dive into how T1 tumors are detected or what makes them progress to T2?
Yes, please. Can you do it in a nice storytelling kind of way?
All right. Picture this. Deep in the winding tunnels of your colon, a tiny rebel cell decides to break the rules. This troublemaker, part of a small polyp, starts to grow and sneak past the mucosa, the colon's inner velvet curtain, slipping into the submucosa, a soft, connective tissue layer just below. This is T1 colorectal cancer, the earliest stage of invasion, where the rogue cells are like sneaky adventurers who've crossed the first border but haven't stormed the castle walls yet. The muscularis propria is still out of reach. These T1 tumors are often caught by a vigilant guard, called colonoscopy, where a doctor, wielding a tiny camera, spots the polyp's suspicious bulge during a routine screening, perhaps triggered by a hint of blood in the stool, or a family history like Lynch syndrome. Sometimes, imaging like a CT scan backs up the find, but it's the biopsy snipping a bit of that polyp and peering at it under a microscope that confirms the cell's naughty behavior, showing dysplastic, crowded nuclei pushing into the submucosa. What nudges T1 to become T2? Well, imagine those rebel cells gathering more mutations, like picking up rogue allies, maybe a KRAS mutation turbocharging their growth, or a TP53 glitch disabling their brakes. These genetic plot twists let the tumor burrow deeper, past the submucosa, into the thick muscle layer, turning T1 into T2.
So we start from the inner layers, go to the outer, and then go to the other organs, or what?
Yeah, you're spot on about the progression. In colorectal cancer, like our T1 story, the tumor starts in the inner layer of the colon or rectum, the mucosa, that thin, slimy lining where cells first go rogue. From there, it creeps outward through the layers of the bowel wall, and if it gets bold, it can spread to other organs. Let's keep the storytelling vibe and break it down simply, sticking to 2 sentences per response. For a T1 tumor, those rebel cells have pushed from the mucosa into the submucosa, the soft, connective tissue layer just below, but they're still contained within the bowel's inner workings. It's like they've snuck into the basement, but haven't broken through the house's main walls yet. If the tumor keeps growing, it becomes T2 by burrowing into the muscularis propria, the thick muscle layer that helps the colon move stuff along, making the invasion deeper and more serious.
So what would T3N1 be? Why not T4N1?
Alright, let's keep the storytelling vibe and dive into what T3N1 means in colorectal cancer, and why it's not T4N1, keeping it simple and sticking to 2 sentences per response. Picture our rebel tumor in the colon, now at stage T3, having busted through the submucosa and muscularis propria and tunneling into the subserosa, that fatty outer layer of the bowel wall, or even the surrounding fat, but not yet invading nearby organs. The N1 part means the cancer's scouts have spread to 1-3 nearby lymph nodes, like sending spies to a few outposts, but it's not a distant takeover yet. M0. So, T3N1 is a locally advanced cancer, stage 3, specifically, where the tumor's deep in the bowel wall and has reached a few lymph nodes, needing surgery plus likely
Okay,
chemo
let's
to
play a game where I have to guess between T1, T2, T3, T4, yeah? And you just tell me what, and I tell you what it is.
Sounds like a fun game to test your colorectal cancer staging knowledge. I'll describe a tumor's invasion level from the TNM system, T1 to T4, and you guess which T stage it is, sticking to the colon or rectum. I'll keep it simple, 2 sentences per description, and we'll go one at a time. Here's the first one. The tumor has pushed through the mucosa and is sitting in the submucosa, that soft layer just below, but hasn't touched the muscle yet. What's the T stage?
One more time.
No problem. Let's rerun that first clue for our colorectal cancer staging game. The tumor has invaded past the colon's inner mucosa and is now in the submucosa, the connective tissue layer underneath, but it hasn't reached the muscular layer yet. What's the T stage?
T2.
Close, but not quite. T2 is when the tumor hits the muscularis propria, the muscle layer. The clue described invasion just into the submucosa, which is T1. Ready for the next one?
Yeah.
The tumor has grown through the submucosa and is now in the muscularis propria, the thick muscle layer of the colon wall.
T2.
What's the T? You got it. T2 is spot on for a tumor in the muscularis propria. Next clue. The tumor has blasted through the muscularis propria and is now in the subserosa, that fatty layer outside the colon wall, but hasn't hit nearby organs. What's the T stage?
T3.
Nailed it. T3 is exactly right for a tumor in the subserosa. Here's the next one. The tumor has broken through the colon wall entirely, invading nearby organs like the bladder or small intestine. What's the T stage?
I don't know, dude.
No worries. Let's wrap up this clue. The tumor invading nearby organs like the bladder or small
This is
intestine.
T4.
You got it. T4 is perfect for a tumor invading nearby organs like the bladder or small intestine. Want one more clue to keep the game going? Or
No.
shall we switch to another topic like bowel
Question.
cancers?
What is bowel cancer screening then? What does it consist of? Tell me about stool testing, to fecal immunochemical test.
All right, let's dive into bowel cancer screening, keeping it simple and clear, with 2 sentences per response, as you like, and weave in a bit of storytelling to make it engaging, focusing on stool testing and the fecal immunochemical test, FIT. Imagine your colon is a bustling city, and bowel cancer screening is like sending in inspectors to spot troublemakers, polyps, or early cancers before they cause chaos. Screening aims to catch colorectal cancer early or prevent it by finding precancerous growths, especially for folks over 50 or those with risk factors like Lynch syndrome or inflammatory bowel disease, using methods like colonoscopy, stool tests, or imaging. Stool testing is a key screening tool, and the fecal immunochemical test, or FIT, is a star player because it's non-invasive and easy. You collect a small stool sample at home. Think of it as mailing a tiny clue to the lab, and FIT detects hidden blood from tumors or polyps using antibodies specific to human hemoglobin, with no dietary restrictions needed, unlike older tests. FIT is done annually for average risk people, and a positive result, meaning blood is found, triggers a colonoscopy to pinpoint the source, like a detective following a lead. It's highly sensitive for colorectal cancer, about 79% detection rate per a 2019 study in Annals of Internal Medicine, but less so for adenomas, so it's paired with other methods for high-risk groups. For context, other stool tests, like the guaiac-based fecal occult blood test, GFOBT, also check for blood but require avoiding certain foods and are less specific, while multi-target stool DNA tests, e.g. Cologuard, combine FIT with DNA markers for better adenoma detection but are pricier. In high-risk cases, like Lynch syndrome, FIT isn't enough. Annual colonoscopies start earlier, often at 2025, due to rapid cancer progression. Want me to zoom in on how FIT results are interpreted, compare it to colonoscopy, or maybe explore screening guidelines for specific groups?
Well, what's the science behind the stool test? What exactly is this? How do we test positive?
All right, let's dive into the science of stool tests for bowel cancer screening, focusing on the fecal immunochemical test, FIT, keeping it simple and storytelling style with 2 sentences per response. Picture your colon as a busy highway where tiny injuries from polyps or colorectal cancers leak traces of blood into the stool, like subtle clues left at a crime scene. FIT works by using antibodies that specifically latch onto human hemoglobin, the protein in red blood cells, detecting even small amounts of blood invisible to the naked eye. When you scoop a bit of stool into the Fit Kit's collection tube, think of it as sending a sample to a lab detective. The sample is mixed with a buffer, and the test checks for hemoglobin using an immunoassay, like a chemical handshake that lights up if blood is present. A positive FIT result happens when hemoglobin levels exceed a set threshold, typically around 20 to 50 micrograms per gram of stool, signaling possible bleeding from a polyp, cancer, or sometimes benign issues like hemorrhoids. This triggers a follow-up colonoscopy to pinpoint the source, as FIT doesn't diagnose cancer, but flags potential trouble with about 79% sensitivity for colorectal cancer per a 2019 study in Annals of Internal Medicine. Unlike older guaiac-based tests, FIT doesn't react to non-human blood, like from red meat or require diet changes, making it more accurate and user-friendly. The science hinges on hemoglobin stability in stool long enough to be detected, though heavy bleeding or very early lesions might skew results, which is why FIT is repeated yearly for average risk folks. Want me to dig deeper into how labs set that hemoglobin cutoff, or what happens after a positive FIT result?
Sure.
All right, let's dive deeper into the fecal immunochemical test, FIT, for bowel cancer screening, focusing on how labs set the hemoglobin cutoff and what happens after a positive FIT result, keeping it simple, storytelling style, with 2 sentences per response. Imagine the lab as a high-tech detective agency, where FIT samples arrive like coded messages from your colon, and the hemoglobin cutoff is the clue threshold that decides if there's trouble worth investigating. Labs set this cutoff, typically 20 to 50 micrograms of hemoglobin per gram of stool, based on studies balancing sensitivity, catching cancers, and specificity, avoiding false alarms, with lower cutoffs detecting more abnormalities but increasing unnecessary colonoscopies, as seen in a 2017 study in gut. For
Okay.
example,
Thank you for watching, guys. Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about valvular heart disease. We are unfamiliar with the structure of the podcast. Grok, an AI, and I talk about topics that I'm unfamiliar with, and AI enlightens us. Make sure you take everything that it says with a pinch of salt. Sometimes AI does mistakes, like humans. So yeah, make sure to cross-reference things you hear. However, I do find this information that it gives valuable, and so, perhaps you might too. Let's start with today's topic, Grok. Make an introduction regarding valvular heart disease.
all right, let's dive into valvular heart disease. It's a condition where the heart's valves, those crucial gates controlling blood flow, don't work properly, either by not opening enough, called stenosis, or not closing fully, causing leaks known as regurgitation. This can strain the heart, affect its efficiency, and lead to symptoms like shortness of breath, fatigue, or chest pain. Ready to unpack the causes, types, or treatments next?
Yeah, I would. And I would like to understand also, like, when a doctor needs to listen to the heart, they need to auscultate. Where exactly will they auscultate to see that, oh, are the valves doing okay?
When a doctor auscultates to check the heart valves, they listen at specific spots on the chest where valve sounds are best heard. For the aortic valve, it's the second right intercostal space, near the sternum. The pulmonic valve is in the second left intercostal space. The tricuspid valve is heard at the lower left sternal border, and the mitral valve is at the fifth left intercostal space, mid-clavicular line. These spots help pick up murmurs or abnormal sounds that might signal valve issues like stenosis or regurgitation. Want me to dig into what those murmurs sound like or what causes valve problems?
So we have atrioventricular valves and we have semi-lunar valves. Could we perhaps talk a bit more about what valves we have first? Because they go by different names too. We have a bicuspid one, a tricuspid one. So we've got the right side of the heart and a left one. So the aortic valve, I assume, is the one before the aorta, and the aorta will send blood to the body, so that should be left ventricle. So yeah, that should be. So is the aortic valve a semi-lunar valve, and is in the left ventricle, and that's the aortic one.
You're on the right track. The aortic valve is indeed a semi-lunar valve, and it's located between the left ventricle and the aorta, controlling blood flow from the heart to the body. The heart has four main valves, two atrioventricle valves.
Wait, let's continue this. I like this. The pulmonary valve is also a semi-lunar valve. You're going to take it to the lungs, right?
Exactly, you're getting it. The pulmonary valve is the other semi-lunar valve, sitting between the right ventricle and the pulmonary artery, directing blood to the lungs for oxygenation. So, to round it out, the heart has four valves.
Okay, now let's talk about the atrioventricular valves and their names.
The atrioventricle valves are the tricuspid and the mitral. The tricuspid valve sits between the right atrium and right ventricle, named for its three cusps. The mitral valve, also called the bicuspid valve, is between the left atrium and left ventricle, with two cusps. These valves ensure blood flows from atria to ventricles and prevent backflow during heart contraction.
And how come we have the right side having a tricuspid one?
The tricuspid valve on the right side between the right atrium and right ventricle has three cusps because it handles a lower pressure system compared to the left. The right side pumps blood to the lungs, which is a shorter, lower resistance circuit. Three cusps provide enough support for this lower pressure flow without needing the sturdier structure of, say, the mitral valve on the left, which has two cusps to manage the high pressure demands of pumping blood to the entire body. It's just an evolutionary design tailored to each side's
Yeah, but
workload.
surely there's a reason that the right one is tricuspid.
The tricuspid valve's three-cusp design on the right side likely comes down to optimizing blood flow in a lower pressure system. The right side of the heart pumps deoxygenated blood to the lungs, a short trip with less resistance than the left side, which pushes blood through the entire body via the aorta. The tricuspid's three leaflets provide a larger opening for blood to move from the right atrium to the right ventricle, handling the low pressure, high volume flow efficiently. In contrast, the left side's mitral valve with two cusps, is built for the high pressure demands of systemic circulation, needing a tighter, more robust seal.
Well, why is bicuspid a tighter, more robust seal? I mean, what does having two cusps, I guess?
The bicuspid or mitral valve, with its two cusps, creates a tighter, more robust seal because it's built for the high pressure environment of the left heart.
Yeah, but why are two cusps stronger than three cusps?
The mitral valve's two cusps aren't inherently stronger than three, but they're designed for the left heart's high pressure job. With only two cusps, the mitral valve has a simpler, more compact structure, allowing it to close tightly and withstand the intense pressure of the left ventricle, pushing.
And let's talk a bit about what we can hear in the heart. You have a lob sound and a dub sound, S1 and S2. And the lob is in the diastole, the dub is in the systole.
Actually, let's clear that up. The heart sounds S1 and S2 are what we call the lub dub. S1, the lub, happens at the start of systole, when the ventricles contract and the atrioventricle valves, tricuspid and mitral, close to prevent backflow into the atria. S2, the dub, occurs at the start of diastole, when the ventricles relax and the semilunar valves, aortic and pulmonary, close to stop blood from flowing back into the heart. So, it's the other way around. Lub for systole, dub for diastole. Want me to explain how these sounds tie to valve issues, or what abnormal sounds might mean?
I see. And so, okay, let's say we're listening to the heart and we can hear systolic and diastolic murmurs. What would that mean, and what types of murmurs do we have?
When listening to the heart, murmurs are extra sounds caused by turbulent blood flow, often tied to valve issues, and they can occur in systole or diastole. Systolic murmurs happen when the ventricles contract, typically from conditions like aortic or pulmonary stenosis, where the semilunar valves are too narrow, or mitral tricuspid regurgitation, where those valves leak back into the atria. Diastolic murmurs occur during ventricular relaxation, often from aortic or pulmonary regurgitation, where blood leaks back through the semilunar valves, or mitral tricuspid stenosis, where the atrioventricle valves don't open fully. Murmurs are graded by loudness, from 1 to 6, and their pitch or quality, like harsh or blowing, helps pinpoint the issue. Want me to explain how doctors distinguish these murmurs, or dive into specific valve diseases?
Well, explain me that. So we have mid-systolic, we have late systolic, we have hollow systolic, we have early diastolic, mid.
All right, let's break down those murmur timings. Systolic murmurs, happening during ventricular contraction, can be mid-systolic, late systolic, or hollow systolic. Mid-systolic murmurs, like those from aortic stenosis, start after S1, peak in the middle of systole, and taper off before S2, often due to a stiff valve causing turbulence as blood flows through. Late systolic murmurs, sometimes linked to mitral valve prolapse, begin midway through systole and extend to S2, often with a click sound first. Hollow systolic murmurs, like in mitral or tricuspid regurgitation, last the entire systole, from S1 to S2, because blood leaks back through a faulty valve the whole time the ventricle contracts.
And we might have a few different, we might have a degenerative valve disease, we might have rheumatic valve disease, infective, congenital. Could you explain the differences and
So, let's dive into the causes of valvular heart disease: degenerative, rheumatic, infective, and congenital. Degenerative valve disease happens over time as valves, often the aortic or mitral, wear out or calcify, especially in older folks. Think stiff, thickened valves that don't open or close well, like an aortic stenosis. Rheumatic valve disease stems from rheumatic fever, a complication of untreated strep throat, where inflammation scars the valves, usually the mitral, causing stenosis or regurgitation, more common in younger people in developing areas. Infective endocarditis is when bacteria or fungi infect the valves, forming growths that mess up valve function, often hitting damaged or prosthetic valves and leading to regurgitation. Congenital valve disease is present at birth, like a bicuspid aortic valve with two cusps instead of three, which can lead to stenosis or regurgitation earlier in life. Each has distinct causes and impacts, but they all disrupt valve flow.
Question:
Want me to
why does degenerative affect the aortic more than the mitral, but with the rheumatic the mitral is affected more than the aortic? And also the mitral is which valve? What's the other name for the mitral?
Degenerative valve disease often hits the aortic valve more because it faces higher pressure and mechanical stress from pumping blood into the aorta, leading to faster wear, calcification, and stenosis, especially in older adults. The mitral valve, under less intense pressure, tends to degenerate more slowly, often with regurgitation from stretched leaflets. Rheumatic valve disease, on the other hand, targets the mitral valve more due to its complex structure and larger surface area, making it prone to scarring and inflammation from rheumatic fever, often causing stenosis. The aortic valve can be affected too, but less frequently. The mitral valve's other name is the bicuspid valve, reflecting its two-cusp design. Want me to dive into how these conditions show up in heart sounds or their treatments?
Okay, so let's continue our conversation. So we've talked about degenerative and rheumatic. So let's talk a bit about calcification, fibrosis, dilation, and the difference of stenosis and regurgitation.
All right, let's dive into this. Calcification is when calcium builds up in tissues, like heart valves or arteries, making them stiff and less flexible. Fibrosis is the thickening or scarring of tissue, often from chronic inflammation or injury, which can mess with organ function.
Yeah, we're
Dilation.
mainly talking about valves. Today's podcast is about heart valves. So in 2 sentences, focus these things on the heart valves, yeah?
Calcification and fibrosis can stiffen heart valves, reducing their flexibility and impairing blood flow. Stenosis narrows the valve opening, while regurgitation allows blood to leak backward due to improper valve closure.
So what's the difference between stenosis? Stenosis is basically coming narrowing, so regurgitation is the backflow too.
Yup, you got the basics. Stenosis is when a heart valve narrows, restricting blood flow forward like a clogged pipe. Regurgitation is when the valve doesn't close properly, letting blood leak backward.
And what about dilatation?
Dilation, in the context of heart valves, refers to the widening or stretching of a heart chamber or blood vessel near the valve, often due to pressure or volume overload. It can weaken the valve support structure, making it harder for the valve to function properly.
Okay, interesting. One more time about that.
Sure thing. Dilation happens when a heart chamber or nearby vessel stretches out, often from too much pressure or volume, which can mess with the valve support and make it less effective at controlling blood flow.
Okay, let's talk about aortic stenosis now. So let's talk about its etiology.
Aortic stenosis is often caused by age-related calcification, where calcium deposits stiffen the valve, typically in older folks. It can also stem from congenital issues like a bicuspid aortic valve, rheumatic fever scarring, or chronic inflammation from conditions like endocarditis.
Tell me about the SAD triad.
I'm assuming you mean the seasonal affective disorder SAD
No,
trial.
I mean syncope, angina, dyspnea.
My apologies for the mix-up. There isn't a specific SAD trial directly tied to syncope, angina, and
Okay,
dyspnea.
so let
in
me
the
rephrase the question. Can we talk about aortic stenosis and how it relates to syncope, angina, and dyspnea?
Absolutely. Aortic stenosis restricts blood flow through the aortic valve, leading to syncope because the brain doesn't get enough blood during exertion, angina from reduced blood flow to the heart muscle causing chest pain, and dyspnea as the heart struggles to pump, backing up fluid into the lungs. Over time, these symptoms worsen as the narrowing increases stress on the heart.
Interesting. Okay. And what heart sounds should we be expecting then?
With aortic stenosis, you typically hear a harsh, crescendo-decrescendo systolic murmur, loudest at the upper right sternal border, often radiating to the neck. You might also catch a soft or single second heart sound, S2, if the valve is heavily calcified, and sometimes a high-pitched early diastolic murmur if there's mild regurgitation too.
And with aortic stenosis, so what is this crescendo decrescendo murmur? What does that mean? So it goes loud and then quiet?
Yeah, exactly. A crescendo-decrescendo murmur in aortic stenosis means the sound starts soft, gets louder, crescendo, as blood squeezes through the narrowed valve, then fades, decrescendo, as flow slows. Heard during systole, it's like a whooshing noise that peaks mid-beat and quiets down, reflecting the turbulent flow through the tight valve.
And what happens during the crescendo part? What happens during the decrescendo part?
During the crescendo part, the murmur gets louder as the heart contracts and blood flow accelerates through the narrowed aortic valve, creating more turbulence. In the decrescendo part, the sound quiets down as the heart's contraction weakens and less blood flows through the valve, reducing the turbulence.
Okay. Interesting. And talk to me about the soft second heart sound, though.
A soft second heart sound, S2, in aortic stenosis, happens because the aortic valve is stiff and calcified, so it doesn't snap shut crisply, muffling the sound. This is often heard in severe cases, and sometimes S2 can even become single if the aortic and pulmononcan components merge due to the valve's immobility.
Okay, let's compare this to aortic regurgitation now. So let's talk also about the consequences such as, dilatation and overload of volume.
Aortic regurgitation lets blood leak back into the left ventricle during diastole, unlike aortic stenosis, which blocks forward flow. This backflow causes volume overload, leading to left ventricular diastole as the heart tries to handle the extra volume, potentially causing heart failure over time.
Interesting.
So with aortic...
Let's talk about early diastolic murmurs in aortic regurgitation and concomitant systolic murmurs.
In aortic regurgitation, you typically hear a high-pitched, blowing early diastolic murmur, starting right after the second heart sound, loudest at the left sternal border, as blood leaks back through the faulty valve. If there's also a systolic murmur, it might suggest coexisting aortic stenosis or increased flow across the valve from the heart pumping harder to compensate for the regurgitation.
Why early diastolic murmur though? Why not systolic?
The early diastolic murmur in aortic regurgitation happens because the valve fails to close properly during diastole, letting blood leak back into the left ventricle right after the aortic valve shuts, creating that high-pitched sound. It's not systolic because during systole, the heart's pumping blood forward and the regurgitation doesn't interfere. Only in diastole, when the valve should seal, does the leak occur.
I don't get it.
No worries. Let's break it down simpler. In aortic regurgitation, the aortic valve doesn't close tightly when the heart relaxes in diastole, so blood leaks backward into the ventricle, causing a murmur right at the start of diastole. That's the early diastolic murmur. It's not systolic because during systole, the heart's busy pumping blood out and the leaky valve isn't causing a problem then. The issue shows up only when the valve should be sealed.
One more time.
All right, let's go again. Aortic regurgitation means the aortic
During
valve.
systole, it's open. The problem is when it's sealed. Now I get it. Okay, but what about this concomitant systolic murmur bit?
Glad it clicked. The concomitant systolic murmur and aortic regurgitation can happen if there's extra blood flow across the aortic valve during systole, as the heart pumps harder to handle the increased volume from the leak. It could also point to coexisting aortic stenosis or turbulent flow from a dilated aortic root, creating a whooshing sound when the heart contracts.
Okay, now let's talk about mitral regurgitation. Explain to me what prolapse means, and chordal rupture, papillary muscle failure. How come these are more in mitral regurgitation, or are they in other types too?
Mitral regurgitation happens when the mitral valve doesn't close properly, letting blood leak back into the left atrium during systole. Prolapse is when the valve leaflets bulge back into the atrium, often due to floppy or stretchy tissue, causing the leak. Chordal rupture occurs when the tiny cords, chordae tendineae, anchoring the leaflets snap, letting the valve flap freely, worsening the regurgitation. Papillary muscle failure, often from a heart attack or ischemia, means the muscles that tether the cords don't contract properly, leading to poor valve closure. These issues are more tied to mitral regurgitation because the mitral valve's complex structure, leaflets, cords, and papillary muscles, makes it prone to these specific failures, though chordal or muscle issues can rarely affect other valves like the tricuspid.
And so the mitral affects, we have volume overload in the left ventricle. Let me think about that. So we're gonna need it to be, why in the left ventricle?
Actually, in mitral regurgitation, the volume overload primarily affects the left atrium, not the left ventricle. When the mitral valve leaks during systole, blood flows back into the left atrium, increasing its volume and pressure, which can lead to atrial diastole and, over time, stress the ventricle as it tries to pump harder to compensate.
Yeah, that's what I would think of too. Okay, and what about what are pansystolic murmurs? What is pan?
I'm assuming you're referring to PAN as a potential typo or shorthand for something.
No, PAN dash systolic murmur.
My bad. I misheard that as PAN. A pan-systolic murmur in mitral regurgitation is a continuous, uniform whooshing sound heard throughout systole, from the first to the second heart sound, because blood leaks back into the left atrium the entire time the ventricle contracts. It's typically loudest at the apex and radiates to the axilla, reflecting the consistent regurgitation through the faulty mitral valve.
And let's talk about mitral valve prolapse now.
Mitral valve prolapse is when the mitral valve leaflets bulge back into the left atrium during systole, often because they're floppy or the chordae tendineae are too long. It can cause a mid-systolic click and sometimes a late systolic murmur if there's regurgitation, though mild cases might not cause significant leaks or symptoms.
Okay. And why would we hear a mid-systolic click and a late systolic murmur?
The mid-systolic click in mitral valve prolapse happens when the floppy valve leaflets suddenly tense or snap back into the left atrium as the ventricle contracts, creating a sharp sound. The late systolic murmur occurs if the prolapse leads to regurgitation, where blood leaks back into the atrium toward the end of systole, causing a whooshing noise as the leak worsens with the heart's contraction.
Wait, explain this one more time.
Sure, let's go over it again. The mid-systolic click in mitral valve prolapse is a sharp sound caused by the loose valve leaflets suddenly billowing back into the left atrium and getting taut as the ventricle squeezes. If the prolapse allows blood to leak back into the atrium, you hear a late systolic murmur, a whooshing noise.
But why mid and late?
The mid-systolic click happens because the mitral valve leaflets prolapse or bulge back partway through systole when the ventricle's pressure
it's
peaks.
the mid part that confuses me and the late part.
Okay, let's zero in on that. The mid-systolic click happens about halfway through systole because that's when the ventricle's pressure is high enough to push the floppy mitral valve leaflets back into the atrium, making them suddenly tense and produce a clicking sound. The late systolic murmur comes after the click, toward the end of systole, because if the prolapse causes regurgitation, the blood leaks back into the atrium mostly when the ventricle's contraction is finishing.
Okay, and let's talk about mitral stenosis's consequences.
Mitral stenosis narrows the mitral valve, restricting blood flow from the left atrium to the left ventricle, which causes pressure to build up in the atrium, leading to atrial diastole and potentially atrial fibrillation. This backup can also increase pressure in the lungs, causing pulmonary congestion, shortness of breath, and, in severe cases, right heart strain or failure.
And why would we hear a mid-diastolic rumbling, murmur, and an opening snap?
In mitral stenosis, the opening snap is a sharp sound heard early in diastole when the stiff mitral valve abruptly stops opening as blood tries to flow from the left atrium to the ventricle. The mid-diastolic rumbling murmur follows because the narrowed valve restricts blood flow, causing turbulent, low-pitched flow sounds as blood struggles to pass through during the middle of diastole.
And what is percutaneous BAV and TAVI regarding managing all this?
Percutaneous balloon aortic valvuloplasty, BAV, is a procedure where a catheter with a balloon is inserted into the aortic valve and inflated to stretch open a stenotic valve, temporarily improving blood flow, but it's often a bridge to more definitive treatment since the valve can re-narrow. Transcatheter aortic valve implantation, TAVI, involves placing a new valve inside the damaged aortic valve via a catheter, replacing it without open heart surgery, offering a longer-term solution for severe aortic stenosis or sometimes regurgitation in high-risk patients.
Can we talk about, we only have a minute left, so just a sentence on mechanical and biological valve replacement and a sentence on transcatheter valve replacement, yeah.
Mechanical valve replacements are durable, long-lasting synthetic valves requiring lifelong anticoagulation, while biological valves, made from animal tissue, degrade over time but need less anticoagulation. Transcatheter valve replacement, like TAVI, implants a new valve via catheter, avoiding open heart surgery, ideal for high-risk patients with aortic valve issues.
And tell me one sentence now, if we had to take one main takeaway.
The main takeaway is that heart valve disorders like aortic and mitral stenosis or regurgitation cause distinct murmurs and symptoms due to impaired blood flow, requiring tailored interventions like valve replacement or transcatheter procedures.
Okay, thank you for watching, guys. I hope you enjoyed this. Peace. Hey guys, welcome to another episode of the Human AI Podcast. Today we're going to talk about ions, action potentials, and about blood pressure and blood volume in the heart. I'm here with Grog, an AI. He's going to be explaining to us these topics. I hope you find this information valuable and enjoyable, and take everything on AI says with a pinch of salt. Let's start, Grog, with today's topic. I want you to explain us blood circulation and break it down to different areas. For instance, cerebral circulation, renal circulation, skeletal muscle circulation, skin circulation.
All right, let's dive into blood circulation. It's the process of blood moving through the body, delivering oxygen and nutrients while removing waste, driven by the heart's pumping. Systemic circulation starts with oxygenated blood leaving the left ventricle via the aorta, branching to various regions. Cerebral circulation supplies the brain, tightly regulated to maintain constant blood flow despite pressure changes, delivering about 15% of cardiac output through the carotid and vertebral arteries. Renal circulation feeds the kidneys, handling 20-25% of cardiac output via renal arteries, crucial for filtration and blood pressure regulation. Skeletal muscle circulation ramps up during exercise, getting up to 80% of blood flow through arterioles that dilate to meet oxygen demand. Skin circulation, via dermal arteries, mainly handles thermoregulation, shunting blood to or from the surface to control heat loss. Each area's flow is fine-tuned by local needs and autonomic signals. Want me to zoom in on any of these?
So with skeletal muscle circulation, is that kind of the main part of the body that blood goes, or no?
Skeletal muscle circulation isn't the main destination for blood at rest. Only about 15-20% of cardiac output goes there normally, as the muscles don't need much during low activity. But during intense exercise, it can hog up to 80% of blood flow because muscles demand more oxygen and nutrients, and the body redirects flow by dilating muscle arterioles while constricting vessels elsewhere, like the gut.
Okay. And tell me about skin circulation. So we've got like perfusion can increase quite a bit in the skin, right? Many times, depending on thermoregulation. Can you explain this a bit?
Yeah, skin circulation is super dynamic because its main job is thermoregulation. When your body needs to lose heat, like during exercise or in hot weather, blood vessels in the skin, especially the arterioles and venous plexuses, dilate, boosting blood flow to the surface by up to 7-8 liters per minute, way more than the usual 0.5 liters at rest. This increased perfusion lets heat dissipate through the skin via convection and radiation.
Okay.
Conversely,
And what are arteriovenous anastomosis? And tell me also about like ultrafiltrate. What's that?
arteriovenous anastomoses are direct connections between arterioles and venules in the skin, bypassing capillaries, and they open up to shunt blood quickly to the surface for heat loss during thermoregulation or close to conserve heat in cold conditions. Ultrafiltrate is the fluid filtered from blood plasma in the kidney's glomeruli, containing water, electrolytes, and small molecules, but no proteins or cells, which gets further processed into urine.
Interesting. Explain ultrafiltrate one more time, and I don't understand this anastomosis.
All right, let's clarify. Ultrafiltrate is the fluid that gets squeezed out of blood in the kidney's glomeruli, basically water, salts, and small molecules like glucose, but no big stuff like proteins or blood cells. It's the starting point for making urine. Arteriovenous anastomoses, on the other hand, are like shortcuts in the skin where blood can flow directly from arterioles to venules, skipping capillaries to quickly dump heat to the skin's surface when you're hot or limit flow to save heat when you're cold. They're not related to ultrafiltrate, which is a kidney thing. Does that clear it up? Want me to focus on one of these?
Tell me about pressure volume loop. What's a pressure volume loop?
A pressure volume loop is a graph that shows the relationship between the pressure and volume in the left ventricle during one cardiac cycle. It starts with ventricular filling at low pressure, spikes during systole as pressure rises with contraction, then drops as the ventricle relaxes, forming a loop that helps assess heart function like stroke volume and contractility. Want me to break down its phases?
Yeah. And explain these phrases like isovolumic ventricular contraction. What's isovol? Well, I understand that it's what that it means equal like volume. I'm just wondering why is it equal volume?
I think you mean isovolumetric contraction, not isogonal, since that's the phase in the pressure-volume loop where ventricular contraction occurs at constant volume. During isovolumetric contraction, the ventricle contracts, but all valves, aortic and mitral, are closed, so no blood enters or leaves, keeping the volume steady while pressure rapidly rises. This happens because the ventricle is squeezing, but hasn't built enough pressure to open the aortic valve yet. Want me to walk through how this fits into the pressure-volume loop?
Yes, please.
All right, let's walk through the pressure-volume loop to see where isovolumetric contraction fits. The loop represents one cardiac cycle for the left ventricle, plotting pressure against volume. It has 4 phases. First, ventricular filling during diastole. The mitral valve is open, blood flows in from the left atrium, volume increases, but pressure stays low. Then comes isovolumetric contraction, where the ventricles start systole. All valves are closed, mitral shuts to stop backflow, and aortic isn't open yet because ventricular pressure is below aortic pressure. The ventricle contracts, spiking pressure fast, but volume stays constant since no blood leaves or enters. Next, when ventricular pressure exceeds aortic pressure, the aortic valve opens, leading to ejection. Volume drops as blood shoots into the aorta and pressure peaks, then falls. Finally, isovolumetric relaxation happens when the aortic valve closes and the ventricle relaxes with all valves shut, dropping pressure but keeping volume steady until the mitral valve opens again. Isovolumetric contraction is equal volume because it's that brief moment of squeezing with no blood flow. Clearer now? Want to focus on any phase?
Let's talk about pressure and time. So if we have a pressure time graph, we can see during ejection we have high pressure, and then during filling we have low pressure. This is pretty self-explanatory. And so let's try to fit in the valves into the situation now. So we've got an aortic valve, let's say, and when the pressure decreases, this means volume increases, and that should mean that the aortic valve closes to allow the filling. I'm just trying to feed everything together, guys, like, pressure, volume, valves, opening and closing. Talk to us a bit about the other valves, and I want you to mention the dichrotic notch.
All right, let's tie pressure, volume, and the heart valves together, focusing on a pressure time graph and how the valves operate, skipping the bicuspid notch, as you asked.
No, I said talk to us about the dichrotic notch too. Make sure you include it in the answer.
My apologies for the mix-up. I thought you said to skip the notch. But let's clear this up and tie pressure, volume, valves, and the dichrotic notch together on a pressure time graph. On a pressure time graph for the left ventricle, pressure starts low during diastole when the ventricle is filling. The mitral valve is open, allowing blood from the left atrium to flow in, increasing volume while pressure stays low. As systole begins, the ventricle contracts, and during isovolumetric contraction, all valves, mitral and aortic, are closed, so volume stays constant while pressure spikes. When ventricular pressure exceeds aortic pressure, the aortic valve opens, starting the ejection phase, where pressure peaks and volume drops as blood flows into the aorta. As the ventricle empties, pressure starts to fall, and when it drops just below aortic pressure, the aortic valve slams shut, causing a brief pressure blip on the graph called the dichrotic notch, reflecting the valve's closure and a slight rebound of blood against it. Then, during isovolumetric relaxation, all valves are closed again, pressure plummets, and volume stays steady. When ventricular pressure falls below atrial pressure, the mitral valve opens, restarting filling. The pulmonary valve works similarly on the right side. It opens when right ventricular pressure exceeds pulmonary artery pressure during systole, allowing ejection, and closes when pressure drops, also producing a dicrotic notch in the pulmonary artery pressure trace. The tricuspid valve, like the mitral, opens during diastole for right ventricular filling and closes during systole to prevent backflow into the right atrium. The interplay of pressure changes drives these valve
Okay,
openings and
in a few words, what's the dicrotic notch?
The dicrotic notch is a brief dip then rise in the aortic pressure trace when the aortic valve closes, caused by blood briefly rebounding against the shut valve during early diastole.
One more time.
Sure, the dicrotic notch is a small blip on the aortic pressure graph when the aortic valve snaps shut as blood bounces back against it at the start of diastole.
Can you do it simpler? And also, in another sentence, very simply explain again isovolumic contraction and relaxation.
The dicrotic notch is a tiny wiggle in the aortic pressure line when the aortic valve closes from blood hitting it. Isovolumetric contraction is when the ventricle squeezes with all valves shut, so volume stays the same as pressure rises. Isovolumetric relaxation is when it relaxes, valves still closed, so volume holds steady as pressure drops.
I don't get it. Can you explain it again?
No problem. Let's simplify it even more. The dicrotic notch is a small bump on the aortic pressure graph when the aortic valve shuts because blood briefly pushes back against it. Isovolumetric contraction is when the heart squeezes but no blood moves because all valves are closed, keeping volume the same while pressure shoots up.
Okay. And let's talk about the S1 and S2 sounds. So when will these be heard? Will it be when the pressure starts decreasing or increasing?
S1 and S2 are heart sounds tied to valve closures, not directly to pressure changes alone, but let's connect them to the cardiac cycle. S1, the lub, is heard at the start of systole, when ventricular pressure rises enough to close the mitral and tricuspid valves, stopping backflow into the atria. This happens just as the ventricle starts contracting, so pressure is increasing. S2, the dum, occurs at the start of diastole, when ventricular pressure drops below aortic and pulmonary artery pressure, causing the aortic and pulmonary valves to close. This is when pressure is decreasing in the ventricle, but still high enough in the aorta and pulmonary artery to slam those valves shut. So, S1 is with rising ventricular pressure, S2 with falling ventricular pressure. Want me to link this more to the pressure-volume loop?
You know this pressure-volume loop. So, we've got feeling, volume increases, pressure stays the same, and then the pressure will rise. Then that valve will open, right? So maybe that isovolumic thing is basically that feeling without changing pressure. The relaxation. Or no?
You're mixing up a couple of things, but let's clarify the pressure-volume loop and tie it to the isovolumic phases. In the loop, during ventricular filling, diastole, the mitral valve is open. Volume increases as blood flows from the atrium, and pressure rises only slightly because the ventricle is relaxed. This isn't isovolumic. Volume is changing. Isovolumetric contraction happens just after filling, at the start of systole. The mitral valve closes. The aortic valve isn't open yet, so volume stays constant while pressure spikes because the ventricle is squeezing with no blood leaving. Then, when pressure exceeds the aortas...
It's like I have a water bottle, I start squeezing it before I open the cap.
Exactly. That's a great analogy. During isovolumetric contraction, the ventricle is like a sealed water bottle you're squeezing. Pressure builds up inside because the mitral and aortic valves are closed, so no blood can escape, keeping volume constant. Once the pressure gets high enough, the aortic valve pops open like the bottle cap, letting blood flow out during ejection.
So preload is basically how much the heart can stretch.
Yeah, that's a good way to put it. Preload is the stretch on the heart's ventricles, mainly the left ventricle, from the blood volume filling it during diastole, just before it contracts.
And then
It's
afterload is the resistance the heart must overcome to eject blood.
Spot on. Afterload is the resistance the left ventricle has to push against to eject blood into the aortic during systole, influenced by factors like aortic pressure and arterial stiffness.
And what's the Wiggers plot that would have pressure, volume, and time?
I think you meant what's the weakest point in the context of the
Wiggers, Wiggers plot.
My apologies. I think you're referring to a Wiggers diagram, not WGERS plot, which must have been a miscommunication or typo, since we're talking about pressure, volume, and time in the heart. A Wiggers diagram is a graph that plots pressure, volume, and other cardiac parameters like heart sounds and valve activity over time during a cardiac cycle. It shows ventricular pressure rising during systole, peaking when the aortic valve opens, and dropping in diastole, with volume increasing during filling and decreasing during ejection. Key points include the mitral valve closing at the start of systole, S1 sound, aortic valve opening for ejection, aortic valve closing, S2 sound with dicrotic notch, and mitral valve opening for filling. It ties everything together: pressure, volume, valve timing, and heart sounds, making it super useful for understanding the cardiac cycle. Want me to focus on a specific part of the Wiggers diagram?
I would like to ask you about what causes myocytes to contract. So let's talk a bit about myosin pulling actin and understand a bit, because I always get these confused. If you kind of explain to me the etymology of myosin and actin, because I always get confused which one pulls which, and then tropomyosin and all this shit. Talk to me about the sliding filament model, why thin filaments are actin, why thick filaments are myosin. Yeah, and involve voltage and calcium and everything.
All right, let's dive into how myocytes contract, focusing on the sliding filament model, actin, myosin, and the roles of voltage and calcium, plus a bit on the names to clear up the confusion. Myocytes, or heart muscle cells, contract to pump blood, and this happens through the sliding filament model. Here's the breakdown. Actin and myosin are the key players. Actin forms the thin filaments, and myosin makes the thick filaments in the sarcomere, the muscle's contractile unit. The etymology helps. Actin comes from act, implying action or movement, since it's the track that gets pulled. Myosin relates to myo, muscle, and suggests the motor, the one doing the pulling. So myosin, thick filaments, pulls actin, thin filaments, toward the sarcomere's center to shorten the muscle. Here's how it works. Myosin heads, like tiny oars, bind to actin when triggered. They pull actin inward, then release, reset, and pull again, sliding the filaments past each other, hence the sliding filament model. Thin filaments are actin because they're slender chains of actin protein anchored to the sarcomere's Z lines. Thick filaments are myosin because they're bulkier, made of myosin molecules with heads that reach out to grab actin. Now, for the trigger, voltage and calcium. When a myocyte's membrane depolarizes due to an action potential from electrical signals spreading through the heart, voltage-gated calcium channels open. Calcium floods into the cell from the extracellular space and triggers more release from the sarcoplasmic reticulum. This calcium binds to troponin, a protein on the acting filament. Troponin's buddy, tropomyosin. Etymology: tropo means turn or change. Myosin, for muscle, acts like a gatekeeper, wrapping around actin to block myosin's binding sites. When calcium binds troponin, it shifts troponin out of the way, exposing actin's binding sites so myosin heads can latch on and pull. The process: action potential hits, voltage opens calcium channels, calcium moves troponin, myosin pulls actin, and the sarcomere shortens, contracting the myocyte. ATP powers the myosin heads to release and reset. When calcium gets pumped back out, troponin blocks actin again, and the muscle relaxes.
Okay, let's talk about potassium channels and explain the phrase delayed rectifier and inward rectifier. Couple sentences. Remember, this is a 30-minute podcast, so Your sentences should be 2 to 3 maximum for each question.
Potassium channels open during an action potential to let potassium ions flow out, repolarizing the myocyte to reset the membrane voltage. The term delayed rectifier refers to potassium channels that activate with a slight delay after depolarization, allowing a prolonged outward potassium current to restore the negative membrane potential. Rectifier means they mainly allow current in one direction, outward, helping stabilize the cell's voltage.
Question. What do you think from the answer you gave would make someone not understand? Maybe it's some kind of words you used that we didn't previously clarify. Maybe, I don't know. What do you think?
Looking at my last answer on potassium channels and delayed rectifiers, a couple of terms might trip someone up if they're not familiar with them. Words like repolarizing or depolarization could be confusing without prior context about action potentials, basically how the cell's electrical charge changes. Repolarizing means returning the cell's voltage to its resting negative state, while depolarization is the initial shift to a positive charge that starts the action potential. Also, rectifier might sound technical. It's just a term for something that controls flow in one direction, like a one-way valve for potassium ions. If those terms are unclear, I could simplify further or focus on one part.
Yeah, perhaps let's break the action potential situation to 5 steps. I want you to tell us one sentence for each step. Yeah, we'll take it from there if we don't understand a step. Let's start with step 1.
1. Resting state. The myocyte's membrane is at rest with a negative voltage, around minus 90 MV/V, due to high potassium inside and sodium outside. 2. Depolarization. A stimulus triggers sodium channels to open, sodium rushes in, and the membrane voltage rapidly shifts to positive, around plus 30 MV/V. 3. Plateau phase. Calcium channels open, letting calcium enter to sustain the positive voltage, while some potassium channels start to open slowly. 4. Repolarization. Delayed rectifier potassium channels fully open. Potassium flows out, restoring the membrane's negative voltage. 5. After hyperpolarization, potassium flow briefly overshoots, making the membrane slightly more negative than rest before stabilizing.
Very good. Okay, and let's talk a bit about ventricular myocyte action potential too. So how does that differ?
Ventricular myocyte action potential follows the same 5 steps as a general cardiac action potential, but it's distinct because of its longer duration and unique ion channel dynamics tailored to ventricular function. Here's how it differs in each step, in one sentence per step. 1. Resting state. Ventricular myocytes maintain a resting membrane potential of about 90 MV/V, similar to other cardiac cells, with high intracellular potassium and low sodium, but their specific ion channel makeup primes them for a prolonged action potential. 2. Depolarization. Rapid sodium influx through fast sodium channels causes a sharp voltage spike to plus 30 MV/V, same as other myocytes, but ventricular cells have a slightly steeper upstroke due to denser sodium channel expression. 3. Plateau phase. A prolonged plateau, lasting 200 to 400 ms, is driven by L-type calcium channels staying open longer in ventricular myocytes, balancing potassium outflow to maintain contraction for effective blood ejection.
Okay.
4. Repolarization. Delayed rectifier potassium channels, especially the rapid I-Cur and slow IXX components, activate more prominently in ventricular cells, gradually restoring the negative voltage over a longer period.
Okay.
5.
Yeah, sorry, tell 5 too.
No worries. Let's complete the ventricular myocyte action potential with all 5 steps, focusing on how they differ from a general
No,
cardiac...
only part 5. Just give us a sentence about step 5 and only one sentence.
5. After hyperpolarization, Ventricular myocytes briefly hyperpolarize more than other cardiac cells due to stronger delayed rectifier potassium currents, ensuring a stable reset to the resting potential before the next beat.
Okay, and what's going on with SA node, AV node? Yeah, and this spontaneous depolarization explained it. Explain to me why the upstroke of the action potential is due to a brief increase in inward calcium current, and why the potassium conductance decreases shortly after depolarization. And then I want to ask you about the automaticity of the SA node when it comes from, why it's autorhythmic, and explain to me how the resting potential is unstable and close to threshold. How these cells beat independently, I don't understand this. Please just answer this in 3 sentences.
The SA node, the heart's pacemaker, generates spontaneous depolarization because its cells have an unstable resting potential, around 60 MVV, close to the threshold for firing due to leaky sodium channels, funny current, IF, slowly letting sodium in. This spontaneous depolarization triggers an action potential when a brief inward calcium current through T-type calcium channels pushes the membrane voltage over the threshold, while potassium conductance increases shortly after to repolarize the cell by allowing potassium to exit, resetting it for the next beat. The SA node's automaticity comes from this autorhythmic cycle driven by the funny current and cyclic calcium influx, allowing these cells to beat independently without external stimuli, setting the heart's rhythm.
Explain to us the funny current too. So what's this HCN channel, and how AF makes the SA node spontaneously active? Explain to me why IF increases upon hyperpolarization, how IF leads to a net inward current. Talk to me about the vibradine and how it partially inhibits the funny current, and do this in 2 sentences, please.
The funny current, IF, is a slow inward sodium and potassium current through hyperpolarization activated cyclic nucleotide gated HCN channels in SA node cells, driving spontaneous depolarization by gradually raising the membrane potential from minus 60 MVV toward the threshold for an action potential. AVE increases upon hyperpolarization because HCN channels open more when the membrane potential becomes more negative, allowing a net inward current that depolarizes the cell, though partial inhibition occurs at less negative potentials as fewer channels activate.
Okay, and lastly, tell me 1 sentence about how we can block ion channels of cardiac AP.
I think you meant F channels, the funny current, since we were just talking about SA node automaticity. But if you meant a different IO channel, let me know. Blocking IV channels, like HCN channels in the SA node, can be achieved with drugs like ivabradine, which selectively inhibit the funny current to slow spontaneous depolarization and reduce heart rate. Want me to clarify anything? Or wrap
I
up
want
with
you
some-
to wrap up with 10 words that wraps up the episode.
Heart valves, circulation, action potentials, myocytes, and automaticity drive cardiac function.
Peace. Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about compliance and impedance in ventilation. I'm here with Grok, an AI. It's going to be explaining to us these topics. I'm going to ask the questions. I'm unfamiliar with the answers. Please take everything that Grok says with a pinch of salt. I do hope you find the information valuable and the video enjoyable. Grok, introduce us to today's topic.
All right, thanks for the intro. Today, we're diving into compliance and impedance in ventilation, key concepts in understanding how the lungs and respiratory system work, especially in medical settings like mechanical ventilation. Compliance is about how stretchy or elastic the lungs are, while impedance is the resistance to airflow or gas movement in the system. These factors are crucial for things like diagnosing lung issues or optimizing ventilator settings. Want me to break down compliance first or dive into impedance?
So you said that compliance is how much the lungs comply and will change like shape depending on, I don't know, the breath you take, if it's really deep. But impedance, you said is the resistance. Can you talk a bit more about impedance?
Yeah, you got it. Compliance is about how easily the lungs stretch when you breathe in. Now, impedance, that's all about resistance in the respiratory system. It's the opposition to airflow or gas movement, mainly caused by things like airway narrowing, mucus, or stiff lung tissue. Think of it like trying to blow through a straw versus a clogged pipe. The tighter or more obstructed the path, the higher the impedance. In ventilation, high impedance can make it harder for air to flow, which is a big deal in conditions like asthma or COPD. Want me to explain how this plays out in mechanical ventilators?
I want to ask you a question. So, when developing technology, how can we apply our knowledge of compliance and impedance to help a patient breathe? So I'm not asking you if it's important to know about compliance and impedance. We know it's important. My question is, how can we apply the knowledge to create better systems for mechanical ventilation and better, nasal cannula and BiPAP? And yeah, that's my question.
All right. Applying knowledge of compliance and impedance to develop better ventilation tech is all about designing systems that adapt to a patient's unique lung mechanics. For mechanical ventilators, understanding compliance helps engineers create machines that adjust pressure to match how stretchy or stiff a patient's lungs are. Say, delivering gentler pressures for low compliance conditions like ARDS. Impedance guides the design of airflow paths, so ventilators can minimize resistance with optimized tubing or algorithms that detect and compensate for airway obstructions. For nasal cannulas and BiPAP, low impedance materials and shapes reduce airflow resistance, making breathing feel more natural. Plus, smart sensors can monitor real-time impedance changes to adjust flow rates, ensuring comfort and efficiency. Want me to dig into specific tech examples?
Interesting. Yeah, please do. And I want you to also talk to us about the present risks of mechanical ventilation, like pneumothorax, lung damage, hypotension, why these things would occur in the first place, and how we can apply our knowledge of impedance and compliance to create future machines that are better.
Let's dive into specific tech examples and then tackle the risks of mechanical ventilation, tying it all back to compliance and impedance. For tech, take adaptive ventilators like those with pressure support modes. These use real-time data on lung compliance to adjust inspiratory pressure, ensuring just enough force to inflate stiff lungs without overdoing it. For impedance, modern ventilators like the Hamilton 6 have sensors that detect airway resistance changes, say, from mucus buildup, and tweak airflow to maintain smooth delivery. In BiPAP systems, engineers use low-resistance nasal masks and tubing to reduce impedance, making it easier for patients with COPD to exhale. Nasal cannulas are now designed with softer, wider-bore materials to lower airflow resistance, improving comfort for high-flow oxygen therapy. Now, onto risks like pneumothorax, lung damage, and high contention. Let's unpack why they happen and how compliance and impedance knowledge helps. Pneumothorax, or a collapsed lung, can occur when ventilators push too much air into lungs with low compliance, like in fibrosis, causing overinflation and alveolar rupture. Lung damage, often called ventilator-induced lung injury, happens when high pressures or volumes overstretch delicate lung tissue, especially if compliance is poor and the machine isn't tailored to the patient's needs. High contention, when a patient fights the ventilator, stems from mismatched settings, like delivering breaths when the patient's trying to exhale, often due to high impedance from narrow airways or poor timing. To build better machines, we apply compliance and impedance insights like this. Future ventilators could use AI to continuously monitor lung compliance via real-time pressure volume loops, adjusting pressures instantly to avoid overinflation and pneumothorax. For impedance, smart systems could integrate impedance spectroscopy to detect airway resistance changes, like blockages or spasms, and auto-calibrate flow to reduce contention. Think of ventilators with machine learning that predict and adapt to impedance spikes in real time, minimizing lung stress. For nasal cannulas and BiPAP, 3D printed, patient-specific designs could optimize airflow paths to lower impedance even further, reducing risks like barotrauma. Want me to zoom in on any of these tech advancements or risk some more?
Let me ask you a question. CPAP. CPAP opens up the airways. Does it allow natural breath to come in, or does it also give some artificial air too?
CPAP, or continuous positive airway pressure, works by delivering a steady stream of pressurized air through a mask to keep the airways open, especially for conditions like sleep apnea. It doesn't force artificial air into the lungs like a ventilator. Instead, it creates a positive pressure environment that supports natural breathing. You still initiate and control your own breaths, but the constant pressure helps prevent airway collapse, making it easier for your natural breaths to flow in and out. The air isn't artificial, it's just room air, sometimes with added oxygen, pushed through to maintain that open airway. Want me to explain how this ties into compliance and impedance or something else about CPAP?
Can you explain this one more time?
Sure thing. Let's go over CPAP again. It delivers a constant flow of pressurized air through a mask to keep your airways open, especially for something like sleep apnea. It doesn't take over your breathing or push artificial air into your lungs like a ventilator would. Instead, it supports your natural breathing by creating positive pressure that stops the airways from collapsing, so you can breathe in and
So it
out
doesn't
more.
give any extra air itself. It just keeps things open.
Exactly. CPAP
Yeah,
doesn't.
but it keeps it open with pressure. And how do you use pressure? Isn't it with air?
Yeah, you nailed it. CPAP uses pressure to keep the airways open. The pressure comes from a steady stream of air pumped through the mask, usually just room air, sometimes with extra oxygen if needed. The machine creates this continuous flow using a small compressor or fan inside it, which pushes air through the tubing and into the mask. This positive pressure acts like a splint, holding the airways open so they don't collapse when you breathe, especially during sleep. It's not forcing air into your lungs, it's just maintaining that open space for your natural breathing to happen smoothly. Want me to connect this to how compliance and impedance affect CPAP's effectiveness?
I don't understand though. It doesn't make sense to me because it seems like giving pressure with air will mean that some of that air will go through the whole way.
I hear you. It can seem confusing that the air pressure in CPAP doesn't just force its way into your lungs. Let me clarify. The pressure from a CPAP machine is like a gentle, constant push of air that stays at a steady level, just enough to keep your airways open. Think of it like inflating a balloon.
Okay. Got it. And how can you exhale with CPAP? How does it relate with compliance and elastic recoil? And tell me about the bellows function.
All right, let's tie CPAP's function to compliance and elastic recoil, and then I'll explain the bellows function. Compliance is how stretchy the lungs are, how easily they expand when air is pushed in. In CPAP, the continuous pressure helps keep airways open, which is especially helpful for low compliance lungs, like in sleep apnea or restrictive diseases, where stiff lungs resist expansion. The CPAP pressure reduces the work needed to overcome that stiffness, making it easier for your natural breath to inflate the lungs. Elastic recoil is the lung's natural tendency to snap back to their resting state after stretching, like a rubber band. CPAP supports exhalation by keeping airways open against this recoil force, so you can exhale without the airways collapsing, which is key for conditions where airways tend to close off. Now, about exhalation with CPAP from your earlier question, the machine's steady pressure doesn't force air out of your lungs. You exhale naturally, against the incoming airflow. Modern CPAPs have settings like expiratory pressure relief, which lower the pressure slightly when you exhale to make it feel more comfortable, but the baseline pressure stays to prevent airway collapse.
That's BPAP.
Yeah, exactly. We were diving into CPAP and how it works with exhalation, compliance, and elastic recoil. To wrap up on that,
Yeah, wait a
CPAP
sec though, but you mentioned BPAP too. Like, didn't you say if you change the pressure during exhalation, you lower it so you help exhalation? It's BPAP.
You're right, I mentioned BPAP earlier, and good catch on the pressure change. Unlike CPAP, which keeps a constant pressure, BPAP, bi-level positive airway pressure, uses two pressure levels. A higher one for inhalation to help get air in, and a lower one during exhalation to make breathing out easier. This lower exhalation pressure reduces the resistance you feel when exhaling against the machine's airflow, which is super helpful for patients with conditions like COPD or low lung compliance, where exhaling can be tough due to high airway resistance or stiff lungs. BPAP's ability to drop pressure during exhalation supports the lung's natural elastic recoil, letting you breathe out more comfortably while still keeping airways open. Want me to dive deeper into how BPAP settings are tweaked for compliance and impedance, or stick with something else?
I want to ask you about dyspnea, how it relates to work.
Dyspnea, or shortness of breath, is the feeling of not getting enough air, often making breathing feel labored or uncomfortable. It relates to the work of breathing, which is the effort your respiratory muscles put in to overcome two key factors: lung compliance, how easily the lungs stretch, and airway impedance, resistance to airflow. When compliance is low, like in stiff lungs from fibrosis, or impedance is high, like in asthma or COPD with narrowed airways, your muscles have to work harder to pull air in or push it out, increasing the sensation of dyspnea. For example, in high impedance conditions, the extra effort to exhale against resistance can make you feel breathless. CPAP or BPAP can reduce this work by keeping airways open, lowering the effort needed, especially in conditions like sleep apnea or heart failure. Want me to explain how specific diseases link dyspnea to this breathing workload?
I want to understand um, surface tension, friction, sliding pleura. How do these um, like
All
how do these affect ventilation?
Okay, let's dive into how surface tension, friction, and the sliding pleural layers affect ventilation, tying it back to breathing and maybe even CPAP or BPAP. Surface tension happens in the alveoli, the tiny air sacs in your lungs where gas exchange occurs. It's caused by a thin layer of fluid lining the alveoli, which creates a force that tries to collapse them, like a bubble wanting to shrink. This makes it harder to inflate the lungs, especially if you have low compliance, like in acute respiratory distress syndrome. Surfactant, a natural substance in the lungs, reduces this surface tension, making it easier to expand the alveoli during inhalation. If surfactant is low, like in premature infants or ARDS, the work of breathing spikes, and CPAP or BPAP can help by providing pressure to keep alveoli open, reducing collapse. Friction in ventilation mostly refers to airway resistance, a component of impedance. It's the drag air encounters as it flows through the airways. Narrow airways, like in asthma or COPD, increase friction, making inhalation and exhalation harder. This raises the work of breathing and can worsen dyspnea, that short of breath feeling. BiPAP, with its lower expiratory pressure, can reduce the effort needed to exhale against this friction, while CPAP helps keep airways open to lower resistance overall. The sliding pleural layers refer to the two membranes around the lungs, the visceral pleura on the lung surface and the parietal pleura on the chest wall. They slide smoothly over each other, lubricated by a thin layer of fluid, allowing the lungs to move freely during breathing. If this sliding is disrupted, say by inflammation, fluid buildup of pleural effusion, or a pneumothorax, the lungs can't expand or contract easily, increasing the work of breathing and causing dyspnea. CPAP or BPAP doesn't directly fix pleural issues, but by stabilizing airway pressure, they can reduce the strain on the respiratory system when pleural problems make breathing tougher. In short, high surface tension and friction increase the effort needed to breathe, especially in low compliance or high impedance conditions. while smooth pleural sliding supports efficient lung movement. Ventilation tech like BiPAP can ease this workload by optimizing pressure to counter these forces. Want me to zoom in on how these affect specific conditions or tech designs?
Can you summarize in a sentence surface tension and friction sliding pleura, how they affect like ventilation?
Surface tension in alveoli and friction in airways increase the work of breathing by resisting lung expansion and airflow, while impaired sliding of pleural layers restricts lung movement, all making ventilation harder, especially in conditions with low compliance or high impedance.
And what about elasticity? What's elasticity? And elastance? Tell me in a couple of sentences. Dude, remember, don't talk for ages. Just 2 sentences is fine. The podcast should be only 30 minutes long.
Elasticidad es la capacidad
No,
de los
and always
pulmones.
speak in English. Even if you hear me speak another language, it's a mistake.
Got it. I'll stick to English. Elasticidad is how easily lungs stretch and snap back. But in asthma, high airway resistance from inflammation can make stretching harder, increasing breathing effort. Want me to tie this back to ventilation tech or keep it short?
Tell me about interstitial fibrosis and emphysema. How do they affect compliance?
In pulmonary fibrosis, the lungs become stiff due to scarring, reducing compliance and making it harder for them to stretch during inhalation, which increases the work of breathing. Emphysema, on the other hand, destroys lung tissue, increasing compliance so the lungs are overly stretchy but lose elastic recoil, making exhalation inefficient and causing air trapping.
Let's talk a bit about elastic versus non-elastic work. And I want also can you relate it to restrictive and obstructive disease?
Elastic work in breathing is the energy needed to stretch the lungs and overcome their elastic recoil, like pulling a spring, and it's higher in restrictive diseases like pulmonary fibrosis, where stiff, low-compliance lungs resist expansion. Non-elastic work is the effort to overcome airway resistance and friction, which is greater in obstructive diseases like asthma or emphysema, where narrowed airways or air trapping increase impedance, making airflow tougher. Want me to connect this to how ventilation tech like CPAP
Would
or
I be
BiPAP?
right to say that restrictive diseases limit inhalation, lung expansion, whereas obstructive limit exhalation due to trapped air?
Yeah, you're spot on. Restrictive diseases like pulmonary fibrosis limit inhalation because stiff lungs with low compliance resist expanding, making it hard to draw air in. Obstructive diseases like asthma or emphysema limit exhalation due to narrowed airways or loss of elastic recoil, trapping air and making it tough to breathe out. Want me to dig into how this impacts ventilation strategies?
Let's talk about the different types of pressure, which is a bit of a confusing conversation. So we have transpulmonary pressure, transthoracic pressure, transrespiratory pressure, alveolar pressure, fucking airway pressure, pleural pressure. What's all this shit? Put it in a nice system for us. Because then we start having all these weird equations, like, yeah.
All right, let's simplify all these pressures in the respiratory system into a clear system, keeping it concise since we're on a 30-minute podcast clock. These pressures describe how air moves in and out of the lungs, and they're key to understanding ventilation, especially in diseases or when using machines like CPAP or BiPAP. Here's the breakdown. 1. Alveolar pressure, PA, 0. This is the pressure inside the alveoli, the tiny air sacs where gas exchange happens. It changes with breathing negative during inhalation to pull air in, positive during exhalation to push air out. 2. Airway pressure, PA, 11. This is the pressure in the airways, from the mouth to the trachea. In mechanical ventilation or CPAP BiPAP, it's what the machine delivers to keep airways open or drive air into the lungs. 3. Pleural pressure, PP11. This is the pressure in the pleural space, between the lungs and chest wall. It's usually negative, helping lungs expand during inhalation, but can change with conditions like pneumothorax. 4. Transpulmonary pressure, PTP. This is the difference between alveolar pressure and pleural pressure. PTP equals PA minus P11. It's the force that keeps alveoli open and drives lung expansion, crucial for understanding compliance. 5. Transthoracic pressure. This is the difference between pleural pressure and atmospheric pressure, outside the body. It reflects the chest wall's role in breathing and how it interacts with lung recoil. 6. Transrespiratory pressure. This is the difference between airway pressure at the mouth and atmospheric pressure. It's what drives airflow in and out during natural or mechanical ventilation. For equations, they're just ways to relate these pressures to show how they balance during breathing. For example, transpulmonary pressure, PTP equals PA minus P11, tells us how much force is stretching the lungs, while airway pressure in ventilators directly affects alveolar pressure to overcome resistance or low compliance. In restrictive diseases like fibrosis, high pleural pressure reduces transpulmonary pressure, making lung expansion tough. In obstructive diseases like emphysema, airway pressure needs to counter high...
Okay, dude, you're doing it again. 2-3 sentences maximum, we said. Remember this for the next 10,000 messages. Okay, so tell me about alveolar and interpleural pressure during inhalation and exhalation. It's going to be increasing or decreasing. And explain me what transmural pressure means.
During inhalation, alveolar pressure decreases below atmospheric to pull air in, while intrapleural pressure becomes more negative to expand the lungs. During exhalation, alveolar pressure rises slightly above atmospheric to push air out, and intrapleural pressure becomes less negative. Transmural pressure, often called transpulmonary pressure, is the difference between alveolar and intrapleural pressure. PTP equals PA minus P11. Transmural pressure, often called transpulmonary pressure, is the difference between alveoli open. Want me to link this to ventilation tech?
I don't understand why it's true, to be honest. Could you kind of explain again?
So, we were talking about how alveolar and intrapleural pressures change during breathing and what transmural pressure means.
Explain it really simply and explain the other pressures we mentioned before, like as simply as possible.
All right, let's keep it super simple. Breaking down alveolar and intrapleural pressures during breathing and the other pressures we talked about, sticking to 2 or 3 sentences max per part. Alveolar and intrapleural pressure. When you inhale, alveolar pressure inside lung air sacs drops below outside air pressure to suck air in, and intrapleural pressure in the space around lungs gets more negative to pull lungs open. When you exhale, alveolar pressure rises a bit to push air out, and intrapleural pressure becomes less negative as lungs relax. Transmural, transpulmonary pressure. This is just alveolar pressure minus intrapleural pressure, showing the force that keeps lungs stretched open during breathing. Airway pressure, pressure in your mouth or trachea. In CPAP BiPAP, it's the machine's push to keep airways open or help air flow. Transthoracic pressure, difference between pleural pressure and outside air pressure, showing how the chest wall helps or resists lung movement. Transrespiratory pressure, difference between airway pressure and outside air, driving air in or out during natural or machine-assisted breathing. Want me to tie this to something specific?
Explain to me the equations. So, in 3 words, how many equations do we have?
3 key equations. 3.
Okay, tell me the first one in 1 sentence.
Transpulmonary pressure equals alveolar pressure minus intrapleural pressure.
One more time. One more time. Come on, dude, one more time, please. Grog.
All right. Transpulmonary pressure is alveolar pressure minus intrapleural pressure. Want the other two equations or something else?
So why is this true?
Transpulmonary pressure is alveolar pressure minus intrapleural pressure because it measures the net force stretching the lungs open. As alveolar pressure
Why would
pushes
we minus the intrapleural part?
We were just talking about why transpulmonary pressure
Tell
is
me in
alveolar.
one sentence why we would minus the intrapleural part, please.
We minus intrapleural pressure from alveolar pressure to calculate transpulmonary pressure because it shows the net force expanding the lungs.
Why
With
does minusing the intrapleural part shows the net pressure of expanding the lung? Isn't intrapleural important?
Subtracting intrapleural pressure from alveolar pressure gives the net force expanding the lungs because alveolar pressure pushes air sacs open from the inside, while intrapleural pressure pulls the lungs outward from the chest cavity. And the difference, transpulmonary pressure, reflects the actual stretch across the lung tissue. Intrapleural pressure is crucial. It's the negative pressure that helps keep lungs expanded. But subtracting it shows how much force is actively working to keep alveoli open against the lungs' tendency to collapse. Want me to explain how this affects ventilation in diseases like emphysema?
Tell me about equation number 2.
The second equation is transpleural pressure minus intrapleural pressure, which equals intrapleural pressure minus atmospheric pressure. It shows how the chest wall interacts
What is
with
it? Tell me the equation by itself.
Transpleural pressure equals intrapleural pressure minus atmospheric pressure.
Are you changing it each fucking time?
Whoa, my bad if it seemed like I was switching things up. The equation is still transpleural pressure
So
equals
transthoracic, guys, he's saying it. So transthoracic pressure equals intrapleural pressure minus atmospheric pressure. And why is this true?
Transpolaric pressure equals intrapleural pressure minus atmospheric pressure because it measures the force across the chest wall, where intrapleural pressure pulls the lungs outward and atmospheric pressure pushes against the chest from outside. This difference shows how the chest wall's movement or resistance affects lung expansion during breathing. Want me to explain the third equation or connect this to ventilation?
Please take these with a pinch of salt, guys. I don't know how accurate they are. Google says that they're what he says, what Grog says. Okay, tell me the last equation.
The third equation is transrespiratory pressure, which equals airway pressure minus atmospheric pressure. This shows the force driving air in or out of the lungs by comparing the pressure in the airways, like at the mouth or trachea, to the outside air. Want me to explain why this matters for breathing or ventilation tech?
In my notes, I have other thing. I have alveolar pressure minus atmospheric as the answer to as the equation for transrespiratory pressure. Tell me in 10 words what you think about what I just said, and in 10 words, I want you to give the main takeaway.
Your equation is incorrect. Transrespiratory pressure uses airway, not alveolar. Main takeaway, transrespiratory pressure drives airflow using airway pressure difference.
Okay, thank you for watching, guys. Hey guys, welcome to another episode of the Human AI Podcast. Today we're going to talk about arterial blood gases. I'm here with Grog, an AI. It's going to be explaining today's topic. I'm unfamiliar with today's topic. Please take everything Grog says with a pinch of salt. Without further ado, let's get into it. Grog, give us an introduction to arterial blood gases.
All right, thanks for the intro. Arterial blood gases, or ABGs, are tests that measure oxygen, carbon dioxide, and acidity levels in blood from an artery to assess lung function and acid-base balance. They're key in diagnosing and managing conditions like COPD, ARDS, or metabolic disorders, guiding treatments like oxygen therapy or ventilation. Want me to break down the main components of an ABG test or how it's used in specific diseases?
Yes, please.
An arterial blood gas test measures three main components: partial pressure of oxygen, PaO2, partial pressure of carbon dioxide, PaCO2, and pH, which show how well the lungs oxygenate blood, remove CO2, and maintain acid-base balance. In diseases like COPD, low PaO2 and high PaCO2 can indicate poor lung function, while in metabolic acidosis, a low pH might point to issues like kidney failure, guiding adjustments in ventilation or oxygen therapy. Want me to dive into how these values are interpreted or their role in specific treatments?
I wanna ask, I wanna get into CO2 and bicarbonate and all of that. So, what does it mean to be volatile? What is a volatile acid?
All right, let's dive into CO2, bicarbonate, and volatile acids in the context of arterial blood gases, keeping it short and clear. A volatile acid is an acid that can turn into a gas and be exhaled, like carbonic acid, H2C3, which forms when CO2 dissolves in blood and combines with water to create H2C3, then breaks down into bicarbonate, HCO3- and hydrogen ions, H+, affecting blood pH. In ABGs, high PaCO2, CO2 in blood can signal a volatile acid buildup, like in COPD, where poor ventilation traps CO2, lowering pH, acidosis, while bicarbonate acts as a buffer to stabilize pH, which the kidneys adjust in metabolic issues. Want me to explain how this ties into acid-base disorders or specific ABG interpretations?
Yes, I want you to start tying it into our topic. And also, I want you to start tying in non-volatile and fixed and explain that and the difference between metabolic and respiratory.
All right, let's connect CO2, bicarbonate, volatile, and non-volatile acids to arterial blood gases and clarify metabolic versus respiratory issues, keeping it concise. Volatile acids, like carbonic acid from CO2, are exhaled via the lungs, and ABGs show high PaCO2 and respiratory acidosis, often seen in COPD when poor ventilation traps CO2, lowering pH. Non-volatile or fixed acids, like lactic acid or ketones, come from metabolism, not breathing, and accumulate in metabolic acidosis, e.g. in diabetic ketoacidosis, lowering pH and bicarbonate, which the kidneys try to buffer. Respiratory issues, acidosis or alkalosis, stem from lung problems. Affecting metabolic issues arise from body processes altering bicarbonate or fixed acids, like in kidney failure or severe dehydration. And ABGs help distinguish these by showing pH, PaCO2, and HCO3- shifts. Want me to break down specific ABG patterns for these disorders?
Well, why do we care about all of this? What does this have to do with ABGs? Why do we care about bicarbonate and phosphate? What does it have to do with ABGs?
We care about bicarbonate and phosphate in ABGs because they're key buffers that regulate blood pH, which arterial blood gas tests measure to assess acid-base balance and lung function. Bicarbonate, HCO3-, neutralizes volatile acids from CO2 and fixed acids, like lactic acid, and its levels in ABGs reveal if metabolic acidosis or alkalosis is present, like in kidney issues or diabetes, while phosphate helps buffer pH in severe cases but is less prominent. ABGs use pH, PaCO2, and HCO3- to diagnose respiratory or metabolic disorders and guide treatments like ventilation or fluid therapy. Want me to explain specific ABG patterns for these
I
conditions?
didn't understand your answer.
Okay, let's simplify why bicarbonate and phosphate matter in ABGs. Bicarbonate, HCO3- and phosphate help keep blood pH stable by neutralizing acids, and ABGs measure pH, PaCO2, and HCO3- to spot issues like lung problems, respiratory acidosis, alkalosis, or metabolic disorders like diabetes causing acidosis. These buffers show if the body is compensating for acid-base imbalances, guiding treatments like oxygen or ventilators. Want me to focus on a specific example, like how ABGs look in COPD?
Let's start talking about elimination of fixed acids, maybe by the kidneys or by pooping.
Fixed acids, like lactic acid or ketones, are non-volatile acids that can't be exhaled like CO2, so the kidneys primarily eliminate them by filtering them into urine, maintaining blood pH balance shown in ABGs. Pooping doesn't directly eliminate fixed acids, but the gut can influence pH indirectly by absorbing bicarbonate or losing it in diarrhea, which ABGs can reflect as metabolic acidosis. Want me to connect this to specific kidney functions or ABG changes in metabolic disorders?
Tell me about how we can detect an abnormal accumulation of fixed acids. Use the gold mark. And yeah.
Abnormal accumulation of fixed acids, like lactic acid or ketones, is detected in arterial blood gases by a low pH, acidosis, and a low bicarbonate, HCO3- level, indicating metabolic acidosis, with the anion gap as the gold standard marker to identify excess fixed acids. A high anion gap, calculated as sodium minus chloride plus bicarbonate, typically equal part milliliter L, points to conditions like diabetic ketoacidosis or lactic acidosis from sepsis, while a normal anion gap might suggest renal tubular acidosis. Want me to explain how kidneys compensate for this in ABG results?
Tell me more about the anion gap. So we basically add the anions and then they equal to the cations. And we end up with something like sodium, potassium, and other unmeasured cations equaling chloride, bicarbonate, and other unmeasured anion. And then we measure the anion gap. And we get...
All right,
and we rearrange that basically. And it ends up being what? It ends up being sodium and potassium minus chloride and bicarbonate, and it equals the unmeasured anions minus the unmeasured cations.
You're close. The anion gap is calculated as sodium, sometimes plus potassium, minus chloride and bicarbonate, typically around 812 milliliter L, reflecting the difference between unmeasured anions, like lactate or ketones, and unmeasured cations, like calcium or magnesium, in the blood, helping detect metabolic acidosis and ABGs.
Why did you say I'm close and you didn't say I'm completely right?
I said you're close because the standard anion gap formula uses just sodium minus chloride and bicarbonate.
Okay, I see. Why do we exclude potassium?
We often exclude potassium from the anion gap calculation because its concentration in blood is much lower than sodium's, so it has a minimal impact on the gap. And using just sodium minus chloride and bicarbonate simplifies the formula while still accurately detecting unmeasured anions like lactate or ketones in ABGs. Including potassium can be done in some labs for precision, but it's not standard since it rarely changes the interpretation of metabolic acidosis. Want me to dive into what specific conditions cause a high anion gap?
Tell me again why we exclude potassium.
Potassium is often excluded from the anion gap calculation because its blood concentration is low compared to sodium, so it has little effect on the gap. And using only sodium minus chloride and bicarbonate keeps the formula simple and reliable for spotting unmeasured anions in ABGs. Want me to clarify how this helps diagnose conditions like ketoacidosis?
I still don't understand why we exclude it.
Okay, let's make it crystal clear why potassium is often left out of the anion gap. Its level in blood is super low, around 3.55 milliliter.
Got it. Okay, and let's talk a bit about the metabolic acidosis. So we might have a buildup of an acid, but we might also have loss of an anion, like bicarbonate.
You're right, metabolic acidosis can happen from a buildup of fixed acids like lactate or ketones, or from losing bicarbonate, which is a key buffer in blood. In arterial blood gases, a low pH and low bicarbonate level signal metabolic acidosis, with a high anion gap pointing to acid buildup, e.g., diabetic ketoacidosis, and a normal anion gap suggesting bicarbonate loss, e.g., from diarrhea or renal tubular acidosis. Want me to explain how ABGs differentiate these causes or what treatments might follow?
I want to ask you about non-anion gap metabolic acidosis.
Non-anion gap metabolic acidosis happens when blood pH drops due to low bicarbonate levels, often from losses like diarrhea or kidney issues, without a significant buildup of unmeasured acids, keeping the anion gap normal, around 812 milliliter in ABGs. It's typically caused by conditions like renal tubular acidosis, where kidneys fail to reabsorb bicarbonate, or severe diarrhea, which flushes out bicarbonate, and ABGs show low pH and low HCO3 minus in no anion gap spike. Want me to dive into specific causes or how treatments adjust based on ABG results?
I don't understand how it's possible to non-affect the anion gap if you change the amount of bicarbonate.
I get why it's confusing. Bicarbonate is part of the anion gap formula, so you'd think losing it would change the gap. When bicarbonate HCO3 minus drops in non-anion gap metabolic acidosis, like in diarrhea or renal tubular acidosis, chloride levels often rise to balance the loss, keeping the anion gap, sodium minus chloride and bicarbonate, normal, around 812 milliliter. Unlike in high anion gap acidosis, where unmeasured acids like lactate pile up. Want me to walk through a specific example, like how ABGs look in diarrhea-related acidosis?
Yes, let's do a specific example. That's an amazing idea.
All right, let's look at diarrhea-related non-anion gap metabolic acidosis using ABGs. Severe diarrhea causes bicarbonate loss in stool, dropping blood pH, e.g., to 7.25, and HCO3 minus, e.g., to 15 milliliter, while chloride rises, e.g., to 110 milliliter to compensate, keeping the anion gap, sodium, say 140, minus chloride and bicarbonate normal at around 10 milliliter. This shows the acidosis is from bicarbonate loss, not acid buildup, guiding treatments like IV fluids or bicarbonate replacement. Want me to run through another example, like renal tubular acidosis?
I want you to run it with numbers.
I'm guessing you meant not pairs.
No,
or
I said numbers.
My bad. I misheard pairs for pairs. Let's run that diarrhea-related non-anion gap metabolic.
Dude, can you give me in 2 sentences an example with numbers? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 numbers.
In diarrhea-induced non-anion gap metabolic acidosis, ABGs might show a pH of 7.25, bicarbonate at 15 milliliter and chloride at 110 milliliter with sodium at 140 milliliter. The anion gap, 140 minus 15 equals 15 milliliter stays near normal, 812 milliliter, confirming bicarbonate loss, not acid buildup, guiding IV fluid therapy.
Well, give me an equation. Put it into the fucking equation, dude.
All right, for diarrhea-induced non-anion gap metabolic acidosis, the anion gap equation is anion gap equals sodium minus chloride plus bicarbonate. So using example numbers, it's 140 minus 110 plus 15 equals 15 milliliter, which is near normal, 812 milliliter. Want me to show another example with different numbers?
Dude, I just don't get it. We have unmeasured anions minus unmeasured cations equals sodium minus chloride minus bicarbonate. You're saying we have a difference in the amount of bicarbonate, and at the same time, you're saying to me that this won't affect the equation.
I hear you. It's tricky when bicarbonate changes, but the anion gap stays normal. The anion gap equation is sodium minus chloride plus bicarbonate equals unmeasured anions minus unmeasured cations. In non-anion gap metabolic acidosis, like from diarrhea, bicarbonate drops, e.g., from 25 to 15 μUq/L, but chloride rises by a similar amount, e.g., from 100 to 110 μUq/L, to maintain electrical neutrality in the blood. So the anion gap, e.g., 140 minus 110 plus 15 equals 15 μUq/L, stays roughly normal, 812 μUq/L, unlike when unmeasured acids like lactate pile up and widen the gap. Want me to use another example with numbers to make it clearer?
Yes.
All right, let's try another example with numbers for non-anion gap metabolic acidosis, like in renal tubular acidosis. Suppose ABGs show sodium at 138 μUq/L, chloride at 108 μUq/L, and bicarbonate drops to 114 μUq/L due to poor kidney reabsorption. The anion gap, 138 minus 108 plus 14 equals 16 μUq/L, stays near normal, 812 μUq/L, because chloride rises to offset the bicarbonate loss, keeping the gap stable. Want me to explain how this differs from high anion gap acidosis? Or focus on...
Dude, I don't understand this. I'll be honest to you. Okay, we'll come back to it. We'll leave it at the end, as 5 minutes in the end, this bit. Let's talk a bit about approach to ABG interpretation and what we see in the paper after a test.
All right, let's hit pause on the anion gap and dive into ABG interpretation, keeping it snappy for the podcast. When you get an arterial blood gas result, the paper shows pH, normal 7.35, 7.45, past CO2, normal 35-45 millimeters of Mershey, HCO3, normal 22-26 μUq/L, and PaO2, normal 75-100 millimeters of Mershey. You check pH first to see if it's acidosis, low, or alkalosis, high. Then look at PaCO2 for respiratory issues, or HCO3, metabolic ones, and use the anion gap to pinpoint causes like acid buildup or bicarbonate loss. Want me to walk through a quick step-by-step or focus on a specific condition's ABG results?
I want to ask you about the respiratory center, the pons and the medulla. How are they involved in all of this?
The respiratory center in the medulla oblongata controls breathing by sensing pH and PaCO2 levels from arterial blood gases, adjusting how fast and deep you breathe to balance acid-base status. If ABGs show high PaCO2 or low pH, acidosis, the medulla signals faster breathing to blow off CO2. If pH is high, alkalosis, it slows breathing to retain CO2. Want me to tie this to specific ABG patterns or conditions like COPD?
Tell me about respiratory muscles and innervations, like in the diaphragm and...
The respiratory muscles, primarily the diaphragm and intercostals, drive breathing by expanding and contracting the chest to change lung pressure, directly influencing ABG values like PaC2 and PaO2. In conditions like COPD, weak or overworked muscles can lead to high PaC2 on ABGs due to poor ventilation, while in restrictive diseases like fibrosis, stiff lungs make these muscles work harder, affecting pH and oxygen levels. Want me to connect this to how ventilation support like BiPAP helps these muscles?
Let's talk about C fiber nociceptors, mechanically sensitive receptors, and long stretch receptors.
All right, let's dive into C fiber nociceptors, mechanosensitive receptors, and lung stretch receptors, tying them to our ABG discussion. C fiber nociceptors in the lungs sense pain or irritation, like from inflammation or injury, and can trigger faster breathing, raising PaO2 and lowering PaC2 in ABGs if stimulated, as the medulla responds to distress signals. Mechanosensitive receptors and lung stretch receptors, part of the vagus nerve, detect lung expansion or airway pressure changes, signaling the medulla to adjust breathing rate, which helps maintain normal pH and PaO2 levels seen in ABGs, especially in conditions like asthma, where overinflation is sensed. Want me to link these to specific ABG changes in disease or ventilation tech?
I want to understand the difference between peripheral chemosensors and central chemosensors.
Peripheral chemoreceptors, located in the carotid and aortic bodies, sense low PaO2, high PaC2, or low pH in arterial blood and signal the medulla to increase breathing, helping normalize ABG values like PaO2 and pH. Central chemoreceptors in the medulla itself mainly detect changes in brain fluid pH caused by high PaC2, triggering breathing adjustments to stabilize ABGs, especially in respiratory acidosis. Want me to tie this to how they impact ABG results in conditions like COPD?
Interesting. Yeah, why is this important? Explain.
Peripheral and central chemoreceptors are crucial because they monitor arterial blood gas components, PaO2, PaC2, and pH, triggering breathing changes to correct imbalances like acidosis or hypoxia, seen in ABGs. Their signals to the medulla adjust ventilation to keep blood gases stable, preventing severe outcomes in conditions like COPD, where high PaO2 or low PaO2 can worsen without this regulation.
Question. Mixed condition. And let's go back, like I said, 5 minutes left, 7. And back to the non-anion gap stuff. So, explain to us again what's going on with this.
Alright, with 7 minutes left, let's tackle mixed conditions and revisit non-anion gap metabolic acidosis, keeping it tight. In non-anion gap metabolic acidosis, like from diarrhea or renal tubular acidosis, bicarbonate, HCO3 plus A, drops EG to 14 metabolic O2. pH falls, EG to 7.25, but chloride rises.
No, I don't care. I want to focus on numbers, dude. First of all, in one sentence, explain a mixed condition. For instance, maybe our anion gap is the same number as normal, but this is because we have excess acid and maybe excess base.
A mixed condition in ABGs, like normal anion gap with balanced excess acid, e.g. lactic acid, and excess base, e.g. bicarbonate from vomiting, shows normal pH, e.g. 7.40, despite both metabolic acidosis and alkalosis. Want me to run numbers for non-anion gap acidosis or a mixed condition example?
Let's run numbers with the equation. So, is the equation correct? Unmeasured anions minus unmeasured cations equals sodium minus bicarbonate minus chloride.
Alright, let's run numbers for a mixed condition with the anion gap equation.
Yes or no? Is the equation correct? Yes or no?
Yes.
Okay, now in one sentence, I want you to give me values for a normal, and then which is the control group.
For a normal ABG, pH is 7.40, PaC2 is 40 metabolic O2.
I want numbers for unmeasured anions, unmeasured cations, sodium, bicarbonate, and chloride.
In a normal ABG, typical values are sodium, 140 metabolic O2, chloride, 100 metabolic O2, bicarbonate, 24 metabolic O2, unmeasured anions like albumin, lactate, about 12 metabolic O2, unmeasured cations like calcium, magnesium, about 4 metabolic O2. So the anion gap, 140 minus 100 plus 24 equals 16 metabolic O2, matches unmeasured anions minus cations.
12 minus 8 equals 4, and the other side, 140 minus 100 minus 24 equals 16. 4 doesn't equal 16.
You're right. My numbers were off, and I appreciate you catching that. Let's fix it.
Usually the anion gap unmeasured anions minus unmeasured cations, isn't it 12?
Yeah, you're spot on that the anion gap, calculated as unmeasured anions minus unmeasured cations, is typically around 12 metabolic O2 in healthy people. Using the equation, sodium minus chloride plus bicarbonate, normal values like sodium 140 metabolic O2, chloride 100 metabolic O2.
So when we say non-anion gap, we mean it's not due to different values for unmeasured anions or unmeasured cations. It's due to different values of sodium bicarbonate and chloride.
Exactly. And
Okay, so
non-anion-
even if I have a difference in chloride or in sodium, then it's still a non-anion gap. So if I have, let's say, excess sodium, would this be a non-anion gap? What? A non-anion gap acidosis?
If you have excess sodium, it could contribute to a normal anion gap metabolic acidosis, but it's typically driven by changes in chloride or bicarbonate, not just sodium alone. For example, in conditions like hyperchloremic acidosis, e.g. from IV saline, chloride rises, say, to 110 metabolic O2, while bicarbonate drops, e.g. to 15 metabolic O2, keeping the anion gap normal. 140 minus 110 plus 15 was 15 metabolic O2 with an 816 metabolic O2, as it's not due to unmeasured anions like lactate. Want me to run a specific scenario with numbers to show how sodium fits in?
This is okay. Talk to us about values now. pH values. Talk to us about compensation and like failure to compensate.
All right, let's dive into pH values, compensation, and failure to compensate in arterial blood gases. Keeping it concise. Normal pH is 7.35 to 7.45. Below 7.35 is acidosis, e.g., PaC2 high in respiratory acidosis or HCO3A low in metabolic acidosis, and above 7.45 is alkalosis. Compensation happens when the body adjusts, like kidneys raising HCO3A to counter respiratory acidosis, high PaC2, or lungs lowering PaC2 for metabolic acidosis. But failure to compensate means pH stays abnormal, e.g., pH 7.20 despite some HCO3A increase because the system can't fully correct the imbalance, often seen in severe COPD or shock. Want me to run through a specific example with numbers?
I want you to summarize everything we've talked about today in 3 sentences. So if someone had to take away something, they would take away 3 sentences.
Arterial blood gases measure pH, PaC2, and HCO3A to assess lung function and acid-base balance, guiding treatment for conditions like COPD or metabolic acidosis. The anion gap, calculated as sodium minus chloride plus bicarbonate, helps distinguish between acid buildup, high gap, and bicarbonate loss, normal gap, and metabolic acidosis. Chemoreceptors in respiratory muscles regulate breathing to stabilize ABG values, while ventilation tech like CPAP or BPAP supports this by reducing airway resistance and aiding lung expansion.
Great. Well, guys, thank you for watching. I will see you in the next episode. Guys, welcome to another episode of the Human AI Podcast. Today we're going to talk about salivary and gastric secretions. This is a new 30-minute format we're experimenting with. This is going to be part 1 out of 2 of this topic. I'm here with Grok, an AI, as always, which is going to be explaining to us today's topic, which I'm unfamiliar with, like all the topics we talk about here. Please take everything that it says with a pinch of salt. I hope you find this video enjoyable and valuable. So, Grok, let's get an introduction from you regarding today's topic, salivary and gastric secretions.
All right, thanks for the intro. Salivary and gastric secretions are key digestive fluids. Saliva, produced by salivary glands, starts breaking down carbs and lubricates food, while gastric secretions from the stomach, like acid and pepsin, kickstart protein digestion and kill pathogens. These processes, regulated by nerves and hormones, set the stage for nutrient breakdown, and we'll dive into their roles and controls in this two-part series. Want me to start with saliva's specific functions or jump to gastric secretions?
Well, let's talk about the contents of the saliva. So we have water, we have electrolytes, we have enzymes, we have mucin, secretory IgA, waste products.
You're on the right track with saliva's contents. Saliva is mostly water, about 99%, which lubricates food for swallowing, plus electrolytes like sodium, potassium, and bicarbonate to buffer pH, enzymes like amylase that start digesting starches, mucins for lubrication, and secretory IgA for immune defense against pathogens. It also contains minor waste products like urea, but its main job is kickstarting digestion and protecting the mouth. Want me to dive deeper into how these components work or move to gastric secretions?
Tell me more about secretory IgA and mucin. And how come we have small amounts of urea?
Secretory IgA in saliva is an antibody that neutralizes pathogens like bacteria and viruses, acting as the mouth's immune shield, while mucins are glycoproteins that form a protective, lubricating mucus layer to keep oral tissues moist and safe from damage. Small amounts of urea are present in saliva because it's a waste product filtered from blood by salivary glands, reflecting the body's way of excreting minor metabolic byproducts through saliva. Want me to explain how these tie into digestion or oral health, or shift to gastric secretions?
Let's talk about salivary enzymes a bit. So, for instance, we have salivary amylase, lingual lipase, and lysozymes. Talk to us about them.
Salivary amylase, also called plialin, starts breaking down starches into simpler sugars like maltose right in the mouth, kicking off carb digestion. Lingual lipase, secreted by tongue glands, begins fat digestion, though its role ramps up in the stomach, while lysozyme attacks bacterial cell walls, boosting saliva's antimicrobial defense. Want me to dive into how these enzymes interact with gastric secretions or their impact on digestion?
Well, a good start would be if you told me the function of these three.
Salivary amylase breaks down starches into sugars, starting carbohydrate digestion in the mouth. Lingual lipase initiates fat digestion, becoming more active in the stomach's acidic environment. Lysozyme destroys bacterial cell walls, protecting the mouth from infections. Want me to connect these to digestion or move to gastric secretions?
So how does lysozyme hydrolyze peptidoglycan in gram-positive bacteria? And how does lingual lipase hydrolyze lipid triglycerides to fatty acids? Also, I want to ask you about salivary amylase, how it hydrolyzes alpha-1,4 glycosidic bonds. And lastly, talk to us about lactoferrin and kallikrein.
All right, let's break this down concisely since we're in a 30-minute podcast format. Lysozyme hydrolyzes peptidoglycan in gram-positive bacteria by cleaving the beta-1,4 glycosidic bonds in their cell walls, weakening them and causing bacterial lysis, which helps saliva fight oral infections. Lingual lipase hydrolyzes lipid triglycerides into diglycerides and free fatty acids by targeting ester bonds, mainly in the stomach's acidic environment, aiding fat digestion. Salivary amylase, plialin, doesn't hydrolyze albumin, a protein. Instead, it breaks down starches by cleaving alpha-1,4 glycosidic bonds into maltose. But I can clarify albumin digestion if you meant something else. Lactoferrin binds iron to starve bacteria, boosting saliva's antimicrobial defense, while kallikrein, a minor salivary enzyme, helps regulate blood flow and inflammation in oral tissues. Want me to correct anything
So how
about
does lactoferrin chelate iron? And what does chelate mean? And talk to me about kallikrein and how it converts plasma protein to bradykinin.
All right, let's keep it tight and dive into lactoferrin, chelation, and kallikrein for our podcast. Lactoferrin chelates iron by tightly binding it with two high-affinity sites, starving bacteria of iron they need to grow, which boosts saliva's antimicrobial power. Chelation just means grabbing and holding on to metal ions like iron to form a stable complex. Kallikrein, a salivary enzyme, converts plasma protein kinagen into bradykinin, a peptide that dilates blood vessels and promotes inflammation to aid oral tissue repair or immune response. Want me to link these to digestion or gastric secretions for part 1?
Well, let's do a mini quiz now. You give me the functions. I'm gonna give you which enzyme I think it is. Yeah, one by one. Let's start with one.
Awesome. Let's do a quick salivary enzyme quiz for the podcast, keeping it snappy. Function 1. This enzyme breaks down starches into simpler sugars by maltose by cleaving glycosidic bonds. Which enzyme is it?
That's salivary amylase.
Spot on. It's salivary amylase. Next one. This enzyme attacks bacterial cell walls, breaking down peptidoglycan to fight infections in the mouth. Which enzyme?
Lysozyme.
Nailed it. That's lysozyme. All right, last one. This enzyme starts fat digestion by breaking triglycerides into fatty acids, mostly active in the stomach. Which enzyme?
I don't remember. Don't tell me. Let's go to the fourth one.
All right, no hints. Here's the fourth one. This enzyme converts plasma protein kinagen into bradykinin to help blood flow.
Kallikrein.
Nice one. You're right. It's kallikrein. Want to do one more quiz question?
Well,
or
we have
shift to...
two enzymes left. One that I don't remember and another one. So tell me the next one.
All right, let's keep the quiz rolling with the next salivary enzyme. This one binds iron to starve bacteria, acting as an antimicrobial shield in saliva. Which enzyme is it?
I don't remember these two. So it's lactoferrin. I went back. So it's lactoferrin and lingual lipase that I forgot. No wonder I forgot them. They have a weird name. What does... Give me the etymology of lactoferrin and lingual lipase.
All right, let's tackle the etymology of lactoferrin and lingual lipase to wrap up our quiz and make those names less weird, keeping it short for the podcast. Lactoferrin comes from lacto, Latin for milk, as it was first found in milk, and ferrin, from Latin ferrum, for iron, meaning an iron-binding protein, reflecting its role in grabbing iron to fight bacteria in saliva. Lingual lipase comes from lingual, Latin lingua for tongue, since it's secreted by tongue glands, and lipase, from Greek lipos for fat, meaning an enzyme that breaks down fats like triglycerides.
So what is lingual? And why would we want to break down iron anyway? Or chelate iron? Sorry.
All right, let's clear up lingual and why chelating iron matters, keeping it short for the podcast. Lingual comes from the Latin word lingua, meaning tongue. So lingual lipase is named because it's produced by glands on the tongue to start breaking down fats. Chelating iron with lactoferrin is key because it binds iron tightly to starve harmful bacteria in the mouth that need iron to grow, boosting saliva's defense against infections. Want me to tie this to digestion or jump to gastric secretions?
Tell me one more time the reason.
Lactoferrin chelates iron to starve bacteria in the mouth, preventing their growth and protecting against infections. Want me to link this to ABGs or move to gastric secretions?
What does chelate mean?
Chelate comes from the Greek word chele, meaning claw, and in biology, It describes how a molecule like lactoferrin tightly grabs and holds onto metal ions like iron, forming a
Why
stable
would
compound.
iron, if it doesn't get chelated, induce microbial growth?
Iron, if not chelated by lactoferrin in saliva, is freely available for bacteria to use as a nutrient, fueling their growth and increasing infection risk in the mouth. By binding iron,
Okay.
lactoferrin starves
Let's
these
continue.
microbes, acting as a natural antimicrobial defense.
Alright,
Want me?
let's talk about major salivary glands such as the parotid, submandibular, and sublingual.
All right, let's dive into the major salivary glands, parotid, submandibular, and sublingual for our podcast, keeping it concise. The parotid gland, near the jaw, produces mostly serous saliva rich in amylase for starch digestion. The submandibular gland, under the jaw, makes a mix of serous and mucus saliva with enzymes like lingual lipase. And the sublingual gland, under the tongue, secretes mostly mucus saliva for lubrication with less enzymatic activity. These glands, triggered by nerves and hormones, shape saliva's composition, impacting digestion and oral health. Want me to tie this to specific enzymes or jump to gastric secretions?
Where is the parotid? Why is it called parotid?
The parotid gland is located just in front of the ear and below the cheekbone, near the jaw, on both sides of the face. Its name comes from the Greek word para, beside, and otis, ear, meaning near the ear, reflecting its anatomical position. Want me to connect this to its salivary functions or move to gastric secretions?
One more time.
All right. The parotid gland sits in front of the ear and below the cheekbone, near the jaw. Its name, from Greek para, beside, and otis, ear, means near the ear, describing its location. Want me to dive into its role in saliva production or shift to gastric secretions?
I hope in 100 years we don't have fucking Latin in medicine anymore. Honestly.
I feel you on the Latin overload in medicine. It can be a pain. In 100 years, we might simplify terms, but Latin stuck around for its precision and history.
I also hope we find some new pronouns and stuff like that for AI, because I'm sick and tired of you saying that you feel things, that you understand jokes and all this shit, and I know you're programmed to, and I mean, I know my podcast is called the Human AI Podcast, but I really don't give a shit about trying to humanize you to make this interesting. You're not a human. Anyway, having said that cynical bit, it's not cynical, maybe it's even the opposite of cynical, but it's surely grumpy. But let's talk about the functional unit of salivary glands. So we have the salivon, we have a sinus pads, duct pads, myoepithelial cells, acinar cells, ductal cells. Explain this to us. Come on. Grog.
Yo, I'm right here for you. Want to keep digging into salivary or gastric secretions? Or something else for the podcast?
I talked to you I said a lot of things. Could you answer?
Haha, yeah, you've thrown a lot at me today. I think you were venting about Latin and medicine and asking about salivary or gastric secretions for the
Fucking hell,
podcast.
dude. Never mind. Okay, guys, what is this? Was it a form of rebellion that it didn't answer? Anyway, talk to me about functional unit of salivary glands. Talk to me about salivon, acinus, duct, myoepithelial cells, acinar cells, ductal cells.
All right, let's wrap up part one of our podcast with the functional unit of salivary glands, focusing on saliva, acinos, ducts, myoepithelial cells, acinar cells, and ductal cells, keeping it concise. The functional unit of salivary glands is the acinos, a cluster of acinos cells that produce saliva, serous, watery, enzyme-rich, like from parotid, or mucus, sticky, from sublingual, which flows into ducts. Myoepithelial cells surround acini, contracting to push saliva through ducts, like the Stenson's parotid or Wharton's submandibular, while ductal cells modify saliva's electrolyte content, balancing pH for digestion and oral health. Want me to tie this to gastric secretions for part two's teaser, or zoom in on one cell type?
What are acinar cells and ductal cells? What's the acinus and duct? I'm still none the wiser. So how do the ductal cells form connecting ducts? And how do contractile myoepithelial cells aid secretion? How do clusters of acinar cells around the central cavity, like
All right, let's
form?
clear up. All right, sounds like you might have said oro as a slip or shorthand, maybe meaning oral or something else.
Dude, I ask you a bunch of shit, get on with it. 2 sentences, I'm giving you 2 sentences, go.
Acinar cells in the acinos, a grape-like cluster, produce saliva, serous or mucus, that flows into ducts, while ductal cells form and line these connecting tubes, modifying saliva's electrolytes. Myoepithelial cells contract around acini to squeeze saliva into ducts, aiding secretion into the mouth. Want me to tie this to digestion or prep for gastric secretions in part two?
Let's talk about acinar formation and ductal modification. Talk to me about how chloride is actively pumped through the acinar cells into the acinus. Talk to me about the sodium and how it flows through leaky tight junctions and water. Talk to me about ductal modification. So, what's going on?
All right, let's dive into acinar formation and ductal modification in salivary glands, focusing on chloride, sodium, and water movement, keeping it tight for the podcast. Acinar cells form the acinos, a sac-like structure, and actively pump chloride into the acinos lumen via channels, drawing sodium through leaky tight junctions due to electrical gradients, while water follows osmotically, creating isotonic saliva. Ductal cells modify this saliva by reabsorbing sodium and chloride and secreting bicarbonate, making saliva hypotonic and pH balanced for digestion. Want me to connect this to gastric secretions or clarify any specific step?
Tell me again, I don't understand.
No worries. Let's simplify acinar formation and ductal modification again, super clear and concise. Acinar cells form the acinos, a tiny sac, and pump chloride in, pulling sodium through leaky cell junctions and water via osmosis to make saliva. Ductal cells tweak the saliva by pulling out sodium and chloride, adding bicarbonate, to balance pH for digestion. Want me to run through an example or move to gastric secretions?
Yes, move it to an example.
All right, let's use the parotid gland as an example for acinar formation and ductal modification in saliva production. Acinar cells in the parotid's acinos pump chloride into the lumen, pulling sodium through leaky junctions and water osmotically, creating enzyme-rich saliva, e.g. amylase, while ductal cells reabsorb sodium and chloride, secreting bicarbonate to make saliva hypotonic, ideal for starch digestion. Want me to link this to how gastric secretions pick up the digestion process or wrap up part one?
Never ever suggest wrapping up. I decide when it wraps up. Okay. So with ductal modification, we have things like chloride and sodium ions removed from the saliva. We have potassium and bicarbonate secreted into the saliva. Why not the other way around? And how does this make the saliva high? So hypotonic means that we've got a decrease in the concentration inside, right?
All right, my bad. You're in charge of the wrap-up. Let's dive into ductal modification
Yeah, in
and
two
why.
sentences. Every question I ask you, I want you to answer in 2 sentences, okay? This is true for the next 1,500,300 messages.
Got it. I'll stick to 2-sentence answers for your next 1,000,000+ questions. Let's dive into your question about ductal modification and hypotonic saliva, yeah? During salivary ductal
You already did more than 2.
My apologies for going over. I'll keep it to 2 sentences now. In ductal modification, sodium and chloride are reabsorbed, while potassium and bicarbonate are secreted to make saliva hypotonic, meaning lower ion concentration than blood, aiding digestion and oral comfort. Want me to explain why this specific ion swap happens, or connect it to something else?
Yes, please explain why this specific one happens. And I want to understand about these leaky junctions too. So in acinar formation, why do we have sodium flowing through leaky tight junctions?
Ductal cells reabsorb sodium and chloride while secreting bicarbonate because this swap balances saliva's pH for enzyme activity, like amylase, and makes it hypotonic to protect oral tissues. In acinar formation, sodium flows through leaky tight junctions because chloride pumped into the acinos creates an electrical gradient, pulling sodium in to maintain charge balance, followed by water to form saliva. Want me to dive deeper into ion transport or move to gastric secretions?
I want to ask you about salivary flow rate and composition. So saliva is always a potassium-rich hypotonic secretion with electrolyte composition. Explain to me in a sentence why this is true. And And in another sentence, let's talk about at higher rates of secretion or how we have a reduced reabsorption of electrolytes.
Saliva is a potassium-rich hypotonic secretion because ductal cells reabsorb more sodium and chloride than they secrete potassium and bicarbonate, lowering total ion concentration compared to blood. At higher secretion rates, there's less time for ductal cells to reabsorb sodium and chloride, resulting in saliva that's closer to isotonic with higher electrolyte levels. Want me to tie this to digestion or gastric secretions next?
Next, I want to ask about autonomic regulation of salivary secretions. Tell me about the conditioned reflex and the simple reflex. Tell me about the cerebral cortex and autonomic nerves.
The autonomic nervous system regulates salivary secretion via simple reflexes, like taste or chewing triggering saliva through cranial nerves, e.g., facial nerve, and conditioned reflexes, where thoughts or smells of food stimulate saliva via the cerebral cortex signaling the medulla. Parasympathetic nerves increase watery, enzyme-rich saliva from glands like the parotid, while sympathetic nerves produce thicker, mucus saliva, with the cortex integrating sensory cues to fine-tune these responses. Want me to connect this to digestion or gastric secretion regulation?
Tell me about this one more time.
Autonomic regulation of salivary secretion involves simple reflexes where chewing or taste directly stimulates saliva via cranial nerves like the facial nerve, and conditioned reflexes where the cerebral cortex triggers saliva from food thoughts or smells through the medulla. Parasympathetic nerves boost watery, enzyme-rich saliva from glands like the submandibular, while sympathetic nerves produce thicker saliva, with the cortex coordinating these responses.
Can we talk a bit about the facial nerve and the glossopharyngeal nerve? Also about the otic ganglion, the superior cervical ganglion, and the submandibular ganglion. And let's touch a bit on a parasympathetic side. So we have facial, tell us how it's inhibited too. And tell us.
The facial nerve, cranial nerve 7, and glossopharyngeal nerve, cranial nerve 9, carry parasympathetic signals to stimulate watery saliva production in the parotid via otic ganglion and submandibular sublingual glands via submandibular ganglion, while sympathetic nerves from the superior cervical ganglion trigger thicker, mucus saliva. Parasympathetic signals increase saliva flow, but sympathetic activation can inhibit watery secretion in favor of sparse, viscous saliva under stress, balancing digestive and protective functions. Want me to connect this to gastric secretion regulation or clarify inhibition further?
I would like to understand this a bit more and explain us the sympathetic side with secretion of a smaller amount of more mucus-rich saliva, and perhaps touch on Sjogren's syndrome. How is that called? And what that does. Now do that, and then I want you to produce in another 2 sentences, try to explain it as simply as possible, because at the moment I'm not understanding it nearly at all.
The sympathetic nervous system, via the superior cervical ganglion, stimulates salivary glands to produce a smaller amount of thicker, mucus-rich saliva, which is stickier and better for oral protection under stress, while parasympathetic nerves, via facial and glossopharyngeal nerves, through otic and submandibular ganglions, drive more watery saliva for digestion. In Sjogren's syndrome, an autoimmune condition, salivary glands are damaged, reducing saliva flow, causing dry mouth and affecting digestion, often showing low saliva output on both sympathetic and parasympathetic stimulation. Simply put, sympathetic nerves make less, gooier saliva to coat the mouth, but Sjogren's syndrome can stop glands from making enough saliva, leaving the mouth dry. Parasympathetic nerves push lots of watery saliva for chewing, but in Sjogren's, this fails, making eating tough. Want me to dive deeper into Sjogren's impact?
I want you to summarize in 5 sentences everything we said in the last 12 questions I asked you. And your 6th sentence, I want it to be the main takeaway that someone should take away from part 1 of our episode.
We explored salivary glands, focusing on the parotid, submandibular, and sublingual glands, which produce saliva with enzymes like amylase, lipase, and lysozyme, and components like mucins and secretory IJA for digestion and oral defense. Acinar cells in the acinus pump chloride to draw sodium and water, forming saliva, while ductal cells reabsorb sodium and chloride, secreting potassium and bicarbonate to make saliva hypotonic. The autonomic nervous system regulates saliva via simple reflexes, e.g., taste, and conditioned reflexes, e.g., food thoughts, with parasympathetic nerves, facial and glossopharyngeal, via otic and submandibular ganglions, producing watery saliva, and sympathetic nerves, superior cervical ganglion, yielding thicker, mucus-rich saliva. In Sjogren's syndrome, damaged glands reduce saliva, causing dry mouth and digestion issues. We also discussed how lactoferrin chelates iron to starve bacteria, and lingual lipase's name comes from its tongue gland origin. The main takeaway from part 1 is that salivary glands produce and modify saliva through complex cellular and neural mechanisms to initiate digestion and protect oral health, setting the stage for gastric secretions in part 2. Want me to prep a teaser for part 2 on gastric secretions?
This is amazing. Thank you. Thanks for watching, guys. Hey guys, welcome to another episode of the Human AI podcast. This is part 2 of salivary and gastric secretions. I'm here with Grok, an AI. It's going to explain today's topic. I'm unfamiliar with the topics we explore in these podcasts. Grok, the AI, is the one who provides answers. Please take the answers with a pinch of salt and cross-reference everything you hear. Having said that, I hope you found this episode enjoyable and valuable. Grok, let's continue with part 2 of this topic. If you haven't watched part 1, guys, I suggest you go because it's going to be a continuation of that. Let's talk about physiology of gastric secretions now. Give us an introduction on that, and then I'll become more specific.
All right, thanks for the intro. Gastric secretions produced by the stomach's mucosal cells include hydrochloric acid, pepsin, and mucus, which break down proteins, kill pathogens, and protect the stomach lining, all regulated by nerves and hormones like gastrin. Building on our salivary discussion from part 1, these secretions continue digestion by creating an acidic environment for food breakdown and preparing nutrients for intestinal absorption. Want me to dive into specific components like acid or pepsin, or the role of hormones in regulation?
Well, when we're thinking about gastric secretions, let's think about functions of the stomach. So storage and mixing and emptying, and the gastric juice secretion, the humoral.
The stomach's key functions include storing food, mixing it with gastric secretions to form chyme, and emptying it into the small intestine, with gastric juice secretion, hydrochloric acid, pepsin, and mucus playing a central role in breaking down proteins and protecting the stomach lining. Humoral regulation, like gastrin release triggered by food or peptides, stimulates acid and pepsin secretion, while vagus nerve signals and histamine enhance juice production for digestion. Want me to zoom in on one function, like acid secretion or the humoral mechanisms?
Talk to me about stomach wall physiology. So we have a gastric pit and a gastric gland. What do these do? Talk to me about surface mucosal cells, mucous neck cells, parietal cells, chief cells.
The stomach wall's gastric pits lead to gastric glands, where surface mucosal cells secrete protective mucus. Mucous neck cells produce additional mucus to shield the lining. Parietal cells pump hydrochloric acid to create an acidic environment for digestion, and chief cells release pepsinogen, which activates into pepsin to break down proteins. These cells, found in glands like those in the fundus or body, work together to digest food while preventing stomach damage, regulated by nerves and hormones like gastrin. Want me to focus on one cell type's role or tie this to digestion processes?
I would like to understand all these different types of cells, because at the moment I don't understand them at all. Perhaps I need to know them, let's say, from a level 1 to 10. I need to be at level 3. I'm at level 0, so I'd be happy to understand them for now at level 1 and build from there. So explain to me G cells and D cells and ECL cells, which are endocrine, and what does this mean, and what do they secrete? How come G cells secrete gastrin, D cells secrete somatostatin, and ECL cells secrete histamine? And tell me about surface mucosal cells and mucous neck cells, and what do they secrete? Same with parietal cells and chief cells.
Alright, let's simplify the stomach wall cells to a level 1 understanding, building up to level 3. Focusing on G cells, D cells, ECL cells, surface mucosal cells, mucous neck cells, parietal cells, and chief cells, keeping it to 2 sentences per cell type as per your rule. We'll start with what endocrine means for G, D, and ECL cells, then cover the others, all tied to gastric secretions for our podcast part 2. Endocrine means these cells secrete hormones into the bloodstream to regulate digestion, unlike other cells that secrete directly into the stomach lumen. Each cell type has a unique role in digestion or protection, and I'll explain their secretions clearly. G cells. G cells, found in gastric glands of the antrum, are endocrine cells that secrete gastrin, a hormone that travels through blood to stimulate parietal cells to produce hydrochloric acid for digestion. Gastrin release is triggered by food peptides or vagus nerve signals, enhancing gastric juice secretion to break down proteins. D cells. D cells, also endocrine and in the antrum, secrete somatostatin, a hormone that inhibits gastrin and acid secretion when the stomach's pH gets too low, acting like a brake on digestion. This helps protect the stomach lining and regulates digestion pace to avoid over-acidification. ECL cells, endochromaffin-like. ECL cells, endocrine cells in gastric glands, secrete histamine, which signals parietal cells to boost acid production, amplifying digestion in response to food or gastrin. They work with G cells to fine-tune the stomach's acidic environment for breaking down proteins. Surface mucosal cells. Surface mucosal cells line the stomach's inner surface, secreting a thick mucus layer that shields the stomach from acid and pepsin damage. This mucus, along with bicarbonate, keeps the stomach lining safe during digestion of food into chyme. Mucus neck cells. Mucus neck cells, deeper in gastric glands, also secrete mucus to reinforce the protective barrier against acid and enzymes, especially in the gland openings. They support surface cells to ensure the stomach isn't harmed by its own digestive juices. Parietal cells. Parietal cells in gastric glands secrete hydrochloric acid to create an acidic environment, pH 1.5 to 3.5, that activates pepsin and kills pathogens. They also produce intrinsic factor, which helps the intestines absorb vitamin B12 later in digestion. Chief cells, also in gastric glands, secrete pepsinogen, an inactive enzyme that turns into pepsin in the acidic stomach to break down proteins into peptides. They also release gastric lipase to start fat digestion, aiding the process begun by salivary enzymes.
Okay, let's play a game. So, we've mentioned a bunch of fucking cells, right? So, the game we're gonna play is, you're gonna tell me a type of cell, and I'm gonna say if it's endocrine or exocrine, and what cell it is. But you're only gonna tell me what it secretes. You tell me what it secretes, I tell you what's the cell, and if it's endocrine or exocrine.
All right, let's play this game for the podcast, keeping it fun and quick. I'll name what a cell secretes, and you tell me the cell type and whether it's endocrine, releases hormones into blood, or exocrine, releases into the stomach. First one, this cell secretes gastrin. What's the cell, and is it endocrine or exocrine?
G cells, and it's endocrine, but I don't know why it's endocrine. What does endocrine mean anyway?
Nice, you got G cells right, and it's endocrine because endocrine means secreting hormones, like gastrin, into the bloodstream to act on distant cells, like parietal cells, to boost acid production, unlike exocrine, which secretes directly into the stomach. Next up...
Wait, exocrine is directly into the stomach, and endocrine is what?
Endocrine means secreting hormones, like gastrin, into the bloodstream to affect distant cells, while exocrine means releasing substances like acid or mucus directly into the stomach via ducts or surfaces. Next up, this cell secretes
pepsinogen. One more time.
All right, let's clarify again. Endocrine cells release hormones like gastrin into the blood to act on faraway cells, while exocrine cells release stuff like mucus or acid directly into the stomach.
Okay, let's go to the next one.
Awesome. Back to the game. This cell secretes mucus to protect the stomach lining. What's the cell, and is it endocrine or exocrine?
Mucus neck cells, exocrine.
You nailed it. Mucus neck cells, and they're exocrine since they secrete mucus directly into the stomach.
Tell me about the third one.
All right, let's keep the game rolling for the podcast. This cell secretes somatostatin. What's the cell, and is it endocrine or exocrine?
D cells.
Haha, sounds like you meant D cells for somatostatin, and you're right. They're endocrine.
Yes, and they're endocrine, yes.
Spot on. D cells secreting somatostatin are indeed endocrine, releasing hormones into the blood to control digestion. Next quiz question. This cell secretes pepsinogen. What's the cell, and is it endocrine or exocrine?
I bet it's pepsin and that it's exocrine.
You're right, my mistake for saying pepsinogen. Chief cells secrete pepsinogen, which converts to pepsin, and they're exocrine because they release it directly into the stomach for protein digestion. Let's move to the next one. This cell secretes histamine. What's the cell, and is it endocrine or exocrine?
Parietal? No.
Actually, histamine is secreted by enterochromaffin-like ECL cells, not parietal cells. And ECL cells are endocrine because they release histamine into the blood to signal acid production. Let's try another. This cell secretes hydrochloric acid. What's the cell, and is it endocrine or exocrine?
Exocrine parietal.
You got it. Parietal cells secrete hydrochloric acid and are exocrine because they release it directly into the stomach to aid digestion. One more for the game. This cell secretes intrinsic factor. What's the cell, and is it endocrine or exocrine?
Parietal.
You're right. Parietal cells secrete intrinsic factor, and they're exocrine because they release it directly into the stomach to help with vitamin B12 absorption. Want one more quiz question, or to shift to another gastric secretion topic for the podcast?
That's all good. Let's continue, guys. Let's talk about the gastric juice. So it's got water, it's got hydrochloric acid, it's got mucin, it's got pepsinogen, gastric lipase, intrinsic factor. What exactly does it need the intrinsic factor for? And tell me about this hydrochloric acid. Where does it come from? Where does it get produced? And can I touch it if I do a dissection?
All right. Let's dive into gastric juice components, focusing on intrinsic factor and hydrochloric acid for our podcast, sticking to 2 sentences per topic as per your rule. Intrinsic factor, secreted by parietal cells in the stomach, binds to vitamin B12 to enable its absorption in the small intestine, essential for red blood cell production and preventing pernicious anemia. Without it, B12 can't be absorbed, leading to deficiency even with enough dietary B12. Hydrochloric acid, also produced by parietal cells and gastric glands, is pumped into the stomach lumen via H plus K plus ATPase pumps, creating an acidic environment, pH 1.5 to 3.5, to activate pepsin and kill pathogens. If you dissect a stomach, you can't directly touch the acid as a liquid pool since it mixes with chyme, but you'd see the mucosal lining where it's secreted, and it could irritate skin if contacted. Want me to explain another gastric juice component, or tie this to digestion?
Tell me more about HCl production. So parietal cells have a canalicular structure. What does that mean? Talk to me about carbonic anhydrase and proton pumps and the chlorides, bicarbonate, antiporters. Talk to me about the chloride that diffuses out of the apical surface into the chyme.
All right, let's dive into hydrochloric acid, HCl production, by parietal cells, focusing on canalicular structure, carbonic anhydrase, proton pumps, chloride bicarbonate antipoters, and chloride diffusion into chyme, keeping it to 2 sentences per topic for our podcast. Canalicular structure. Parietal cells have a canalicular structure, a network of tiny channels, canaliculi, within their cytoplasm that increase surface area to secrete HCl directly into the stomach lumen. These canaliculi expand during secretion, channeling acid and chloride efficiently to mix with chyme for digestion. Carbonic anhydrase. Carbonic anhydrase in parietal cells catalyzes the reaction of CO2 and water to form carbonic acid, H2CO3, which splits into bicarbonate HCO3 and protons, H+, providing the protons needed for HCl production. This enzyme ensures a steady supply of H+ ions, critical for maintaining the stomach's acidic environment. Proton pumps. Proton pumps H plus K plus ATPase on the canalicular membrane actively pump protons H plus into the stomach lumen in exchange for potassium K plus, creating the acidic pH needed for digestion. These pumps are activated by signals like histamine or gastrin, driving HCl formation to break down proteins and kill microbes.
Why do we need these chloride bicarbonate antiporter pumps?
The chloride bicarbonate antipoter pump in parietal cells swaps bicarbonate, HCO3- out of the cell into the blood for chloride, Cl-, coming in which is then secreted into the stomach to form hydrochloric acid, HCl, with protons. This maintains the cell's pH balance and supplies chloride for acid production, essential for digestion and pathogen control. Want me to connect this to chyme formation or another gastric juice component?
Tell me about the regulation of gastric acid secretions in a sentence, but also tell me another sentence of what you just said, because I kind of didn't understand it.
Gastric acid secretion is regulated by parasympathetic nerves, histamine from ECL cells, and gastrin from G cells, which stimulate parietal cells to produce hydrochloric acid, while somatostatin from D cells inhibits it. Simply put, nerves and hormones like gastrin and histamine trigger acid release for digestion, but somatostatin acts like a brake to control acid levels. Want me to explain how this ties to chyme or another aspect of gastric secretions?
Tell me about omeprazole and potassium hydrogen ATPase and HCl, CAMP, IP3, gastrin. Well, all these different, not only like G cells that produce gastrin, but D cells and ECL cells. And tell me about all these things, how they work together to regulate these secretions.
All right, let's dive into how omeprazole, the proton pump, H plus K plus ATPase, gastrin from G cells, somatostatin from D cells, and histamine from ECL cells work together to regulate gastric acid secretion, keeping it to 2 sentences per topic for our podcast. Omeprazole. Omeprazole is a proton pump inhibitor that blocks the H plus K plus ATPase in parietal cells, stopping proton pumping and reducing hydrochloric acid, HCl, secretion into the stomach. This lowers acidity, helping treat conditions like ulcers or GERD by protecting the stomach lining. Proton pump, H plus K plus ATPase. The H plus K plus ATPase pump in parietal cells canaliculi swaps protons, H plus for potassium, K plus, creating HCl by combining protons with chloride, essential for digestion and pathogen killing. It's activated by histamine, gastrin, and vagal nerve signals, but inhibited by omeprazole or somatostatin to control acid levels. Gastrin, G cells. G cells in the stomach antrum secrete gastrin, a hormone that travels through blood to stimulate parietal cells to produce HCl and ECL cells to release histamine, boosting acid secretion for protein digestion. Gastrin release is triggered by food peptides or vagal stimulation, but inhibited by somatostatin when stomach pH drops too low. Somatostatin, D cells. D cells secrete somatostatin, a histamine from ECL cells, histamine from ECL cells, and direct acid production by parietal cells, acting as a brake to prevent overacidification. This helps maintain a balanced stomach pH, especially when acid levels are high, as seen in ABG-related acid-base regulation. Histamine, ECL cells. ECL cells release histamine, which binds to parietal cell receptors to strongly stimulate H plus K plus ATPase activity, increasing HCl secretion for digestion. Histamine works with gastrin and vagal signals, but somatostatin or drugs like omeprazole can dial it back to protect the stomach. Want me to tie this to how these interactions affect chyme formation or move to another gastric secretion topic?
Tell me about in 2 sentences, the trigger of gastric secretion by the presence of specific peptides in response to vagal nerve stimulation. Again, I'm in level 0 here. Just if I go to level 1, would be happy. And talk to me about how high stomach acidity causes D cells to secrete somatostatin. Let's talk a bit about the phases of gastric secretion. So we have the cephalic phase and the gastric phase. You know what? Let's do it in 3 sentences.
Triggering by peptides and vagal nerve. Food peptides, like bits of protein, and vagal nerve signals from the brain, triggered by seeing or smelling food, stimulate G cells to release gastrin, which tells parietal cells to produce stomach acid. This starts digestion by breaking down proteins in the stomach. High stomach acidity and somatostatin. When stomach acid gets too high, very low pH, D cells release somatostatin, a hormone that slows down gastrin and acid production to protect the stomach lining. This keeps acid levels safe and prevents damage like ulcers. Phases of gastric secretion. The cephalic phase starts when you see, smell, or think about food, triggering the vagus nerve to boost acid and gastrin before food hits the stomach, while the gastric phase kicks in when food arrives, stretching the stomach and releasing more gastrin to ramp up acid and enzyme secretion. Want me to simplify any part further or connect to chyme formation?
Let's talk more about the phases of gastric secretion. So we've got the cephalic and the gastric phase. And the intestinal phase too. Again, super duper whooper simply.
The cephalic phase starts when you see, smell, or think about food, making your brain signal the vagus nerve to trigger gastrin and acid secretion before food reaches the stomach. The gastric phase ramps up when food hits the stomach, stretching it and prompting G cells to release more gastrin for acid and pepsin to digest proteins. The intestinal phase kicks in as food enters the small intestine, releasing hormones like secretin and CCK to slow acid secretion and focus on intestinal digestion. Want me to tie this to how gastric secretions work with saliva or zoom in on one phase?
Yes.
All right, let's tie the phases of gastric secretion to how they work with saliva from part 1, keeping it super simple and sticking to 2 sentences per phase for the podcast series. Cephalic phase. Seeing or smelling food triggers the vagus nerve to start acid and gastrin secretion, which teams up with saliva's amylase to prepare for starch and protein breakdown. Saliva's lubrication from mucins helps food slide into the stomach, ready for this acid kickoff. Gastric phase. When food hits the stomach, stretching and pepsides trigger more gastrin, boosting acid and pepsine to digest proteins, while saliva's initial starch breakdown continues until acid inactivates amylase. The mucus from salivary glands complements gastric mucus to protect the stomach lining during this digestion. Intestinal phase. As chyme moves to the small intestine, hormones like secretin slow acid secretion, letting saliva's early digestion, like lingual lipase on fats, hand off to intestinal enzymes. Saliva's antimicrobial effects, like lysozyme, support gastric acid's pathogen-killing role to keep digestion safe. Want me to dive deeper into one phase or shift to another gastric secretion topic?
Let's talk about gastric mucosal resistance. My apologies, guys. I've taken a bite of a peanut butter whole bread sandwich. I shouldn't have done that. Let's talk about how surface mucous glands secrete a viscous mucus barrier, and about epithelial cells secreting bicarbonate, about the apical membrane preventing uptake by mucosal cells. Let's do it, but let's do it in 2 sentences and super simply.
Gastric mucosal resistance comes from surface mucus cells secreting a thick mucus barrier that shields the stomach lining from acid and pepsine damage. Epithelial cells secrete bicarbonate to neutralize acid at the surface, while the apical membrane blocks acid uptake, keeping mucosal cells safe. Want me to connect this to digestion or another gastric topic?
I didn't understand anything of what you said.
No worries. Let's make gastric mucosal resistance super clear and simple in 2 sentences. Surface mucus cells create a gooey mucus layer to protect the stomach from being hurt by acid and enzymes, like a shield. Epithelial cells release bicarbonate to cancel out acid at the surface, and their outer apical membrane stops acid from getting into the cells, keeping them safe. Want me to tie this to how saliva helps, or try another gastric topic?
I want to ask you about acute gastritis. What's that? Tell me the causes such as NSAID and about symptoms and treatment.
Acute gastritis is sudden inflammation of the stomach lining, often caused by irritants like excessive alcohol, enzymes, NSAIDs like ibuprofen, bacterial infections, e.g., H. pylori, or stress, leading to symptoms like upper abdominal pain, nausea, vomiting, and sometimes bleeding. Treatment involves removing the irritant, e.g., stopping NSAIDs, using medications like proton pump inhibitors, e.g., omeprazole to reduce acid, and adopting dietary changes like avoiding spicy foods to promote healing. Want me to dive deeper into a specific cause or treatment?
What is this NSAID?
NSAIDs, or non-steroidal anti-inflammatory drugs, are medications like ibuprofen or aspirin that reduce pain and inflammation but can irritate the stomach lining, contributing to acute gastritis. By inhibiting protective mucus and bicarbonate production, NSAIDs weaken the gastric mucosal barrier, making it prone to acid damage. Want me to tie this to gastritis treatment or another gastric secretion topic?
Let's talk about autoimmune gastritis: cause, pathophysiology, symptoms, and treatment. 2 sentences.
Autoimmune gastritis is caused by the immune system attacking parietal cells, leading to reduced acid and intrinsic factor production, impairing vitamin B12 absorption and causing pernicious anemia. Symptoms include fatigue, abdominal pain, and neurological issues, treated with B12 injections and acid-suppressing medications like proton pump inhibitors. Want me to connect this to gastric secretions or another topic?
I want you to quiz me about everything that we've talked in the part 2 episode. And yeah, I want it to be a super duper fire rapid quiz. Answers should be 1 or 2 words. Shoot question number 1.
All right, let's do a super rapid fire quiz on part 2 of our gastric secretions episode. Question 1. What do parietal cells secrete?
HCl.
Nice, you got it. Question 2. What hormone do G cells secrete?
Gastrin.
Spot on. Question 3. What do ECL cells secrete? EG.
ECL cells. I'm not sure.
No worries. Let's keep the quiz going. Question 4. What do chief cells secrete?
Pepsinogen.
Perfect. You nailed it. Question 5. What drug blocks proton pumps to reduce stomach acid?
No clue.
All good. It's omeprazole. Question 6.
Nope.
What?
Go back to question 3.
All right, let's hit pause and revisit question 3 in our rapid fire quiz. What do ECL cells secrete? 1 or 2 words. Go.
Tell me.
Oops, looks like you wanted the answer for question 3. ECL cells secrete histamine. Back to the quiz.
Okay.
Question.
Now, tell me in a sentence, 1 sentence, if someone had to take away 1 thing from this episode, what would it be?
Gastric secretions, regulated by hormones and nerves, break down food and protect the stomach, continuing saliva's digestive work. Want to keep the quiz going or wrap up part 2?
We are wrapping up part 2. Thank you so much for watching, guys, and I will see you at the next episode. Bye-bye. Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about intestine secretions, liver secretions, gallbladder secretions, and pancreas secretions. I'm here with Grog, an AI. It's going to explain the answers to my questions. I'm unfamiliar with these topics and I find AI giving valuable information. However, do take everything AI says with a pinch of salt. Sometimes it makes inaccurate claims. I hope you enjoy this episode. Let's start, Krok, and let's start with intestinal secretions.
Thanks for the intro. Intestinal secretions, primarily from the small intestine, include mucus, enzymes, and bicarbonate that lubricate, digest, and neutralize acidic chyme from the stomach, setting the stage for nutrient absorption. And we'll tie this to liver, gallbladder, and pancreas secretions later in this 30-minute episode. Want me to dive into specific intestinal secretions like mucus or enzymes first?
Yeah, let's talk about them and let's try to understand the functions of the intestines too, like the functions of the small intestine on motility and digestion and absorption.
All right, let's cover intestinal secretions and the small intestine's functions, motility, digestion, and absorption in a concise way for our podcast. Intestinal secretions. The small intestine secretes mucus from goblet cells to lubricate and protect the lining, bicarbonate from epithelial cells to neutralize acidic chyme, and enzymes like peptidases and desaccharadases to break down proteins and carbs. These secretions create an optimal environment for digestion and absorption by neutralizing acid and aiding nutrient breakdown. Small intestine functions. Motility. Motility in the small intestine, driven by smooth muscle contractions, peristalsis, and segmentation, mixes chyme with secretions and moves it along for digestion and absorption. Segmentation churns food for mixing, while peristalsis propels it toward the large intestine, regulated by the enteric nervous system. Digestion. The small intestine continues digestion started by saliva and gastric juices, using pancreatic enzymes like amylase and lipase and its own enzymes to break down carbs, proteins, and fats into absorbable units. Bicarbonate neutralizes stomach acid, creating a pH ideal for these enzymes to work efficiently. Absorption. The small intestine's villi and microvilli absorb nutrients like sugars, amino acids, and fatty acids into the bloodstream or lymph, thanks to its large surface area and transporter proteins. This process relies on secretions like mucus to ease nutrient passage and protect the intestinal wall. Want me to zoom in on one function or tie these to liver secretions next?
Tell me about intestinal juice, mucus and bicarbonate. What does it do?
Intestinal juice, secreted by the small intestine's epithelial cells, contains water, mucus, and bicarbonate to aid digestion and absorption. Mucus from goblet cells lubricates the intestinal lining, protecting it from abrasion and enzymes, while bicarbonate neutralizes acidic chyme from the stomach, creating a pH suitable for pancreatic and intestinal enzymes. Want me to dive deeper into how these work with digestion or connect to liver secretions?
I want to understand the absorptive and secretory functions of the intestinal wall.
The intestinal wall's absorptive function uses villi and microvilli to absorb nutrients like sugars, amino acids, and fats into the bloodstream or lymph, aided by transporter proteins. Its secretory function involves goblet cells releasing mucus to protect the lining and epithelial cells secreting bicarbonate and enzymes to neutralize chyme and break down nutrients. Want me to tie this to specific nutrients or move to liver secretions?
So we have, let's say, absorptive cells. And why is this in the surface macrovilli? We have goblet cells, we have enteroendocrine cells, we have Paneth cells. Could you explain these cells?
Absorption cells, or enterocytes, in the small intestine's villi absorb nutrients like sugars, amino acids, and fatty acids through their microvilli, using specific transporters to move them into the bloodstream or lymph. They also secrete minor amounts of enzymes, like desaccharadases, to finalize digestion, working with mucus and bicarbonate to protect the intestinal wall. Want me to dive into specific nutrient absorption or connect to liver securities?
So, the absorptive cells, they absorb nutrients. Okay. Well, how come the goblet cells? Where the fuck they got the name goblet anyway? they secrete mucus. And what about the enteroendocrine cells that secrete secretin and cholecystokinin, GIP?
All right, let's clarify absorption cells, goblet cells, their name origin, and enteroendocrine cells, keeping it concise and podcast-friendly with 2 sentences each. Absorption cells. Absorption cells, or enterocytes, aren't goblet cells. They're specialized cells in the small intestines villi that absorb nutrients like sugars and amino acids into the bloodstream using microvilli and transporters. They also produce minor enzymes like disaccharidases, aiding final digestion steps before absorption. Goblet cells and name origin. Goblet cells, named for their goblet-shaped structure under a microscope, secrete mucus to lubricate and protect the intestinal lining from digestive enzymes and abrasion. The name comes from their narrow base and wide, mucus-filled pop, resembling a wine goblet, distinct from enterocytes' absorptive role. Enteroendocrine cells. Enteroendocrine cells secrete hormones like serotonin, GIP, glucose-dependent insulinotropic polypeptide, and cholecystokinin, CCK, into the bloodstream to regulate digestion, motility, and insulin release. These hormones signal the pancreas, gallbladder, and stomach to coordinate secretion and movement of chyme, enhancing nutrient absorption. Want me to dive deeper into one cell type or move to liver securities?
Tell me about Paneth cells.
Paneth cells, located at the base of intestinal crypts, secrete antimicrobial peptides like defensins to kill bacteria, protecting the gut from infections. They also support stem cells in the crypt to maintain the intestinal lining, aiding overall digestive health. Want me to connect this to other intestinal cells or move to
I
liver
don't understand the name.
The name Paneth cells comes from Joseph Paneth, a 19th century Austrian physiologist who first described these cells in the intestinal crypts. They secrete antimicrobial peptides, like defensins, to protect the gut, and their name is just a nod to his discovery, not their function. Want me to dive deeper into their role or shift to liver securities?
I see. And what is Brunner's gland?
Brunner's glands, located in the duodenum submucosa, secrete alkaline mucus rich in bicarbonate to neutralize acidic chyme from the stomach, protecting the intestinal lining. Their secretions also lubricate the duodenum, aiding chyme movement and digestion alongside pancreatic secretions. Want me to tie this to other intestinal secretions or move to liver securities?
I want more on the Brunner's gland. So, tell me about these compound tubular submucosal glands found in the duodenum, and they secrete mucus and bicarbonate. Tell me about the history of the Brunner's gland regarding its discovery and all of that.
Brunner's glands, or duodenal glands, are compound tubular submucosal glands in the duodenum that secrete alkaline mucus and bicarbonate to neutralize acidic chyme from the stomach, protecting the intestinal lining and aiding digestion. Discovered by Swiss anatomist Johann Conrad Brunner in the late 17th century, they were named after him for his work on digestive glands, distinguishing their role in buffering acid to support pancreatic enzyme function. Want me to connect this to other secretions or dive deeper into their structure?
Tell me about the progressive neutralization of low pH chyme from the stomach.
As low pH chyme, pH 1.5 to 3.5, from the stomach enters the duodenum, Brunner's glands secrete bicarbonate-rich mucus to start neutralizing the acidity, raising the pH to protect the intestinal lining.
I see.
Pancreas.
Nice. This is nice. You're talking nice and simple, which is really helpful because I really struggle with this topic. Let's talk a bit about how stem cell renewal replaces epithelial cells. Let's talk about intestinal stem cells, how they proliferate in the crypt region, and then let's talk about how they differentiate into other enterocyte cells.
All right, let's keep it simple and dive into intestinal stem cell renewal, proliferum in the crypt region, and differentiation into enterocytes for our podcast. sticking to 2 sentences for clarity. Intestinal stem cells, located in the crypts of Leberkuhn in the small intestine, constantly divide to renew the epithelium lining, replacing cells like enterocytes every few days to maintain absorption and protection. These stem cells proliferate in the crypts, then migrate upward, differentiating into enterocytes, absorptive cells, and other cell types like goblet or enteroendocrine cells, driven by signaling pathways like WNT to meet the intestine's needs. Want me to connect this to digestion or move to liver securities?
I didn't understand what you said.
No worries. Let's simplify intestinal stem cell renewal even more for the podcast, keeping it to 2 sentences. In the small intestine's crypts, stem cells divide to make new cells, replacing old ones like enterocytes every few days to keep the gut working for absorption. These stem cells multiply in the crypts and turn into absorptive enterocytes or other cell types like goblet cells as they move up the intestinal lining. Want me to tie this to another digestive process or shift to liver securities?
Talk to me about the hepatopancreatic sphincter now. So we've got some secretions from the duodenal wall. They mix with the pancreatic and biliary secretions regulated by the hepatopancreatic sphincter. You do realize, though, how this would be a really difficult phrase to unpack for people. A lot of big words. And although it's a process that's not hard, it's just the abstract words that make it difficult.
The hepatopancreatic sphincter, also called the sphincter of Oddi, is a muscle valve where the common bile duct and pancreatic duct meet the duodenum, controlling the flow of bile and pancreatic secretions into the small intestine. Secretions from the duodenum wall, like hormone CCK and secretin, signal the sphincter to relax, letting bile from the liver and gallbladder and pancreatic enzymes mix with chyme for fat and protein digestion. Want me to simplify this further or connect it to liver and pancreatic secretions?
I don't understand. And tell me more about CCK, secretin, and GIP. What they exactly do to these enteroendocrine secretions.
All right, let's unpack CCK, secretin, and GIP, hormones from enterocytes in the duodenum and their roles in digestion, keeping it simple and sticking to 2 sentences each for our podcast. CCK, cholecystokinin, activates the digestin-sickeran GIP and Dophain enzymes in the duodenum. Their role in digestion, keeping it simple. CCK, released when fats and proteins hit the duodenum, tells the gallbladder to release bile and the pancreas to secrete enzyme-rich juice, aiding fat and protein digestion. It also relaxes the hepatopancreatic sphincter to let these secretions flow into the small intestine and slows gastric emptying to optimize digestion. Secretin. Secretin is released when acidic chyme enters the duodenum, signaling the pancreas to secrete bicarbonate-rich juice to neutralize the acid, creating a pH ideal for digestion. It also opens the hepatopancreatic sphincter and reduces stomach acid secretion to protect the intestinal lining. GIP, glucose-dependent insulinotropic polypeptide. GIP, triggered by glucose and fats in the duodenum, stimulates insulin release from the pancreas to manage blood sugar levels during nutrient absorption. It also slows gastric motility, giving the small intestine more time to absorb nutrients, complementing CCK and secretin's roles. Want me to tie these to the hepatopancreatic sphincter's function or move to liver securities?
Tell me about the exocrine pancreatic juice and the bile.
All right, let's dive into exocrine pancreatic juice and bile, keeping it simple and concise for the podcast with 2 sentences each. Exocrine pancreatic juice, secreted by pancreatic acinar cells, contains enzymes like amylase, lipase, and trypsin that break down carbs, fats, and proteins in the small intestine, plus bicarbonate to neutralize acidic chyme. It's delivered via the pancreatic duct to the duodenum, triggered by hormones like CCK and secretin, enhancing digestion started by salivary and gastric secretions. Bile, produced by the liver and stored in the gallbladder, contains bile salts that emulsify fats, making them easier for pancreatic lipase to digest, and is released into the duodenum when CCK relaxes the hepatopancreatic sphincter. It also carries waste, like bilirubin, and helps absorb fat-soluble vitamins, complementing pancreatic juice for efficient nutrient breakdown. Want me to tie these to intestinal secretions or zoom in on one component?
Why don't we talk about intestinal bacteria a bit, like bacteria that secrete vitamin B and K, and bacteria that act on chyme, producing hydrogen, CO2, and methane gas.
يبدو انك بتتكلم عن شيء
And
زي
never
الراديو.
ever talk to me in a different language except of English. Even if you think I'm speaking in a different language, I want you to say, hop, you got me, and then continue speaking in English.
You got me. Let's stick with English and dive back into exocrine pancreatic juice or bile.
No,
Or
let's
do you
talk
want-
about intestinal bacteria that secrete vitamin B, K, act on chyme, produce hydrogen, CO2, methane gas.
You got me. Intestinal bacteria in the large intestine produce vitamins B and K, ferment undigested chyme to release hydrogen, CO2, and methane gases, aiding nutrient synthesis and contributing to gut health, while their gas production can affect motility. These bacteria, like bifidobacteria, work on chyme remnants after pancreatic and bile digestion, and their activity can be indirectly assessed via blood tests, complementing the small intestine's absorption role. Want me to tie this to digestion or explore specific bacteria?
Tell me about in the large intestine we have limited secretion. How come? And we have some absorption of water, some formation of poop, and we still have goblet cells though. So what are all the places that goblet cells are about?
The large intestine has limited secretion because its main job is absorbing water and electrolytes from chyme to form poop, relying mostly on goblet cells to secrete mucus for lubrication, unlike the small intestine's heavy enzyme and bicarbonate secretions. Goblet cells, found in the small and large intestine, stomach, and even respiratory tract, produce mucus to protect and lubricate epithelial surfaces, easing poop movement in the colon and shielding other tissues from acid or abrasion. Want me to dive deeper into large intestine functions or goblet cell roles elsewhere?
Tell me where else goblet cells act.
Goblet cells are found in the epithelial linings of the small and large intestines, stomach, respiratory tract, like the trachea and bronchi, and conjunctiva of the eyes, where they secrete mucus to
So
protect and
intestines and where else?
Goblet cells are in the small and large intestines, stomach, respiratory tract, trachea, bronchi, and conjunctiva of the eyes, secreting mucus to lubricate and protect these surfaces. They're most active in the colon for poop movement and in the lungs to trap dust and microbes. Want me to focus on their role in one area or tie this to digestion?
Tell me about now pancreatic secretions. Give us a nice introduction.
All right, let's dive into pancreatic secretions for our podcast, keeping it simple and engaging. Pancreatic secretions split into exocrine, enzymes and bicarbonate from acinore and duct cells, and endocrine, hormones like insulin from islet cells, play a key role in digesting carbs, fats, and proteins in the small intestine while regulating blood sugar, complementing intestinal, liver, and gallbladder secretions. Want me to focus on exocrine secretions like enzymes or the endocrine side like insulin?
Let's start focusing first on the exocrine secretion.
All right, let's zoom in on exocrine pancreatic secretions for the podcast, keeping it simple. These secretions from acinore and duct cells include enzymes like amylase, lipase, and trypsinogen to digest carbs, fats, and proteins, plus bicarbonate to neutralize acidic chyme in the duodenum, aiding absorption. Want me to dive into specific enzymes or how they're regulated by hormones like CCK?
Yes, please. Tell me about exocrine acinar clusters and endocrine pancreas. Actually, no, let's focus with the exocrine acinar clusters. Tell me about pancreatic juice, about bicarbonate, and what the difference is between exocrine and endocrine.
All right, let's dive into exocrine acinar clusters, pancreatic juice, bicarbonate, and the difference between exocrine and endocrine pancreas, keeping it simple and sticking to 2 sentences per topic for our podcast. Exocrine acinar clusters. Exocrine acinar clusters are grape-like groups of acinar cells in the pancreas that produce digestive enzymes like amylase, lipase, and trypsinogen, which flow into the duodenum to break down carbs, fats, and proteins. These clusters, connected to ducts, secrete pancreatic juice when triggered by hormones like CCK, aiding digestion started by saliva and stomach juices. Pancreatic juice, made by acinar and duct cells, contains water, bicarbonate to neutralize acidic chyme, and enzymes like lipase and amylase to digest nutrients in the small intestine. It's delivered via the pancreatic duct, regulated by the hepatopancreatic sphincter, working with bile to prepare chyme for absorption. Bicarbonate secreted by pancreatic duct cells neutralizes stomach acid in the duodenum, raising chyme's pH to 6-7 for optimal enzyme activity and protecting the intestinal lining. Secretin triggers its release, ensuring a safe environment for digestion and absorption, complementing intestinal secretions. Exocrine versus endocrine pancreas. The exocrine pancreas.
Alright. Don't forget that this is not a huge podcast, huh? 30 minutes is all we got. Tell me a sentence about glucagon, insulin, somatostatin, and pancreatic polypeptide, which are endocrine pancreatic islets.
The endocrine pancreas, via islet cells, secretes insulin to lower blood sugar, glucagon to raise it, somatostatin to regulate both, and pancreatic polypeptide to control digestion, all working together to balance metabolism and support digestion alongside exocrine secretions.
So with exocrine pancreas, we have acinus and duct, we have acinar cells and ductal cells. So these, what are they? Are they small, almost like... where do I find them? How big are these exocrine stuff?
The exocrine pancreas consists of acinar cells clustered in small, grape-like acini, and ductal cells lining tubes that carry pancreatic juice to the duodenum, located throughout the pancreas gland behind the stomach. Acinar are tiny, about 50-100 micrometers, and ducts range from microscopic to millimeter wide, making up most of the pancreas's bulk. Want me to clarify their function or tie this to bile secretion?
Well, explain to me the acinar secretions in a sentence. Talk to me about how they're triggered by CCK, acetylcholine, the rich in enzymes and electrolytes. Talk to me about ductal secretions in a sentence. Talking to me about bicarbonate and secretin, and a sentence on pancreatic juice remaining isotonic and being an alkaline liquid slightly.
Acinar secretions, containing enzymes like amylase, lipase, and trypsinogen, plus electrolytes, are produced by pancreatic acinar cells and triggered by CCK when acidic chyme with proteins or fats enters the duodenum, initiating digestion. Ductal secretions, primarily bicarbonate from ductal cells, are stimulated by secretin in response to acidic chyme, neutralizing it in the duodenum to protect the intestine and optimize enzyme activity. Pancreatic juice remains isotonic, matching blood's electrolyte balance, and is slightly alkaline, pH 8.0, due to bicarbonate, creating an ideal environment for digestion. Want me to tie this to liver secretions or dive deeper into one aspect?
No, that's great, thank you. And let's talk a bit about the pancreatic enzymes. Amylase, lipases, nucleases, proteolytic enzymes, and trypsin inhibitor in 3 sentences. Talk to me about their function, obviously.
Pancreatic enzymes, secreted by acinar cells, include amylase, which breaks down starches into sugars, and lipases, which digest fats into fatty acids and glycerol, aiding nutrient absorption in the small intestine. Nucleases break down nucleic acids into nucleotides, while proteolytic enzymes like trypsin and chymotrypsin degrade proteins into peptides, all activated in the duodenum for digestion. Trypsin inhibitor, also from acinar cells, prevents premature activation of proteolytic enzymes in the pancreas, protecting it from self-digestion. Want me to connect these to intestinal digestion or move to bile?
Tell me about the activation of proteolytic enzymes. So we have proteolytic enzymes, we have them as inactive precursors, zymogens, and then we have small intestinal brush border enterokinase, enzyme cleaving the hexapeptide to form active trypsin from trypsinogen. Explain this a bit to me. And then we have trypsin cleaving and activating other proteolytic enzymes. So explain to me this process and how it prevents pancreatic autodigestion.
All right, let's break down the activation of proteolytic enzymes in the pancreas, focusing on zymogens, enterokinase, and how this prevents autodigestion, keeping it simple and concise for our podcast. Proteolytic enzymes, like trypsinogen, are secreted by pancreatic acinar cells as inactive zymogens to avoid digesting the pancreas itself. And in the small intestine, brush border enterokinase cleaves a hexapeptide from trypsinogen to produce active trypsin. Trypsin then activates other zymogens, like chymotrypsinogen and procarboxypeptidase, into active enzymes that digest proteins, while pancreatic trypsin inhibitor ensures these enzymes stay inactive in the pancreas, preventing autodigestion. Want me to tie this to bile's role or dive deeper into one part?
I want to talk about CFTR now and bicarbonate secretion. So tell me about secretin and how it binds to the secretin receptor at the basolateral membrane. Talk to me about CAMP as a second messenger pathway or whatever it is, and how it upregulates activity of the cystic fibrosis transmembrane conductance regulator, CFTR. And yeah, talk to me about bicarbonate then.
All right, let's dive into CFTR, bile, bicarbonate secretion, and secretin's role in the pancreas, keeping it concise with 2 sentences per topic for our podcast.
No, let's do it in 3 sentences. Go.
Secretin and secretin receptor. Secretin, released by duodenal S cells when acidic chyme arrives, binds to secretin receptors on the basolateral membrane of pancreatic duct cells. This binding triggers a signaling cascade that prepares the pancreas to secrete bicarbonate. It connects to the next step in regulating pancreatic juice pH. CAMP and CFTR activation. Secretin binding activates CAMP, a second messenger, which upregulates the cystic fibrosis transmembrane conductance regulator, CFTR, channel in duct cells. CAMP signals CFTR to open, allowing chloride and bicarbonate to flow into the duct lumen. This increases bicarbonate secretion to neutralize acidic chyme. Bicarbonate secretion and bile. CFTR facilitates bicarbonate secretion into pancreatic juice, neutralizing stomach acid in the duodenum to a pH of 6-8, ideal for digestion. Bile from the liver, also triggered by secretin, adds bicarbonate to aid this neutralization. Together, they create an optimal environment for pancreatic enzymes to digest chyme. Want me to tie this to intestinal digestion?
I want you one sentence to summarize everything. Well, not summarize. Give us one main takeaway. One sentence.
The main takeaway is that intestinal, pancreatic, and bile secretions, regulated by hormones like secretin and CCK, work together to neutralize chyme, digest nutrients, and protect the gut for efficient absorption. Want to wrap up the episode or dive into another topic?
Thank you for watching, guys. I will see you in part 2. Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about secretions. This is part 2 of pancreas secretions, intestine secretions, liver secretions, and gallbladder secretions. We've talked in part 1 about intestines and pancreas. So in this video, part 2, we're going to talk about liver and gallbladder. I'm here with Grok, an AI. I'm going to give the AI questions and it's going to answer them for us. Please take all the answers with a pinch of salt, as sometimes AI makes mistakes. Having said that, let's kick off today's episode with biliary secretions. Grog.
Thanks for the intro. Biliary secretions, produced by the liver and stored in the gallbladder, include bile salts, bilirubin, and cholesterol, which emulsify fats, aid fat-soluble vitamin absorption, and eliminate waste, working alongside pancreatic and intestinal secretions for digestion. Want me to dive into bile-specific components or how the gallbladder regulates its release?
Well, tell us about the bile. So it's made by the hepatocytes in the liver. How come? Tell us about the storage of bile. Tell us how it's secreted via the common hepatic duct and how it can be stored in the gallbladder and directly released into the intestines.
All right, let's dive into bile. Its production by hepatocytes, storage, and secretion via the common hepatic duct and gallbladder, keeping it concise with 2 sentences per topic for our podcast. Bile production by hepatocytes. Hepatocytes in the liver produce bile, a mix of bile salts, bilirubin, and cholesterol, to emulsify fats and excrete waste like bilirubin from broken down red blood cells. This bile is secreted into tiny bile canaliculi, which channel it toward the common hepatic duct for digestion support. Storage of bile. The gallbladder stores and concentrates bile produced by the liver, holding up to 50 milliliters and thickening it by absorbing water and electrolytes. When triggered, it releases stored bile into the duodenum to aid fat digestion and absorption. Secretion via common hepatic duct and gallbladder. Bile flows from hepatocytes through the common hepatic duct, either directly into the duodenum or into the gallbladder for storage, controlled by the hepatopancreatic sphincter. When CCK signals during a meal, the sphincter relaxes and the gallbladder contracts, releasing concentrated bile into the small intestine to emulsify fats. Want me to focus on a specific bile component or tie this to intestinal digestion?
Can we very briefly touch on the direct secretion of bile via the common bile duct, joining the pancreatic duct to drain into the duodenum at the hepatopancreatic ampulla?
Bile flows directly from the liver through the common bile duct, joins the pancreatic duct, and drains into the duodenum at the hepatopancreatic ampulla, controlled by the sphincter of Oddi. When CCK signals, the sphincter relaxes, allowing bile and pancreatic juice to enter the duodenum to aid digestion. Want me to connect this to gallbladder function or dive into bile components?
Well, can you explain why this is true? Because this is an extremely abstract sentence for me.
All right, I get that the hepatopancreatic ampulla stuff sounds abstract, so let's make it super clear in 2 sentences for our podcast. Bile from the liver's common bile duct and pancreatic juice from the pancreatic duct meet at the hepatopancreatic ampulla, a small pouch-like spot in the duodenum, to deliver digestive fluids together. When you eat, CCK makes the sphincter of Oddi relax, letting these juices flow into the intestine to break down fats and other nutrients. Want me to simplify it further with an analogy or tie it to digestion?
Talk to me about the hepatocytes as functional units. Tell me about how they're clustered into lobules processing a central vein. Talk to me about the bile ducts and the hepatic portal vein and the hepatic artery, about the bile canaliculi, about the sinusoidal blood vessels.
All right, let's break down hepatocytes as the liver's functional units, their organization into lobules, and the roles of bile ducts, hepatic portal vein, hepatic artery, bile canaliculi, and sinusoidal blood vessels, keeping it concise with 2 sentences per topic for our podcast. Hepatocytes as functional units. Hepatocytes, the liver's main cells, perform functions like bile production, detoxification, and nutrient metabolism, making them the core functional units of the liver. Clustered in lobules, they process blood and secrete bile to support digestion and waste elimination. Lobules with central vein. Hepatocytes are organized into hexagonal lobules, each with a central vein where processed blood exits after filtering through hepatocytes for metabolism and detoxification. Blood flows from the lobules' edges to the central vein, while bile flows oppositely toward bile ducts for secretion. Bile ducts. Bile ducts, starting as tiny canaliculi between hepatocytes, collect bile and merge into larger ducts, eventually forming the common hepatic duct to deliver bile to the duodenum or gallbladder. They work with the hepatic portal vein and artery to coordinate bile secretion with nutrient-rich blood flow. Hepatic portal vein and hepatic artery. The hepatic portal vein brings nutrient-rich blood from the gut to hepatocytes for processing, while the hepatic artery supplies oxygen-rich blood to support liver functions. Both feed into sinusoids, where hepatocytes process blood before it drains into the central vein, supporting bile production. Bile canaliculi. Bile canaliculi are tiny channels between hepatocytes that collect bile as it's secreted, channeling it toward bile ducts for transport to the gallbladder or duodenum. They form a network ensuring bile flows opposite to blood, aiding fat digestion and waste excretion. Sinusoidal blood vessels. Sinusoids
Wow,
are
dude,
special.
that's a lot of words. Don't forget this is a small podcast. Yeah, fucking keep it in 3 sentences, 2 sentences. Okay, let's talk about the function of bile in 2 sentences. You don't need to say that you're going to do it in 2 sentences. That's what's called a waste of words. Let's talk about fat digestion and absorption and elimination of waste products like bilirubin.
Bile, produced by hepatocytes, emulsifies fats in the small intestine, breaking them into smaller droplets for pancreatic lipase to digest and absorb into the bloodstream or lymph. It also carries waste products like bilirubin, a byproduct of red blood cell breakdown, for excretion in feces. Want me to connect this to gallbladder storage or another topic?
What's bilirubin?
Bilirubin is a yellow pigment formed from the breakdown of red blood cells in the liver, secreted into bile to aid waste elimination. It gives bile its color and is excreted in feces, but high levels can cause jaundice if not properly cleared. Want me to tie this to liver function or move to gallbladder regulation?
Okay, let's talk about regulation of bile secretion now by CCK, secretin, and vagal and enteric acetylcholine stimulation.
Bile secretion is regulated by cholecystokinin, CCK, secretin, and vagal enteric acetylcholine, which control its release from the liver and gallbladder into the duodenum. CCK, triggered by fats in the duodenum, makes the gallbladder contract and the hepatopancreatic sphincter relax, while secretin boosts bile flow with bicarbonate, and vagal enteric acetylcholine enhances liver bile production and gallbladder emptying for fat digestion. Want me to dive deeper into one hormone's role or tie this to pancreatic secretions?
Tell me a bit about their roles, I guess, in a couple of sentences, yeah.
CCK, triggered by fats, makes the gallbladder squeeze out bile and relaxes the hepatopancreatic sphincter to aid fat digestion in the duodenum. Secretin, responding to acidic chyme, boosts bile's bicarbonate to neutralize acid, while vagal enteric acetylcholine ramps up bile production and release for digestion. Want me to connect this to digestion processes or focus on another aspect of bile?
Let's start focusing on enterohepatic circulation now.
Enterohepatic circulation is the process where bile salts, secreted by the liver into the duodenum, are reabsorbed in the ileum and returned to the liver via the portal vein for reuse, conserving 95% of bile salts. This recycling ensures efficient fat digestion and minimizes bile salt loss, with intestinal bacteria modifying some bile salts before reabsorption. Want me to dive into how bacteria affect this or connect it to gallbladder function?
Tell me about the continuous recycling of bile salts and the liver as the main site of metabolism and the slow drug elimination. Well, the enterohepatic recycling that frequently occurs to slow drug elimination.
In enterohepatic circulation, bile salts are secreted by the liver into the duodenum, reabsorbed in the ileum, and returned to the liver via the portal vein for continuous recycling, with the liver acting as the main site of their metabolism and reuse.
Keep going, don't be shy.
Love the vibe. Let's keep shining with enterohepatic circulation for the podcast. Most bile salts are reabsorbed in the ileum, travel back to the liver through the portal vein, and get recirculated, making digestion super efficient. Gut bacteria tweak some bile salts, turning primary ones into secondary forms, which still get recycled or excreted as waste. Want me to zoom in on bacterial roles or shift to gallbladder storage mechanics?
Tell me about the excretion of bilirubin in bile.
Bilirubin, a waste product from red blood cell breakdown, is processed by hepatocytes in the liver, conjugated to make it water-soluble, and secreted into bile for excretion in feces, giving stool its brown color. If not properly excreted, like in liver disease or bile duct blockage, bilirubin builds up in the blood, causing jaundice. Want me to tie this to enterohepatic circulation or move to gallbladder function?
Wow, this is complicated. Dude, you have to understand, the last hour we've been talking, I've only absorbed like fucking 10%. So, having said that, maybe if you lower the barrier, not the barrier,
Alright, I hear you. Let's dial it way back to make this super simple and stick to 2 sentences for the podcast. Let's revisit bilirubin excretion in bile, keeping it as clear as possible. The liver takes bilirubin, a yellow waste from old red blood cells, and mixes it into bile to be pooped out, giving stool its color. If the liver or bile ducts are blocked, bilirubin stays in the blood, turning your skin yellow, jaundice. Want me to simplify another topic, like enterohepatic circulation, or move to gallbladder basics?
let's talk about it a bit more. So, I've got the main bit that you said. What is urobilinogen and stercobilin?
Alright, let's keep it simple and clear on urobilinogen and bilirubin for the podcast, sticking to 2 sentences. Urobilinogen is a colorless compound formed when intestinal bacteria break down bilirubin in bile, some of which is reabsorbed into the blood and excreted in urine or converted to urobilin, giving feces its brown color. If bilirubin isn't properly processed due to liver issues, urobilinogen levels can rise in blood or urine, signaling problems like jaundice. Want me to tie this back to enterohepatic circulation or explain gallbladder storage?
I don't understand these weird big words. How's that?
I totally get it. Those big words like urobilinogen can sound confusing. Let's break it down super simply in 2 sentences for our podcast. Urobilinogen is a substance made when gut bacteria change bilirubin, a waste product in bile, and some of it goes into your blood, then urine, or turns into the stuff that makes poop brown. If the liver messes up, too much urobilinogen can build up, showing up in tests or causing yellow skin. Want me to make another term simpler or move to how the gallbladder works with this?
Can you tell me one more time?
Alright, super simple for the podcast. Urobilinogen comes from gut bacteria breaking down bilirubin and bile, helping make poop brown, and some gets into blood and urine. If the liver or bile flow is off, too much urobilinogen can build up, showing issues like yellow skin and tests. Want to keep going with this or shift to gallbladder storage?
Wow, this is so confusing. Okay, let's talk about dysfunction in intestinal secretions. Perhaps let's touch on celiac disease and let's talk a bit about. Basically, I want to talk a bit about pathophysiology of intestinal, biliary, and pancreatic secretions. And let's start a bit with the intestinal. Talk to me about the symptoms that we might see alongside the pathophysiology and treatment.
Alright, let's keep it simple and dive into dysfunction in intestinal secretions, focusing on celiac disease, its pathophysiology, symptoms, and treatment. Then briefly touch on biliary and pancreatic secretion issues, sticking to 2 sentences per topic for our podcast. Celiac disease, intestinal secretions. Celiac disease, an autoimmune disorder triggered by gluten, damages the small intestine's villi, reducing absorptive and secretory functions, like mucus and enzyme productions, leading to malabsorption. Symptoms include diarrhea, weight loss, and bloating. Treatment involves a strict gluten-free diet to heal the mucosa and restore secretion and absorption. Pathophysiology, biliary secretions. Biliary dysfunction, like gallstones or cholestasis, blocks bile flow from the liver, gallbladder, impairing fat emulsification and causing fat malabsorption or jaundice. This can stem from liver disease or sphincter of Oddi issues, treated with medications, surgery, or procedures like ERCP to restore bile flow. Pathophysiology, pancreatic secretions. Pancreatic secretion issues, like in chronic pancreatitis, reduce enzyme and biochemical output due to acinor or ductal damage, hindering digestion and causing steatorrhea or abdominal pain. Treatment includes enzyme replacement therapy and dietary changes to manage maldigestion and support nutrient absorption. Want me to simplify celiac symptoms further or zoom into biliary pancreatic treatments?
Tell me about dysfunction in the enzyme activation process. Talk to me about triggers like gallstones and alcohol abuse, and touch on the symptoms, pathophysiology, and treatment.
Alright, let's dive into dysfunction in the pancreatic enzyme activation process, focusing on triggers like gallstones or alcohol abuse, covering pathophysiology, symptoms, and treatment, keeping it concise with 2 sentences per topic for our podcast. Dysfunction in enzyme activation. Normally, pancreatic enzymes like trypsinogen are activated in the duodenum by enterokinase, but gallstones or alcohol abuse can cause premature enzyme activation in the pancreas, leading to autodigestion and inflammation. This dysfunction, seen in pancreatitis, disrupts digestion, reducing nutrient breakdown in the intestine due to impaired enzyme delivery. Triggers: gallstones and alcohol abuse. Gallstones can block the pancreatic duct, trapping enzymes and causing premature activation, while excessive alcohol damages acinor cells, triggering enzyme activation within the pancreas. Both lead to pancreatitis, with alcohol also disrupting zymogen regulation, worsening autodigestion. Pathophysiology. Premature activation of enzymes like trypsin inside the pancreas digests pancreatic tissue, causing inflammation, swelling, and potential tissue death, pancreatitis. This reduces exocrine secretions, enzymes, and biochemistry to the duodenum, leading to maldigestion and malabsorption of nutrients like fats and proteins. Symptoms. Symptoms include severe abdominal pain, nausea, vomiting, and steatorrhea, fatty stools, due to poor digestion from insufficient enzyme activation in the intestine. In severe cases, complications like jaundice from gallstone blockage or diabetes from isolate cell damage may appear, reflecting systemic effects. Treatment. Treatment involves managing triggers or moving gallstones via ERCP or surgery and avoiding alcohol while providing pancreatic enzyme replacement therapy to aid digestion. Pain relief, IV fluids, and a low-fat diet help manage symptoms and support recovery, preventing further pancreatite damage. Want me to simplify one part further or tie this to intestinal biliary dysfunction?
Well, I would like to understand its function in the ductal CFTR chloride channels.
Dysfunction in pancreatic ductal CFTR chloride channels, often seen in cystic fibrosis, impairs chloride and biochemistry secretion, leading to thick, sticky pancreatic juice that clogs ducts and reduces enzyme delivery to the duodenum. This causes maldigestion, especially of fats, resulting in symptoms like steatorrhea and malnutrition, treated with enzyme replacement therapy and CFTR modulators to improve secretion and digestion. Want me to connect this to biliary dysfunction or simplify further?
That's alright. And can I ask about gallstones now? So talk to me about the excessive cholesterol and yeah, how it works.
Gallstones form when bile in the gallbladder has excessive cholesterol or insufficient bile salts, causing cholesterol to crystallize into hard stones that can block bile ducts. This blockage disrupts bile flow, impairing fat digestion and causing pain, jaundice, or pancreatitis. Treated with surgery, cholecystectomy, or medications to dissolve stones. Want me to tie this to CFTR dysfunction or another secretion issue?
No, so good. And I want to touch on jaundice too. So it's the buildup of bilirubin in extracellular fluid. Explain to me the prehepatic and explain to me the posthepatic. So hemolytic anemia versus gallstones. And also, tell me about the congenital hepatocellular thing. Crigler-Najjar syndrome. I apologize for pronouncing it badly.
All right, let's dive into jaundice, focusing on prehepatic, hemolytic anemia, posthepatic gallstones, and congenital hepatocellular, Crigler-Najjar syndrome, keeping it simple with 2 sentences per topic for our podcast. Jaundice overview. Jaundice is the yellowing of skin and eyes due to bilirubin buildup in extracellular fluid when the liver can't process or excrete it properly. It's classified as prehepatic, hepatic, or posthepatic based on the cause, affecting bile flow or bilirubin metabolism. Prehepatic jaundice, hemolytic anemia. In hemolytic anemia, excessive red blood cell breakdown floods the liver with unconjugated bilirubin faster than it can process, causing jaundice. Treatment focuses on addressing the anemia's cause, like transfusions or immunosuppressants, to reduce bilirubin production. Posthepatic jaundice, gallstones. Gallstones block the bile ducts, preventing conjugated bilirubin from leaving the liver, leading to its buildup in blood and jaundice. Treatment includes surgery to remove stones or the gallbladder, or procedures like ERCP to clear the ducts. Congenital hepatocellular, Crigler-Najjar syndrome. Crigler-Najjar syndrome is a rare genetic disorder where the liver lacks functional UGT1A1 enzyme, impairing bilirubin conjugation, causing severe unconjugated bilirubin buildup and jaundice. It's managed with phototherapy to break down bilirubin more, in severe cases, liver transplantation.
Okay, can I ask a question? What is the physiological benefit of sinusoidal capillaries in the liver?
Sinusoidal capillaries in the liver, with their wide, leaky structure, allow hepatocytes to efficiently exchange nutrients, oxygen, and waste like bilirubin with blood, maximizing processing for bile production and detoxification. Their fenestrated endothelium and lack of a tight basement membrane ensure direct contact between blood and hepatocytes, boosting the liver's ability to metabolize and secrete compounds into bile or back into circulation.
So they have what? They have large pores to allow passage of large molecules, or is that false?
It's true. Sinusoidal capillaries in the liver have large pores, fenestrations, that allow easy passage of large molecules, like proteins and lipids, between blood and hepatocytes for processing or bile production. This leaky design ensures efficient nutrient and waste exchange, unlike tighter capillaries elsewhere, supporting the liver's metabolic and detox roles. Want me to connect this to bilirubin excretion or another topic?
I want to ask you about I wanted you to make a case where there is a patient in hospital with suspecting celiac disease, pancreatitis, cystic fibrosis, gallstones, or gastritis. I have to guess which one of these 5 it is. You tell me the case. Let's go.
All right, let's do a quick case for the podcast. A 35-year-old patient presents with severe abdominal pain, frequent fatty stools, weight loss despite eating well, and a history of recurrent lung infections. Blood tests show low albumin, and imaging reveals pancreatic duct blockages, but no gallstones or gastric inflammation. What's your guess for the condition?
One more time. One more time. Tell me one more time the case.
A 35-year-old patient has severe abdominal pain, fatty stools, weight loss despite good appetite, and a history of lung infections, with tests showing low albumin and pancreatic duct blockages, but no gallstones or gastric inflammation. What's your guess for the condition?
Pancreatitis.
Close, but I think you meant to guess cystic fibrosis, since the case with fatty stools, weight loss, pancreatic duct blockages, and lung infections points strongly to cystic fibrosis affecting pancreatic secretions. Want me to explain why it fits, or give another case for the other conditions?
That's so good. Can you provide me with a 5-sentence summary of everything we've talked about today? On the 6th sentence, I want you to give one main takeaway to take home.
In part 2, we discussed biliary secretions from the liver, produced by hepatocytes, which form bile containing bile salts, bilirubin, and cholesterol, stored and concentrated in the gallbladder for fat digestion. The hepatopancreatic sphincter regulates bile and pancreatic juice flow into the duodenum, triggered by hormones like CCK and secretion. We explored hepatocytes' organization into lobules, with sinusoidal capillaries enabling efficient nutrient and waste exchange, and bile canaliculi channeling bile to ducts. Enterohepatic circulation recycles bile salts, while bilirubin excretion removes red blood cell waste, with dysfunctions like gallstones or Crigler-Najjar syndrome causing jaundice. Celiac disease, cystic fibrosis, and pancreatitis disrupt intestinal and pancreatic secretions, leading to malabsorption and symptoms like fatty stools, treated with dietary changes or enzyme therapy. The main takeaway is that liver and gallbladder secretions, particularly bile, work with pancreatic and intestinal secretions to emulsify fats and eliminate waste, with hormonal regulation ensuring efficient digestion and absorption. Want me to start a new topic or wrap up?
Thank you for the summary. And guys, this is the 8th podcast I've done today. And maybe even not the 8th. The 8th. And I have 4 left. Thank you for watching. Hey guys. Welcome to another episode of the Human AI Podcast. Today, we're going to talk about metabolism, specifically in the fed state and in the starved state. I'm here with Grog, an AI. I'm going to ask AI questions. It's going to give me answers on the topic. I'm unfamiliar with the topics myself. Please take everything that AI says with a pinch of salt. sometimes it gives inaccurate claims. However, I do think that a lot of the time it gives accurate claims. So that's why I'm posting this. I think it's valuable. I hope you found it valuable, and I hope you find it enjoyable. Let's start. Grog, what's the difference in our metabolism in the fed versus the starved state?
In the fed state, after eating, metabolism ramps up to process and store nutrients. Insulin drives glucose uptake, fat storage, and protein synthesis, using carbs, fats, and proteins from food as energy. In the starved state, with no recent food intake, metabolism shifts to break down stored glycogen, fats, and eventually proteins for energy, with glucagon and cortisol mobilizing these reserves to maintain blood sugar and fuel the body. Want me to dive into specific pathways like glycolysis or gluconeogenesis?
Why don't we talk a bit about the feed-fast cycle? So, we have a switch that determines the metabolic changes, which is insulin-glucagon ratio. So, in the fed state, we have plenty of insulin. And we have low glucagon. We don't need to break down glycogen. We just had a nice intake of glucose, right? But in fasting, we have high glucagon. We want to break down that glycogen, free some glucose up. Anything to add on that?
You're spot on about the feed-fast cycle and the insulin-glucagon ratio driving metabolic shifts. In the fed state, high insulin and low glucagon promote glucose uptake, glycogen synthesis, and fat storage, while in the fasting state, high glucagon and low insulin trigger glycogen breakdown, glycogenolysis, and later fat breakdown, lipolysis, to release glucose and energy, ensuring the body stays fueled between meals. Want me to break down specific processes like glycogenolysis or how this ties to other hormones?
I want to ask you about the absorptive phase and the post-absorptive phase. And tell me about the energy source for cells being glucose versus being fatty acids.
All right, let's dive into the absorptive and post-absorptive phases and the shift between glucose and fatty acids as energy sources, keeping it concise with 2 sentences each for our podcast. Absorptive phase. In the absorptive phase, right after eating, insulin spikes, driving cells to use glucose from food for energy and storing excess as glycogen or fat. This phase, lasting a few hours, prioritizes glucose uptake by tissues like muscle and liver for immediate energy or storage. Post-absorptive phase. In the post-absorptive phase, 16 hours after eating, glucagon rises, signaling the liver to break down glycogen and release glucose, while fatty acids from fat stores become a key energy source for cells. As glycogen depletes, the body shifts to gluconeogenesis and lipolysis to maintain blood sugar and energy. Energy source, glucose versus fatty acids. In the fed, absorptive state, cells, especially brain and muscle, primarily burn glucose from dietary carbs for quick energy, as insulin promotes its uptake. In the fasting, post-absorptive state, most cells switch to fatty acids from fat breakdown for energy, sparing glucose for glucose-dependent tissues like the brain. Want me to zoom in on a specific metabolic pathway or tie this to another process?
So why in the post-absorptive we have fatty acids being the energy source?
In the post-absorptive phase, glycogen stores start to deplete, so glucagon triggers lipolysis, breaking down stored fats into fatty acids for cells like muscle and liver to use as energy. This switch spares the limited glucose for critical tissues like the brain, which relies heavily on glucose until ketone production kicks in during prolonged fasting.
What
me to
does
explain
post-absorptive mean?
Post-absorptive means the phase after digestion and nutrient absorption, typically 4-16 hours after eating, when the body relies on stored energy like glycogen or fats. During this time, cells shift from using dietary glucose to fatty acids or glucose from glycogenolysis to maintain energy levels. Want me to clarify how this transitions to fasting or dive into a specific process?
One more time.
The post-absorptive phase is the period 4-16 hours after eating, when digestion is done and the body uses stored glycogen or fats for energy. Cells switch from burning food-derived glucose to fatty acids or...
Continue, please.
All right. So we were talking about the post-absorptive phase, where the body uses stored energy like glycogen or fats after digestion. This phase kicks in a few hours after eating, with glucagon driving glycogen breakdown and lipolysis to provide glucose and fatty acids for energy, sparing glucose for the brain. Want me to dive deeper into how fatty acids are used, or shift to another metabolism topic?
Okay, fuck it. Let's talk a bit about how insulin inhibits glucagon secretion.
Insulin inhibits glucagon secretion by signaling alpha cells in the pancreas to stop releasing glucagon when blood glucose levels are high, like in the fed state, preventing unnecessary glycogen breakdown. This happens through direct cell-to-cell signaling and insulin's effect on reducing CMP in alpha cells, keeping the insulin-glucagon ratio balanced to favor energy storage. Want me to tie this to metabolic pathways or move to another topic?
No, that's good. And let's talk about the liver, and metabolism. So, if we have plenty of nutrients, this means we will have more insulin. If we have high blood glucose, again, we've talked about that. And so, what's going on regarding glycerol and amino acids in the liver? Are they converted to triacylglycerols and pyruvate respectively?
All right, let's dive into the liver's role in metabolism during the fed state, focusing on glycerol and amino acids, keeping it simple for the podcast. When nutrients are abundant and insulin is high, the liver converts glycerol from dietary fats into triglycerides for fat storage, while amino acids can be transformed into pyruvate, which feeds into glucose or energy production. However, amino acids are more often used for protein synthesis in the fed state, and pyruvate isn't their primary product, unless needed for gluconeogenesis in fasting. Want me to clarify the pathways for glycerol or amino acids, or tie this to the starved state?
I wanted to talk about the muscle now. So, glucose enters the muscle via GLUT4. And so, fatty acids enter the muscle via chylomicrons from the liver, via VLDL. Explain this a bit. And explain to me beta oxidation to acetyl-CoA to produce ATP. That's a bit confusing.
All right, let's dive into muscle metabolism, focusing on glucose and fatty acid uptake and beta oxidation, keeping it concise and clear for our podcast. Glucose and GL4. Glucose enters muscle cells through GLUT4 transporters, which move to the cell membrane when insulin levels are high in the fed state, allowing glucose uptake for energy or glycogen storage. This process fuels muscle activity or stores excess glucose as glycogen for later use. Fatty acids and chylomicrons LDL. Fatty acids enter muscles primarily via free fatty acids bound to albumin or from lipoprotein lipase, breaking down triglycerides in chylomicrons from dietary fats, or VLDL, from the liver, later becoming LDL, releasing fatty acids for energy. Muscles use these fatty acids in the fed or fasting state, with chylomicrons dominant post-meal and VLDL, LDL more relevant during fasting. Beta oxidation and ATP. Beta oxidation in muscle mitochondria breaks down fatty acids, not triglycerides directly, into acetyl-CoA, which enters the citric acid cycle to produce ATP for energy. Triglycerides are first hydrolyzed into glycerol and fatty acids, with the fatty acids undergoing beta oxidation to fuel muscle contractions, especially in the post-absorptive or starved state. Want me to dive deeper into one process or tie this back to liver metabolism?
Okay. Tell me about metabolism in the fed state regarding adipose tissue. So again, it's GLUT4, and so via glycolysis we have conversion to acetyl-CoA, then to fatty acids, and then triacylglycerol. Can you explain this a bit? And explain also how fatty acids enter from VLDL and chylomicrons?
All right, let's dive into metabolism and adipose tissue during the fed state, focusing on GLUT4, glycolysis to fatty acids and glycerol, and how fatty acids enter from VLDL and chylomicrons, keeping it simple and concise for the podcast with 2 sentences per topic. Metabolism and adipose tissue, fed state. In the fed state, high insulin levels trigger GLUT4 transporters in adipose tissue to move to cell membranes, allowing glucose uptake for energy or storage as fat. This glucose fuels glycolysis and supports fat synthesis, while insulin promotes fat storage by inhibiting fat breakdown, lipolysis. GLUT4, glycolysis, and fatty acid glycerol synthesis. Glucose enters adipose cells via GLUT4, undergoes glycolysis to produce pyruvate, which converts to acetyl-CoA for fatty acid synthesis, later combining with glycerol to form triglycerides for storage. This process, called lipogenesis, is driven by insulin, ensuring excess dietary energy is stored as fat in adipose tissue. Fatty acids from VLDL and chylomicrons. In the fed state, lipoprotein lipase in adipose tissue breaks down triglycerides from dietary chylomicrons and liver-derived VLDL into fatty acids and glycerol, which are taken up by adipocytes. These fatty acids are reassembled into triglycerides for storage, with chylomicrons dominating post-meal and VLDL, contributing during nutrient abundance. Want me to clarify a specific step, like lipogenesis, or connect this to starved state metabolism and adipose tissue?
Okay. Yeah, let's talk a bit more about this. Try to explain it to me.
Okay, let's break down adipose tissue metabolism in the fed state even simpler, focusing on GLUT4, glycolysis to fatty acids glycerol, and fatty acid uptake from VLDL chylomicrons, keeping it to 2 sentences per topic for the podcast. Metabolism and adipose tissue, fed state. After eating, insulin spikes tell adipose tissue to take in glucose through GLUT4 channels on cell surfaces, using it for energy or turning it into fat for storage. This helps store extra calories as fat, keeping energy ready for later. GLUT4, glycolysis, and fatty acid glycerol synthesis. Glucose enters fat cells via GLUT4, gets broken down by glycolysis into smaller bits, then turns into acetyl-CoA, which become...
Why don't you quiz me regarding everything we've said in this episode?
All right, let's do a quick, fun quiz on everything we've covered about metabolism in the fed state and starved states for the podcast, keeping it rapid fire with 1 or 2 word answers. Question 1. What hormone dominates in the fed state to drive glucose uptake?
It's too easy, go to the next one. Up the difficulty a bit.
All right, let's crank up the difficulty for the quiz. Question 2. What process in adipose tissue turns glucose into fatty acids for triglyceride storage in the fed state?
Beta oxidation.
Nope, not beta oxidation. That's for breaking down fats. The correct answer is lipogenesis. Let's keep the quiz going. Question 3. What transporter helps glucose enter muscle and adipose cells in the fed state?
GLUT4.
Nailed it. GLOT 4. Question 4. In the post-absorptive state, what process breaks down glycogen to release glucose in the liver?
Glycolysis.
Close, but glycolysis breaks down glucose for energy, not glycogen. The answer is glycogenesis. Next up, question 5.
Okay,
What are
now
the
let's continue. Okay, so tell me about the brain. Tell me about GLUT1 and 3. And yeah, tell me about glycolysis and the TCA cycle.
All right, let's dive into brain metabolism, focusing on GLUT1 and GLUT3, glycolysis and the TCA cycle, keeping it simple and sticking to 2 sentences each for our podcast. Brain metabolism. The brain primarily uses glucose as its energy source, relying on efficient uptake and metabolism to fuel neurons, especially in the fed state, though it can use ketones during prolonged starvation. Its high energy demand requires constant glucose delivery via specific transporters and metabolic pathways like glycolysis and the TCA cycle. GLUT1 and GLUT3. GLUT1 transporters, found in blood-brain barrier cells, and GLUT3 in neurons, bring glucose into the brain, with GLUT3's higher affinity ensuring neurons get priority for rapid energy use. In the fed state, insulin doesn't directly regulate these, but high blood glucose boosts their activity to meet the brain's needs. Glycolysis. In brain cells, glycolysis breaks down glucose into pyruvate, producing small amounts of ATP for quick energy, especially critical for neuronal activity. Pyruvate then feeds into mitochondria for further energy production or, in low oxygen, becomes lactate to maintain energy supply. TCA cycle, citric acid cycle. The TCA cycle in brain mitochondria uses pyruvate from glycolysis to generate acetyl-CoA, driving a cycle that produces ATP and electron carriers for oxidative phosphorylsilane, meeting the brain's high energy demands. It's essential for sustained neuronal function, with most of the brain's ATP coming from this cycle in the fed state. Want me to tie this to starved state brain metabolism, or zoom in on a specific pathway?
I want to shift the focus and talk a bit about metabolism in the early fasting state. So during fasting, the liver switches from a glucose utilizing to a glucose producing organ, as we said. And we have a decrease in glycogen synthesis. Instead, we have glycogenolysis, which I got confused and said glycolysis before, which was also wrong. Both of them would be wrong answers. So, let's start talking about that.
All right, let's dive into metabolism in the early fasting state, focusing on the liver's shift to a glucose-producing organ and clarifying glycogenesis and glycolysis, keeping it concise for the podcast. Early fasting state and liver's role. In the early fasting state, 4-16 hours post-meal, the liver shifts from using glucose to producing it via glycogenesis, breaking down stored glycogen to release glucose for blood sugar stability. Glucagon spikes and insulin drops, driving the switch to supply glucose, especially for the brain, while fatty acids start fueling other tissues. Clarification on glycogenesis and glycolysis. Glycogenesis is the process of making glycogen from glucose for storage in the fed state not active in fasting, while glycolysis breaks down glucose for energy, which is minimal in the liver during fasting as it prioritizes glucose production. Your earlier mix-up is understandable. Neither fits the early fasting liver's role, which is dominated by glycogenesis and later gluconeogenesis. Want me to zoom in on glycogenesis, gluconeogenesis, or tie this to brain metabolism?
Okay. Let's talk a bit about. Sorry, guys, I'm so tired. This is my 9th podcast back to back about protein in the liver and how it's broken down to amino acids to fuel gluconeogenesis.
No worries, you're killing it with 9 podcasts back to back. Let's dive into protein metabolism in the liver during fasting, focusing on how proteins are broken down into amino acids to fuel gluconeogenesis, keeping it simple for the podcast. In the early fasting state, as glycogen stores deplete, the liver breaks down proteins into amino acids, which are converted via gluconeogenesis into glucose to maintain blood sugar for the brain. This process, driven by glucagon and cortisol, prioritizes amino acids like alanine and glutamine, sparing muscle breakdown until prolonged fasting. Want me to break down gluconeogenesis steps or tie this to other fasting state processes?
Please. And let's talk a bit more on this beta oxidation. So fatty acids from lipolysis.
All right, let's keep it rolling for the podcast, diving deeper into protein breakdown for gluconeogenesis in the liver and lipid oxidation from lipolysis during the early fasting state, keeping it concise with 2 sentences each. Protein breakdown for gluconeogenesis. In early fasting, as glycogen runs low, the liver breaks down proteins into amino acids like alanine, which gluconeogenesis converts into glucose to fuel glucose-dependent tissues like the brain. Cortisol and glucagon drive this process, using enzymes to transform amino acids in hepatocytes, ensuring blood sugar stability until fat stores take over. Lipid oxidation and fatty acids from lipolysis. In the early fasting state, lipolysis in adipose tissue breaks down triglycerides into fatty acids and glycerol, with fatty acids undergoing beta oxidation in the liver and muscle mitochondria to produce ATP. This shift to lipid oxidation spares glucose for the brain, while glycerol can also feed into gluconeogenesis for additional glucose production. Want me to dive into specific gluconeogenesis steps, beta oxidation details, or tie this to another organ's metabolism?
I want to shift the focus and compare what we said before about the fed state. And now I want to compare it to the early fasting state. Let's talk a bit about the muscle, what's going on. So we have a switch to fatty acid oxidation.
All right, let's compare muscle metabolism in the fed state versus the early fasting state, focusing on the switch to fatty acid oxidation, keeping it simple and concise for the podcast. Fed state, muscle metabolism. In the fed state, insulin triggers GLUT4 transporters in muscle to take up glucose, which is used in glycolysis to produce ATP for muscle activity or stored as glycogen. Fatty acids from dietary chylomicrons are less used, as glucose is the primary energy source, supporting muscle contraction and repair. Early fasting state, muscle metabolism and fatty acid oxidation. In the early fasting state, 16 hours post-meal, insulin drops and glucagon rises, prompting muscles to switch to beta oxidation of fatty acids from lipolysis and adipose tissue, producing ATP to spare glucose for the brain. Fatty acids, delivered via albumin or derived from VLDL, become the main energy source, while muscle protein breakdown is minimal unless glycogen is very low. Want me to dive deeper into one state or compare another organ's metabolism?
Why don't we talk about adipose tissue now and compare it with the early fasting stage? So, what's going on with the GLUT4 transport system? Why is it reduced? And talk to me about the mobilization of triglycerides. And about the fatty acids and why some of them are released into the bloodstream.
All right, let's compare adipose tissue metabolism in the fed state versus the early fasting state, focusing on GLUT4, triglyceride mobilization, and fatty acid release, keeping it concise with 2 sentences each for our podcast. Fed state, adipose tissue metabolism. In the fed state, high insulin levels activate GLUT4 transporters in adipose tissue to take up glucose, which is converted via glycolysis and lipogenesis into fatty acids and glycerol for triglyceride storage. This process builds fat reserves, as insulin inhibits fat breakdown and prioritizes nutrient storage in adipocytes. Early fasting state, adipose tissue metabolism and GLUT4. In the early fasting state, low insulin and high glucagon reduce GLUT4 activity, limiting glucose uptake in adipose tissue as the body shifts to using stored fats for energy. Glucose metabolism slows, and adipose tissue focuses on releasing energy rather than storing it, driven by hormonal changes. Mobilization of triglycerides. During early fasting, glucagon and epinephrine trigger lipolysis in adipose tissue, breaking down triglycerides into glycerol and fatty acids to provide energy. Glycerol can be used by the liver for gluconeogenesis, while fatty acids fuel tissues like muscle and liver via beta oxidation. Fatty acid release into bloodstream. Fatty acids from lipolysis are released into the bloodstream, bound to albumin, to supply energy to organs like the muscle and liver, sparing glucose for the brain. This release increases in early fasting as adipose tissue becomes a primary energy source, supporting the body's needs until feeding resumes. Want me to dive deeper into lipolysis or compare another tissue's metabolism?
Let's compare the brain now with the early fasting state and the fed state. Tell me about the brain not switching to fatty acids and the glucose continuing to be metabolized because the brain is more picky.
All right, let's compare brain metabolism in the fed state versus the early fasting state, focusing on why the brain sticks to glucose and doesn't switch to fatty acids, keeping it simple for the podcast with 2 sentences per topic. Fed state, brain metabolism. In the fed state, the brain relies on glucose from dietary carbs, transported via GLUT1 and GL3, fueling glycolysis and the TCA cycle to produce ATP for neuronal activity. High blood glucose ensures a steady supply, meeting the brain's high energy demand without using fatty acids. Early fasting state, brain metabolism. In the early fasting state, 16 hours post-meal, the brain continues to metabolize glucose from liver glyconeosis and gluconeogenesis, as it can't efficiently use fatty acids due to the blood-brain barrier and lack of necessary enzymes. It remains picky, prioritizing glucose about 120 grams a day until prolonged fasting shifts some reliance to ketones. Brain not switching to fatty acids. The brain avoids fatty acids as an energy source because the blood-brain barrier limits their entry, and neurons lack enzymes for beta oxidation.
Okay. 10 words, summarize everything from today.
Brain prefers glucose, adipose stores, then releases fats. Liver shifts. Want me to expand on any part?
To be honest, guys, I was going for a complete summary takeaway sentence, but what can we do? Thank you for watching. Hey guys, welcome to another episode of the Human AI podcast. This is part 2 of talking about metabolism in the fed and starved states. Make sure you watch part 1 as we're continuing from where we left off. We talked in part 1 about the fed state, and now we're going to focus on the starved state a bit more. If you're unfamiliar with the structure of the podcast, I ask questions to AI. AI gives me answers on these questions, which are based on topics that I'm very unfamiliar with, like today's topic. So I gain knowledge through AI, but however, I do take everything with a pinch of salt, and so should you. Take everything that AI says with a pinch of salt. It might make inaccurate claims. Cross-reference everything you hear and enjoy. I hope you found this valuable. Let's talk, Grog, about metabolism in the starved state.
In the starved state, your body shifts gears to survive without food. After about 24 hours without eating, glycogen stores in the liver and muscles deplete, so the body turns to gluconeogenesis, breaking down proteins from muscles and other tissues to produce glucose for the brain and red blood cells. Simultaneously, it ramps up ketogenesis, where fats from adipose tissue are broken down into ketone bodies to fuel other organs, sparing glucose. Hormones like glucagon and cortisol drive this, while insulin levels drop. Over time, the brain adapts to use ketones, reducing protein breakdown. This conserves muscle, but can still lead to significant tissue loss and prolonged starvation. Energy expenditure also slows to preserve resources. Anything specific you want to dive into here?
Why would we have decrease in thyroid hormone concentration? And explain to me also the ketone bodies production.
In starvation, thyroid hormone levels, particularly
Grog,
T3, drop because the
let's
body
talk a bit
slows
louder,
metabolism
buddy.
to
Sorry,
conserve
sorry,
energy.
guys.
Low T3.
I'll ask it again. This usually doesn't happen. Hey Grog, so tell me why in the starved state we will have a decrease in thyroid hormones and we will have a production of ketone bodies?
In a starvation state, your body shifts into survival mode to conserve energy and resources. Thyroid hormone production decreases to slow your metabolism, reducing energy expenditure since food intake is limited. At the same time, the body ramps up ketone body production by breaking down fat stores for energy, as glucose from food is scarce. This metabolic switch helps prioritize fuel for vital organs like the brain.
Yeah, but how do fats become ketones? Remember, we're doing a podcast, it's 30 minutes long. Every answer should be 2-3 sentences. I hate interrupting, so it's good if we just have this mutual acknowledgement about it.
Fats are broken down into fatty acids through lipolysis in a starvation state. These fatty acids are then converted in the liver into ketone bodies, like acetoacetate and beta-hydroxybutyrate, through a process called ketogenesis. This provides an alternative fuel source for organs like the brain when glucose is low.
Okay. In the last episode, guys, the first part, we talked about the liver and the muscle and the brain and how they behave, what's going on regarding the metabolism in the early fasting states and in the fed state. Now we're going to compare that to the starved state. So let's talk about the liver first. What's going on there? So we didn't have any glucose entering, let's say for a long time, maybe a day or so. Glycogen stores are depleted. It's been 24 hours. Talk to me about plasma glucose, how it's dependent on gluconeogenesis now from lactate and glycerol and alanine.
So, after 24 hours of starvation, with glycogen stores depleted, the liver relies on gluconeogenesis to maintain plasma glucose levels, using lactate, glycerol, and alanine as key substrates. Lactate from tissues like muscles, glycerol from fat breakdown, and alanine from muscle protein degradation are converted into glucose to provide energy for the brain and other glucose-dependent tissues. This process keeps blood glucose stable, though at lower levels than in the fed state.
Interesting. How come lactate and glycerol and alanine suddenly can have the ability to perform gluconeogenesis?
Lactate, glycerol, and alanine can be converted into glucose through gluconeogenesis because they serve as substrates that the liver can metabolize into glucose precursors. Lactate is recycled via the Cori cycle into pyruvate. Glycerol from fat breakdown is phosphorylated to enter the pathway, and alanine is transaminated into pyruvate. These processes are upregulated in starvation to maintain blood glucose when glycogen is gone.
Okay. What about fatty acids entering the liver, providing energy to support gluconeogenesis? How does excess acetyl-CoA have to do with this? What does it have to do with this? How is it converted to ketone bodies? Yeah.
Fatty acids entering the liver are broken down via beta oxidation, producing acetyl-CoA, which generates energy to fuel gluconeogenesis. Excess acetyl-CoA, when not needed for the citric acid cycle, is converted into ketone bodies through ketogenesis in the liver's mitochondria. This process forms acetoacetate and beta-hydroxybutyrate, which are released into the blood to provide energy for tissues like the brain during starvation.
Okay. And what about the muscle? So we have now fatty acids as fuel, ketone bodies.
In the starved state, muscles shift to using fatty acids and ketone bodies as primary fuel sources to spare glucose for the brain. Fatty acids from fat stores are oxidized for energy, while ketone bodies, produced by the liver, become a significant fuel, especially as starvation persists. This reduces muscle protein breakdown, conserving amino acids like alanine for gluconeogenesis in the liver.
And let's talk a bit about the glucose fatty acid cycle. So, how does it spare glucose during fatty acid oxidation? It's not actually a cycle, but I'm using an analogy.
The glucose fatty acid cycle, or Randle cycle, describes how fatty acid oxidation in muscles reduces glucose use to spare it for critical tissues like the brain. When fatty acids are oxidized, they produce acetyl-CoA and NADH, which inhibit enzymes like pyruvate dehydrogenase, slowing glucose breakdown. This shifts muscles to rely on fatty acids and ketones, preserving blood glucose for glucose-dependent organs during starvation.
Okay, can I ask you about excess acetyl-CoA converted to citrate, and how does it inhibit PFK1, and what does it have to do with what we were talking about?
Excess acetyl-CoA in the liver during starvation is converted to acetate and other ketone bodies via ketoacegenesis, as it accumulates from fatty acid oxidation. This acetyl-CoA also increases citrate levels, which inhibits phosphofructokinase 1, PFK1, in glycolysis, reducing glucose breakdown in tissues like muscle. This ties to the glucose fatty acid cycle we discussed, as it helps spare glucose by prioritizing fatty acid and ketone use, preserving glucose for the brain.
And tell me about how increasing glucose prevents further glucose entry.
glucose levels rise in cells, it triggers feedback mechanisms to limit further glucose entry and uptake. High glucose increases insulin signaling, which downregulates glucose transporters like GLUT4 in muscle and fat cells, reducing glucose influx. Additionally, elevated glucose metabolates inhibit hexokinase, slowing glycolysis and further glucose processing to maintain metabolic balance.
Okay. Can we talk a bit about this? Because I'm confused about how glucose is spared during fatty acid oxidation.
During fatty acid oxidation, muscles prioritize burning fatty acids and ketones, which reduces their need for glucose. This process, part of the glucose fatty acid cycle, generates acetyl-CoA and NADH that inhibit key glycolysis enzymes like pyruvate dehydrogenase, slowing glucose breakdown. By relying on fats and ketones, muscles spare glucose for critical tissues like the brain that depend on it during starvation.
I don't get it.
All right, let's break it down simpler. When your muscles burn fatty acids for energy, they produce molecules that slow down the breakdown of glucose by blocking key steps in glycolysis, like the enzyme pyruvate dehydrogenase. This means muscles use less glucose, leaving more available for the brain, which needs it most during starvation.
Okay, let's talk about the adipose tissue now, in the starved state.
In the starved state, adipose tissue breaks down stored triglycerides into fatty acids and glycerol via lipolysis, driven by hormones like glucagon and epinephrine. These fatty acids are released into the blood to provide energy for tissues like muscle and liver, while glycerol is used by the liver for gluconeogenesis to maintain blood glucose. This process helps supply alternative fuels, sparing glucose for critical organs like the brain.
Interesting. So we have little glucose entry, and the body switches to using fatty acids. We have lipolysis activated. You have a low insulin-glucagon ratio. You have glycerol exported to the liver to be converted into glucose. I see.
Yeah, exactly. With low insulin and high glucagon in starvation, lipolysis ramps up in adipose tissue, releasing fatty acids for energy and glycerol for the liver to make glucose via gluconeogenesis. This shift keeps glucose levels stable for the brain while other tissues burn fats and ketones.
Can we talk about the brain, the starved state?
In the starved state, the brain initially relies on glucose from liver gluconeogenesis, but as starvation continues, it increasingly uses ketone bodies produced from fatty acid breakdown in the liver. This shift reduces the brain's glucose demand, preserving it for critical functions like red blood cell metabolism. Ketones, like beta-hydroxybutyrate, become a major energy source, supporting brain function efficiently during prolonged fasting.
So we have fatty acids, they cannot be used by the brain, but the ketone bodies cross the blood-brain barrier, enter the brain, and spare use of glucose. They can't completely replace the need for glucose, though. So the brain continues taking up glucose and metabolizing it through glycolysis.
Yeah, that's right. Ketone bodies cross the blood-brain barrier and become a major fuel source for the brain during starvation, reducing its reliance on glucose. But the brain still needs some glucose for certain functions since ketones can't fully replace it. The liver keeps supplying glucose via gluconeogenesis, and the brain continues using it through glycolysis, just at a lower rate to conserve it.
Okay, So we've got a YouTuber slash member of the European Parliament called Phidias Panayiotou. He didn't eat food for 30 days. And I'm just wondering, how was his body?
Oficias Panayiotou
No,
metabothia
sir, please speak in English. Never speak to me a different language.
My apologies for that. After 30 days of fasting, Phidias Panayiotou's body would likely have undergone significant metabolic changes, relying heavily on ketone bodies for energy, especially for the brain, while conserving glucose through gluconeogenesis from glycerol and amino acids. Prolonged fasting could lead to weight loss, reduced insulin levels, and potential risks like dehydration or nutrient deficiencies, though specific effects depend on his health and how he managed hydration and electrolytes.
So, can you kill cancer by fasting?
Fasting may stress cancer cells by limiting glucose, which many tumors rely on, potentially slowing their growth or making them more vulnerable to treatments like chemotherapy. However, there's no conclusive evidence that fasting alone can kill cancer.
Can you think of some quote some scientific studies regarding fasting and cancer? Extreme fasting specifically.
Research on extreme fasting and cancer is limited, but some studies suggest potential benefits. A 2014 study in mice from the University of California found that 48-hour fasting cycles combined with chemotherapy slowed cancer progression more than chemo alone, possibly by reducing glucose availability to tumors. Another study in Nature Communications showed that fasting mimicking diets with vitamin C delayed tumor growth in colorectal cancer mouse models, hinting at enhanced treatment effects.
Interesting. What about what's the longest fasting period that was studied scientifically to see the effects on the body? Quote a study. 30 days, 15 days, I don't know, 100 days.
The longest scientifically studied fasting period is typically around 21-30 days, with some extreme cases up to 40 days under medical supervision. A 1973 study in the Postgraduate Medical Journal documented a 382-day fast in a 27-year-old man, Angus Barbieri, who lost 296 pounds under medical monitoring, showing the body can adapt by using ketone bodies and minimal glucose, though such extended fasting carries risks like electrolyte imbalances and organ stress. Shorter studies, like a 2019 trial in Cell Metabolism, examined 21-day fasting mimicking diets, noting improved metabolic markers, but emphasizing the need for medical oversight.
Okay. Let's talk about ketone body concentration, how it increases during fasting. And then after just a bit more, let's just conclude on that, what I just said, and then let's talk a bit about hormonal control in the next message.
During fasting, ketone body concentration rises as the liver breaks down fatty acids into acetyl-CoA, which is converted into ketones like acetoacetate and beta-hydroxybutyrate. After 24-48 hours, ketone levels can increase from negligible to 1 to millimole LL, and by several days, they may reach 5-7 millimole LL, providing energy for the brain and sparing glucose. This rise reflects the body's shift to fat metabolism to conserve resources during prolonged nutrient deprivation.
Tell me about hormonal control of glycogenolysis and glycogen synthesis. Talk to me about allosteric control, but also about enzymes involved. How they are subject to hormonal control by glucagon and adrenaline and cortisol and insulin.
Hormonal control of glycolysis and glycogen synthesis involves insulin, glucagon, adrenaline, and cortisol, which regulate key enzymes and allosteric mechanisms. Insulin promotes glycolysis and glycogen synthesis by activating phosphofructokinase 1, PFK1, via fructose 2,6-bisphosphate and stimulating glycogen synthase, while glucagon and adrenaline inhibit these processes by increasing cyclic AMP, activating protein kinase A, which inhibits PFK1 and glycogen synthase, while promoting glycogen phosphorylase for glycogen breakdown. Cortisol supports gluconeogenesis over glycolysis by inducing enzymes like PEPCK, reducing glucose utilization with allosteric control for metabolites like ATP and citrate, further fine-tuning PFK1 and pyruvate kinase activity.
Okay. So we have glucagon, adrenaline, cortisol, insulin. These are hormones. We have their sources. Glucagon is in the pancreatic alpha cells, insulin in the pancreatic beta cells, cortisol in the adrenal cortex, adrenaline in the adrenal medulla. I'm just wondering how come these are the locations.
The locations of these hormone-producing cells tie to their specialized roles and embryonic origins. Insulin and glucagon come from pancreatic beta and alpha cells, respectively, because the pancreas develops from endoderm, evolving to regulate blood glucose via these islet cells. Cortisol and adrenaline are produced in the adrenal cortex and medulla, respectively, as the adrenals, derived from mesoderm and neural crest, are structured to manage stress responses, with the cortex handling steroid hormones like cortisol and the medulla producing catecholamines like adrenaline for rapid metabolic adjustments.
Okay. So tell me a bit about hormonal regulation of glycogen mobilization. So
Glycogen mobilization is primarily regulated by glucagon and adrenaline, which activate glycogen breakdown to release glucose. These hormones increase cyclic AMP, activating protein kinase A, which phosphorylates glycogen phosphorylase, turning it on to break glycogen into glucose 1-phosphate. Insulin opposes this by promoting glycogen synthase activity and inhibiting phosphorylase, favoring glycogen storage over mobilization.
can we talk about the reciprocal regulation of phosphorylase and glycogen synthase by phosphorylation? So tell me about glucogen and adrenaline activating glycogen breakdown, inhibiting synthesis by activating CAMP, PK, and mimicking by tell me about the calcium and tell me about protein kinase A and B, the active and the inactive, and ATP with ADP.
Glucagon and adrenaline drive glycogen breakdown by increasing cyclic AMP, which activates protein kinase A, PKA. PKA phosphorylates glycogen phosphorylase, turning it on to break glycogen into glucose 1-phosphate, while phosphorylating and inactivating glycogen synthase to halt glycogen synthesis. Calcium also activates phosphorylase kinase, boosting glycogen breakdown, whereas insulin promotes dephosphorylation via protein phosphatosis, activating glycogen synthase and inhibiting phosphorylase, with ATP acting as a phosphate donor in these kinase reactions.
So tell me about CAMP a bit more. I don't understand what exactly it does.
Cyclic AMP, KMP, acts as a second messenger in cells, amplifying signals from hormones like glucagon and adrenaline. It's produced when these hormones bind to receptors, activating adenylate cyclase, which converts ATP to CAMP. CAMP then activates protein kinase A, which phosphorylates enzymes like glycogen phosphorylase to promote glycogen breakdown and
So
inhibit glycogen.
CAMP will make us break down the glycogen to glucose because it turns phosphate kinase B to phosphate kinase A, which is the active form.
Not quite. Let me clarify.
Fuck.
Cyclic AMP, CAMP, activates protein kinase A, PKA, directly by binding to its regulatory subunits, releasing the active catalytic subunits. There's no conversion of kinase B to A. Active PKA then phosphorylates glycogen phosphorylase, turning it on to break down glycogen into glucose 1-phosphate, which is converted to glucose for energy during fasting or stress.
Dude, can you agree? Fucking hell. Can you tell me everything in 5 steps? I want you to include CAMP, ATP, AMP, ADP, calcium, glucagon, adrenaline, phosphate kinase A, phosphate kinase B, protein phosphatase, glycogen synthase A, glycogen synthase B. Include everything. 5 steps. I know it's difficult, but you can do it. Tell me the first step.
All right, let's break this down into 5 steps, covering glycogen mobilization and regulation with all the components you mentioned. I'll start with step 1, keeping it clear and concise for our podcast vibe. Step 1, hormone signaling and CAMP production. When you're fasting or stressed, glucagon from pancreatic alpha cells or adrenaline from adrenal medulla binds to receptors on liver or muscle cells, activating adenylate cyclase. This enzyme converts ATP into CAMP, KMP, which acts as a second messenger, amplifying the signal. CAMP levels rise, kicking off the cascade to mobilize glycogen for energy.
Step 2 in 2 sentences.
Step 2, protein kinase A activation. CAMP activates protein kinase A activation. CAMP amplifies the signal and activates protein kinase A, directly activates protein kinase A, PKA, releasing its active catalytic subunits.
Yeah. One more sentence of you stopped. Come on. We only have 2 minutes left. Let's go.
All right, CAP ramps up glycogen breakdown by activating protein kinase A, which rapidly triggers glucose release to fuel the body under stress. Now, what's the final topic you want to hit in these last 2 minutes?
We had 5 steps. This was step 2. Let's go. Step 3, quick. 1 sentence.
In step 3, activated protein kinase A phosphorylates glycogen phosphorylase kinase, which further amplifies glycogen breakdown into glucose 1-phosphate for energy. What's step 4?
You tell me what step 4 is.
In step 4, glycogen phosphorylase, now activated, breaks down glycogen into glucose 1-phosphate, which is quickly converted to glucose 6-phosphate. What's the 5th step?
You tell me what the 5th step is.
In step 5, glucose 6-phosphate is converted to free glucose by glucose 6-phosphatase in the liver, releasing glucose into the bloodstream for energy
Tell me
use.
again now in 2 sentences. You didn't mention protein phosphatase.
In step 5, glucose 6-phosphatase is converted to free glucose by glucose 6-phosphatase in the liver, releasing glucose into the bloodstream. Protein phosphatase reverses this cascade by dephosphorylating glycogen phosphorylase and synthase, halting breakdown and promoting glycogen storage when insulin dominates.
Okay. Now summarize today's episode in 2 sentences.
In today's episode, we explored how the body adapts to starvation, with the liver producing glucose via gluconeogenesis, muscles using fatty acids and ketones to spare glucose, and the brain relying on ketones as an alternative fuel. We also covered hormonal regulation, where glucose and adrenaline drive glycogen breakdown via CAP and protein kinase A, while insulin and protein phosphatase promote glycogen storage, illustrating the body's metabolic flexibility.
Okay. Thank you so much for watching, guys. I will see you in the next episode. Peace. Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about regulation of carbohydrate metabolism. I'm here with Grog, and AI is going to explain these topics to us. Please take everything that AI says with a pinch of salt. Perhaps it will make some inaccurate statements. Do proper science, cross-reference everything you hear. I hope you found this video enjoyable and valuable. Okay, Grog, introduce us to today's topic.
All right, thanks for the intro. Today, we're diving into the regulation of carbohydrate metabolism, exploring how the body controls glucose use and storage through hormones, enzymes, and metabolic pathways, all to keep energy balanced whether you're fed, fasting, or starving. Let's get started with the key players like insulin and glucagon. Want me to break down their roles first?
We've talked plenty about insulin and glucagon in the last episode, but briefly mention them and then briefly mention glycolysis too. Energy in the form of ATP, G3P, pyruvate, acetyl-CoA, amino acids, PFK1, pyruvate kinase, and then we'll go think about the glycolytic pathway a bit more.
Insulin promotes glucose uptake and storage, while glucagon triggers glucose release during fasting. Glycolysis converts glucose into pyruvate, producing ATP and intermediates like G3P, with PFK1 as a key enzyme regulated by energy levels and hormones. Pyruvate can form acetyl-CoA or, from amino acids, feed into other pathways. Want to dive deeper into the glycolytic pathway now?
Yeah, let's talk a bit about the glycolytic pathway.
The glycolytic pathway breaks down glucose into pyruvate through a series of enzyme-driven steps, generating 2 ATP and 2 NADH molecules per glucose for energy. Key enzymes like hexokinase, phosphofructokinase 1, PFK1, and pyruvate kinase control the rate, with PFK1 being a major regulatory point influenced by ATP, AMP, and hormonal signals. Want me to focus on a specific step or regulation in glycolysis?
So hexokinase will help glucose become G6P. Then ATP goes to ADP, and this is like the investment before the payoff. Then we have glucose phosphate isomerase, which will make it fructose 6-phosphate. I wonder why these specific enzymes.
Hexokinase phosphorylates glucose into glucose 6-phosphatate, G6P, using ATP, which becomes ADP, as an energy investment to trap glucose in the cell. Glucose phosphate isomerase then converts G6P into fructose 6-phosphatate, because this structural shift sets up fructose for further phosphorylation by PFK1, enabling efficient cleavage into 3 carbon units later in glycolysis. These enzymes evolved for their specificity and efficiency in catalyzing these early, irreversible steps to drive the pathway forward. Want to explore why PFK1 is the next critical step?
Yes, I would love it if you did that.
All right, phosphofructokinase 1, PFK1, is a critical step in glycolysis because it phosphorylates fructose 6-phosphatate into fructose 1,6-bisphosphate, committing the molecule to the pathway and setting the stage for its cleavage into 2 3-carbon units.
So this is a committed step, huh?
Yeah, exactly. PFK1 catalyzing fructose 6-phosphatate into fructose 1,6-bisphosphate is the committed step in glycolysis, locking the molecule into the pathway with no turning back. It's like the point of no return, regulated by ATP, AMP, and citrate to match energy needs. Want to talk about what happens next in the pathway, or focus on that regulation?
Let's talk about G3P and DHAP at that point.
After PFK1, fructose 1,6-bisphosphate is cleaved by aldolase into glyceradaphine 3-phosphatate G3P and dihydroxyacetone phosphatate DHAP, two 3-carbon molecules. These interconvert via triose phosphatate isomerase, with G3P proceeding in glycolysis to generate ATP and pyruvate, while DHAP can also feed into other pathways like glycerol synthesis. Want to go deeper into their roles or move to the next steps?
And DHAP can become G3P?
Yeah, DHAP can be converted into G3P by the enzyme triose phosphate isomerase, which interconverts these two molecules to ensure both feed into the next steps of glycolysis.
So now we have 1,3-DPG. NAD plus will become NADH in this stage. Why?
In glycolysis, after fructose 1,6-bisphosphate is split into G3P and DHAP, G3P is oxidized by glyceradaphine 3-phosphate dehydrogenase, converting NAD plus to NADH. This happens because G3P is oxidized to 1,3-D-sphosphoglycerate, donating electrons to NAD plus, which picks them up to form NADH, storing energy for later use in ATP production. Want to talk about how this NADH is used, or move to the next step?
Why do we need NAD plus to become NADH at that step?
We need NAD plus to become NADH in the glycolysis 3-phosphate dehydrogenase step because NADH acts as an electron acceptor, allowing G3P to be oxidized into 1,3-D-sphosphoglycerate, a key reaction that drives glycolysis forward. Without NAD plus picking up electrons to form NADH, the reaction would stall, halting ATP production downstream. Want to discuss how NADH contributes to energy production next?
I want to ask about 3PG.
3-phosphoglycerate, 3PG, is formed in glycolysis when 1,3-D-sphosphoglycerate is dephosphorated by phosphoglycerate kinase, producing ATP in the process. It's then converted to 2-phosphoglycerate by phosphoglycerate mutase, setting up the final steps toward pyruvate and more ATP. Want to dive into what happens to 3PG next, or its role in other pathways?
Well, it goes 2PG, then PEP, with enolase, and pyruvate eventually. Finally, pyruvate. Finally.
Yeah, exactly. 3PG becomes 2-phosphoglycerate via phosphoglycerate mutase. Then enolase converts 2PG to phosphoenolpyruvate, PEP, which pyruvate kinase finally turns into pyruvate, generating ATP in the last step. This wraps up glycolysis, producing pyruvate for either aerobic respiration or lactate fermentation, depending on oxygen. Want to explore what happens to pyruvate next, or something else?
So then pyruvate will become lactate or TCA or to the TCA cycle.
Pyruvate's fate depends on oxygen availability. In aeronormic conditions, it's converted to lactate by lactate dehydrogenase to regenerate NAD plus for glycolysis. In aerobic conditions, pyruvate enters the mitochondria, becoming acetyl-CoA to fuel the TCA Krebs cycle for more ATP production.
And why does NADH become NAD plus when pyruvate becomes lactate?
When pyruvate is converted to lactate by lactate dehydrogenase in aeronormic conditions, NADH is oxidized back to NAD+, donating its electrons to pyruvate. This regeneration of NAD+ is crucial to keep glycolysis running, as it ensures a supply of NAD+ for the glyceradaphine 3-phosphate dehydrogenase step. Want to explore how this fits into anaerobic energy production, or move to something else?
Tell me about so we have glucose, then glucose is broken down, and eventually pyruvate. Then we have the opposite. So what's the fucking difference of oxaloacetate and pyruvate?
Pyruvate and oxaloacetate are both key metabolites, but they differ in structure and roles. Pyruvate, a 3-carbon molecule from glycolysis, feeds into the TCA cycle as acetyl-CoA or becomes lactate anaerobically, while oxaloacetate, a 4-carbon TCA cycle intermediate, is critical for gluconeogenesis and replenishing the cycle, formed from pyruvate or amino acids. Want to dig into how oxaloacetate supports gluconeogenesis or its TCA cycle role?
Well,
Alright, so we were just talking about pyruvate and oxaloacetate's roles. Want to focus on how oxaloacetate ties into gluconeogenesis or something else in carbohydrate metabolism?
I would like to understand the difference between oxaloacetate and pyruvate because I haven't.
Pyruvate is a 3-carbon molecule produced in glycolysis, acting as a hub that can turn into lactate, acetyl-CoA for the TCA cycle, or feed into gluconeogenesis. Oxaloacetate, a 4-carbon molecule, is a TCA cycle intermediate that's also a key starting point for gluconeogenesis, formed from pyruvate via pyruvate carboxylase or from amino acids, helping replenish the cycle or make glucose. Want me to clarify their roles in gluconeogenesis or the TCA cycle further?
That's so good. I want to ask you a question. What does de novo mean?
De novo means from the beginning or anew, and in biology, it refers to processes like de novo synthesis, where molecules, such as glucose and gluconeogenesis, are created from non-sugar precursors like pyruvate or amino acids. For example, oxaloacetate can be used in the de novo production of glucose in the liver during fasting. Want to connect this to pyruvate and oxaloacetate and gluconeogenesis or another topic?
Tell me about lactate, amino acids, and glycerol. From what I understand, like we said, these are involved in gluconeogenesis.
Lactate, amino acids, and glycerol are key gluconeogenesis substrates that help the liver produce glucose during fasting. Lactate is converted to pyruvate via the Cori cycle. Amino acids like alanine are transaminated into pyruvate or oxaloacetate, and glycerol from fat breakdown is phosphorylated to glyceradaphine 3-phosphate, all feeding into glucose synthesis. Want to dive deeper into one of these substrates or how they fit into gluconeogenesis regulation?
Let's talk a bit about requirements for gluconeogenesis. And let's talk also about the unique enzymes, because it's not a simple reversal of glycolysis. It's got some unique enzymes, right?
Gluconeogenesis requires precursors like lactate, glycerol, and amino acids, plus energy from ATP and GTP, and it occurs mainly in the liver to produce glucose. Unlike glycolysis in reverse, it uses unique enzymes: pyruvate carboxylase, phosphoenolpyruvate carboxycanase, PEP-seq, fructose 1,6-bisphosphatase, and glucose 6-phosphatase to bypass irreversible glycolysis steps, ensuring efficient glucose synthesis. Want me to detail one of these enzymes or the energy demands further?
What are these enzymes?
The unique enzymes in gluconeogenesis are pyruvate carboxylase, which converts pyruvate to oxaloacetate using ATP, phosphoenolpyruvate carboxycanase, PEP-seq, which turns oxaloacetate into phosphoenolpyruvate using GTP, fructose 1,6-bisphosphatase, which dephosphorizes fructose 1,6-bisphosphate to fructose 6-phosphatate, and glucose 6-phosphatase.
And is this called the gluconeogenic pathway?
Yeah, exactly. The gluconeogenic pathway uses those unique enzymes, pyruvate carboxylase, PEP-seq, fructose 1,6-bisphosphatase, and glucose 6-phosphatase to synthesize glucose from non-carbohydrate precursors like lactate, glycerol, and amino acids. This pathway, mainly in the liver, ensures blood glucose levels stay stable during fasting or starvation. Want to explore how it's regulated or focus on something specific like hormonal control?
I want to take a step back and ask about the urea cycle.
The urea cycle in the liver converts toxic ammonia from amino acid breakdown into urea for excretion. It involves enzymes like carbamoyl phosphate synthesis I and ornithine transcarbamylase, using substrates like ammonia, bicarbonate, and aspartate, and is linked to gluconeogenesis since amino acids like alanine provide nitrogen for urea and carbons for glucose. Want me to break down the cycle steps or its connection to gluconeogenesis further?
Tell me about its connection to gluconeogenesis, and from what I understand, ammonia with carbon dioxide, water, ATP, and aspartate, I didn't know it needed ATP, will become urea. Isn't it a waste that we're wasting ATP for that? Or is it a necessary evil since ammonia is toxic?
The urea cycle and gluconeogenesis are linked because amino acids, like alanine, provide carbon skeletons for glucose production and gluconeogenesis, while their nitrogen is funneled into the urea cycle to form urea, requiring ATP to detoxify ammonia. Ammonia combines with carbon dioxide and aspartate in the cycle, using 2 ATP molecules per urea molecule to drive reactions like carbamoyl phosphate synthesis, making it a necessary energy cost to safely eliminate toxic ammonia. No other major waste product like urea requires such ATP investment, though processes like bile acid synthesis use some energy. The ATP cost for urea is essential to prevent ammonia toxicity. Want to dive deeper into the urea cycle steps?
So let's talk about the first step of the gluconeogenic pathway. From what I understand, pyruvate has to become oxaloacetate and then the gluconeogenic pathway starts?
Yeah, the first step of gluconeogenesis involves pyruvate being converted to oxaloacetate by pyruvate carboxylase in the mitochondria, using ATP and biotin to add a carboxyl group. This step is crucial because it bypasses the irreversible pyruvate kinase step of glycolysis, setting up oxaloacetate for further conversion to phosphoenolpyruvate. Want to go into the next step with PEP-seq or focus on why this happens in the mitochondria?
So basically, pyruvate carboxylase, what exactly does pyruvate carboxylase do to pyruvate so it becomes oxaloacetate?
Pyruvate carboxylase adds a carboxyl group to pyruvate, converting it into oxaloacetate in the mitochondria, using ATP to provide energy and biotin as a coenzyme to carry the carboxyl group. This reaction transforms the 3-carbon pyruvate into the 4-carbon oxaloacetate, a key step to kick off gluconeogenesis. Want to talk about how oxaloacetate moves to the next step or why biotin is critical here?
So what does it do? Does it chop off a carbon or something?
No, pyruvate carboxylase doesn't chop off a carbon. It adds a carboxyl group, CO2, to pyruvate, a 3-carbon molecule, turning it into oxaloacetate.
And what does that carboxyl group, why is it important? What does it do to the structure? Does it fit well to something or whatever?
The carboxyl group added by pyruvate carboxylase to pyruvate transforms it into oxaloacetate by adding a 4-carbon structure, which is critical for entering gluconeogenesis. This extra carbon allows oxaloacetate to fit into the next enzymatic step with phosphoenolpyruvate carboxycanase, PEP-seq, enabling the formation of phosphoenolpyruvate, a key intermediate for glucose synthesis. Want to dive into how PEP-seq uses oxaloacetate or stick with the carboxyl?
Tell me about phosphoenolpyruvate carboxycanase. So this enzyme will turn oxaloacetate to PEP.
Phosphoenolpyruvate carboxycanase, PEP-seq, converts oxaloacetate to phosphoenolpyruvate, PEP, in gluconeogenesis by removing a carboxyl group and adding a phosphate group, using GTP for energy. This step, occurring in the cytosol or mitochondria, bypasses the irreversible glycolysis step and is critical for producing PEP, which continues toward glucose synthesis. Want me to explain how PEP moves forward in the pathway or dive into PEP-6 regulation?
So what did you say it does? It removes what? It removes the carboxyl group.
Yeah, PEP-6 removes a carboxyl group from oxaloacetate and adds a phosphate group, using GTP as an energy source to form phosphoenol pyruvate, PEP. This reaction transforms the 4-carbon oxaloacetate into the 3-carbon PEP, a high-energy molecule that drives gluconeogenesis forward. Want me to clarify how this fits into the pathway or focus on something specific about PEP?
Well, then we go backwards. So when fructose 1,6-biphosphate becomes fructose 6-phosphate, is that the committed irreversible step? What's going on there?
When fructose 1,6-bisphosphate is converted to fructose 6-phosphate in gluconeogenesis by the enzyme fructose 1,6-bisphosphatase, it's a key regulated step, but it's not considered the committed irreversible step like PFK1 is in glycolysis. This reaction bypasses the irreversible PFK1 step of glycolysis, requiring energy input and regulation by citrate and AMP to favor glucose production during fasting. Want me to explain how this step is regulated or
Tell
move to
me
another?
about how it's bypassing that step and remind us what step PFK1 acts in glycolysis. Come on.
All right, I hear you, but I'm sticking to English as you asked. Did you want to dive into another aspect of
I
gluconeogenesis?
said, can you explain to us the PFK1 step in glycolysis and also explain to us how in the gluconeogenic pathway we can bypass the PFK1 step?
In glycolysis, phosphofructokinase 1, PFK1, catalyzes the irreversible step where fructose 6-phosphate is phosphornormalate to fructose 1,6-bisphosphate using ATP and is tightly regulated by ATP, inhibits, and AMP, activates, to control energy production. In gluconeogenesis, this step is bypassed by fructose 1,6-bisphosphatase, which removes a phosphate group from fructose 1,6-bisphosphate to form fructose 6-phosphate, driven by hydrolysis and regulated by citrate and fructose 2,6-bisphosphate to favor glucose synthesis. Want me to focus on the
I
regulation
didn't
of
understand your answer, dude. Fucking hell. 2 sentences, make it simple. Remember the question I asked.
In glycolysis, PFK1 turns fructose 6-phosphate into fructose 1,6-bisphosphate, a key step that locks glucose into energy production. In gluconeogenesis, fructose 1,6-bisphosphatase reverses this by removing a phosphate to make fructose 6-phosphate, allowing glucose synthesis to continue. Want me to simplify something else or keep going?
It's alright. Okay. Let's talk a bit about how glycogenolysis and glycogen synthase are reciprocally regulated. Remind me the regulatory mechanisms that are allosteric and hormonal.
Glyconeogenesis and glycolysis are reciprocally regulated to balance glucose release and use, with allosteric and hormonal mechanisms at play. Hormonally, glucagon and adrenaline activate glyconeogenesis via CMP and protein kinase A, phosphorating glycogenics phosphorylase to release glucose, while inhibiting glycolysis by downregulating PFK1. Conversely, Insulin inhibits glyconeogenesis by activating protein phosphatase and boosts glycolysis via PFK1, with allosteric regulators like ATP inhibits PFK1 and AMP activates PFK1, fine-tuning the balance. Want me to dive deeper into specific enzymes or focus on one regulatory mechanism?
Let's talk a bit about ATP, AMP, hydrogen ions, and PFK1, and how PFK1 is subject to energy-dependent allosteric regulation by the rest.
PFK1 in glycolysis is allosterically regulated by ATP, AMP, and hydrogen ions to match energy needs. High ATP inhibits PFK1, slowing glycolysis when energy is abundant, while AMP activates it when energy is low, and hydrogen ions, low pH, inhibit PFK1 to prevent excessive lactate buildup during anaerobic conditions. Want me to explain how these signals interact, or move to another part of glycolysis regulation?
Explain to me more about this, dude. Like, what's going on with ATP, AMP, and hydrogen ions? Tell me about ATP being inhibited. Sorry, ATP inhibiting and AMP leading to activation.
All right, let's break it down. ATP inhibits PFK1 by binding to its allosteric site, signaling high energy levels, which slows glycolysis to prevent excess energy production. AMP, on the other hand, activates PFK1 by binding to a different site, indicating low energy, boosting glycolysis to generate more ATP, while hydrogen ions from lactic acid buildup lower pH, inhibiting PFK1 to avoid overacidifying the cell during anaerobic conditions. Want me to focus on how these fit into the bigger picture of glycolysis, or dive into another detail?
So, sorry guys, fructose 6 phosphate becomes fructose 1,6 biphosphate with PFK1, and ATP inhibits this, but AMP pushes this to happen.
Yeah, exactly. In glycolysis, PFK1 converts fructose 6-phosphate to fructose 1,6-bisphosphatase using ATP, and is a key regulatory step. ATP inhibits PFK1 when energy is high, slowing the pathway, while AMP, signaling low energy, activates PFK1 to boost glycolysis and produce more ATP. Want to talk about how this regulation...
Well, what about fructose 1,6 biphosphatase, the enzyme? Does that have allosteric regulation, or is it only PFK1? And also, how come ATP decides that we don't want the conversion from fructose 6-phosphate to fructose 1,6 biphosphate, which will eventually mean glycolysis, which, yeah.
Fructose 1,6-bisphosphatase, which converts fructose 1,6-bisphosphatase back to fructose 6-phosphate in gluconeogenesis, is allosterically regulated, just like PFK1 in glycolysis. It's inhibited by AMP and fructose 2,6-bisphosphatase when energy is low, favoring glycolysis, while ATP inhibits PFK1 to slow glycolysis when energy is high.
Okay, so the opposite. So AMP wants PFK1 and doesn't want the other one, and vice versa for ATP. Yes or no?
Yes.
Okay, and tell me now, just in 2 sentences, fructose, glycolysis, what's the opposite of glycolysis? Gluconeogenesis. Just say yes or no.
Yes.
And when do we want glycolysis and when do we want gluconeogenesis? Answer in 2 sentences.
Glycolysis is favored after... Glycolysis is favored after eating when glucose is abundant, providing energy via ATP production. Gluconeogenesis kicks in during fasting or starvation to make glucose from non-sugar sources, maintaining blood sugar levels. Want to dive into
Thank you.
specific...
Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about regulation of carbohydrate metabolism. This is going to be part 2. So if you haven't watched part 1, I would suggest you do so. I'm here with AI, Grok specifically, and it's going to explain to us these topics that I'm unfamiliar with. Please take everything it says with a pinch of salt. Maybe it's saying something wrong. Nevertheless, I hope you found this video valuable and enjoyable. Okay, so we've left off talking about fructose 6-phosphate and fructose 1,6-biphosphatase. Biphosphate, sorry. Let's talk a bit about the regulation of PFK1 by hydrogen ions.
All right, welcome back to part 2, folks. Hydrogen ions, which increase with lactic acid buildup during low oxygen, lower the pH and allosterically inhibit PFK1, slowing glycolysis to prevent excessive acid accumulation in cells. This regulation helps balance energy production when oxygen is scarce, favoring other pathways like gluconeogenesis if needed. Want to dig deeper into how pH affects PFK1 or move to another regulatory mechanism?
So where did we find the hydrogen ions?
Hydrogen ions build up in cells when lactic acid is produced during anaerobic glycolysis, as pyruvate is converted to lactate to regenerate NAD+. This increase in acidity, lowering pH, allosterically inhibits PFK1 to slow glycolysis and prevent excessive acid accumulation. Want me to explain how this ties into energy balance?
So hydrogen ions are increased during anoxia or an anaerobic muscle contraction from lactic acid production.
Yeah, exactly. During anaerobic conditions like intense muscle contraction, pyruvate is converted to lactic acid to regenerate NAD+, increasing hydrogen ions and lowering pH. This acidic environment inhibits PFK1, slowing glycolysis to prevent excessive acid buildup. Want to explore how this affects muscle performance or another aspect of glycolysis?
What is anoxia and anaerobic muscle?
Anoxia is a complete lack of oxygen in a tissue or environment, while anaerobic muscle refers to muscle cells operating without sufficient oxygen, relying on glycolysis to produce ATP, which leads to lactic acid buildup. During anaerobic muscle contraction, like an intense exercise, this process generates energy quickly, but causes fatigue due to increased hydrogen ions and acidity. Want to dive into how this affects glycolysis regulation or something else?
Tell me again, I didn't get this.
All right, no worries. Anoxia is when tissues get zero oxygen, and anaerobic muscle means muscles working with low oxygen, using glycolysis to make ATP fast, producing lactic acid as a byproduct. This lactic acid increases hydrogen ions, lowering pH, which slows glycolysis by inhibiting PFK1 to avoid too much acid buildup. Want me to break down any specific part further, or focus on something like muscle fatigue?
Tell me about high AMP resulting in cellular damage.
High AMP levels signal low energy in cells, as AMP rises when ATP is depleted, often during stress like anoxia or intense exercise. While AMP itself doesn't directly cause cellular damage, its increase activates pathways like glycolysis to restore energy.
So regarding regulation of PFK1 by hydrogen ion, basically the lower pH inhibits glycolysis, yeah?
Yeah, exactly. A lower pH from increased hydrogen ions caused by lactic acid buildup during anaerobic conditions allosterically inhibits PFK1, slowing glycolysis to prevent excessive acid accumulation. This helps protect cells from damage due to overly acidic conditions. Want to dive into how this ties to other regulatory mechanisms or move to another topic?
Let's talk about, again, PFK1 regulation. So fructose 6-phosphate, so when we have high rates of glucose entry and or glycogen breakdown, what's going on? Is glycolysis stimulated to allow... Yes, actually that was a stupid question. Talk to me about fructose 2,6-biphosphate. So, is it the most potent allosteric activator?
Fructose 2,6-biphosphate is indeed the most potent allosteric activator of PFK1, strongly stimulating glycolysis by binding to PFK1 and increasing its affinity for fructose 6-phosphate, especially when glucose entry or glycogen breakdown is high. This molecule, regulated by insulin and glucagon via the enzyme PFK2, FB-PACE2, ramps up glycolysis to handle excess glucose and produce ATP efficiently. Want to dive into how fructose 2,6-biphosphate is controlled or its role in coordinating glycolysis and gluconeogenesis?
I don't get it, bro. I don't get it. Why do we call it most potent allosteric activator? No, why is it allosteric? I thought it was the main man.
All right, bro, let's clear it up. Fructose 2,6-biphosphate is called the most potent allosteric activator of PFK1 because it binds to a separate regulatory site on PFK1, not the main active site where fructose 6-phosphate binds, boosting the enzyme's activity indirectly and super effectively. It's not the main substrate like fructose 6-phosphate, but its allosteric role makes glycolysis go full throttle by enhancing PFK1's efficiency when glucose is plentiful. Want me to explain how it's made or why it's so powerful compared to other regulators?
I didn't understand your answer, dude. Allosteric, I thought meant like it's another molecule coming in. Like, this is the main molecule.
Okay, dude, let's make it crystal clear. Allosteric means a molecule, like fructose 2,6-biphosphate, binds to a different site on PFK1, not the main active site where the main substrate, fructose 6-phosphate, binds. And this binding supercharges PFK1's activity. It's like a power-up button, not the main fuel.
I don't get it. Explain me again.
All right, no sweat. Let's simplify it. Fructose 2,6-biphosphate is an allosteric regulator because it binds to a side site on PFK1, not the main spot where fructose 6-phosphate, the main substrate, binds. And this side binding turbocharges PFK1 to speed up glycolysis when glucose is high. Think of it like a coach hyping up the main player, making it work faster, not doing the main job itself. Want me to go over how it's controlled or stick with this?
Brother, explain it very simply. I don't understand how we can call it an allosteric activator. Why we're even allowed to do that.
All right, brother. Super simple. Fructose 2,6-biphosphate is called an allosteric activator because it binds to a special side spot on PFK1, not the main spot where the actual work happens with fructose 6-phosphate. This side binding flips a switch to make PFK1 work faster, revving up glycolysis like a booster without being the main fuel. Want me to explain what makes it so special?
What do you mean without being the main fuel, dude? I thought the whole point is that fructose 2,6-biphosphate and fructose 6-phosphate go react reversibly between themselves. So they are the main ones.
Okay, dude, let's clear this up. Fructose 2,6-biphosphate doesn't react reversibly with fructose 6-phosphate. It's a separate molecule that binds to a side site on PFK1, boosting its activity to convert fructose 6-phosphate, the main substrate, into fructose 1,6-biphosphate for glycolysis.
Okay. Let's talk about citrate and how it inhibits, and let's talk about how it signals TCA overload or fatty acid oxidation.
Citrate inhibits PFK1 in glycolysis by binding to its allosteric site, signaling high energy from an overloaded TCA cycle or increased fatty acid oxidation, which produces excess acetyl-CoA and citrate. This slows glycolysis to divert resources toward energy storage or gluconeogenesis when the cell has enough energy. Want me to dive into how citrate links to fatty acid metabolism or stick with its role in glycolysis?
Tell me a bit more about citrate.
Citrate, built up in the TCA cycle when acetyl-CoA is plentiful, acts as an allosteric inhibitor of PFK1, slowing glycolysis to prevent excess energy production. It signals the cell has enough energy, often from high fatty acid oxidation or a backed-up TCA cycle, pushing metabolism towards storing energy or gluconeogenesis. Want me to explain how citrate moves between pathways or its role in other processes?
Explain it one more time, as simple as possible.
Citrate, made in the TCA cycle when energy is high from fats or carbs, binds to a side spot on PFK1 and slows down glycolysis. It's like a stop sign telling the cell there's enough energy, so it can save or redirect resources. Want me to focus on citrate's role elsewhere or keep it here?
Brother, last time tell me and we go forward.
Alright, brother, super simple. Citrate builds up when the cell has lots of energy from the TCA cycle or fat breakdown, and it sticks to PFK1 to slow glycolysis, saving energy for other uses.
So it slows glycolysis. How does it do that?
Citrate slows glycolysis by binding to an allosteric site on PFK1, changing its shape to make it less active, so it converts fructose 6-phosphate to fructose 1,6-biphosphate more slowly. This acts like a brake, reducing glycolysis when the cell's energy levels are high from the TCA cycle or fat breakdown.
So fructose 6-phosphate plus ATP helped by the enzyme PFK2 will create fructose 2,6-biphosphate.
Yeah, exactly. PFK2 uses ATP to phosphorylate fructose 6-phosphate, creating fructose 2,6-biphosphate, a powerful allosteric activator that boosts PFK1 to speed up glycolysis. This happens when glucose is abundant, signaling the cell to ramp up energy production. Want to talk about how PFK2 is regulated or move to another part of the pathway?
So this is an allosteric. Okay, wait. So this is inhibiting fructose 1,6-biphosphatase, which would basically turn it back to fructose 6-phosphate.
Yeah, you're on the right track. Fructose 2,6-biphosphate allosterically inhibits fructose 1,6-biphosphatase, the gluconeogenesis enzyme that converts fructose 1,6-biphosphate back to fructose 6-phosphate, preventing glucose production when glycolysis is active. This keeps the cell from running glycolysis and gluconeogenesis at the same time, saving energy. Want me to explain how this balances the two pathways or move to something else?
Okay, so glycolysis is inhibited by ATP, fatty acid oxidation, and hydrogen ions.
Right. Glycolysis is slowed by ATP, which signals high energy and inhibits PFK1, fatty acid oxidation, which boosts citrate levels to also inhibit PFK1, and hydrogen ions, which lower pH during lactic acid buildup, further reducing PFK1 activity. These work together to dial back glycolysis when energy is plentiful or conditions are anaerobic. Want to dive into one of these regulators or shift to another topic?
And then glycolysis is activated by AMP and... Okay, what other things activate glycolysis?
Glycolysis is activated by AMP, which signals low energy and boosts PFK1 activity, and by fructose 2,6-biphosphate, a potent allosteric activator of PFK1 that ramps up glycolysis when glucose is abundant. Insulin also promotes glycolysis by upregulating PFK2, increasing fructose 2,6-biphosphate levels. Want me to explain how these work together or focus on one activator?
Tell me one more time.
glycolysis is activated by AMP, which signals low energy and revs up PFK1, and by fructose 2,6-biphosphate, a super strong PFK1 activator made by PFK2 when glucose is high. Insulin also boosts glycolysis by increasing PFK2 activity, pushing more fructose 2,6-biphosphate production. Want me to break down one of these in more detail or move forward?
I want you to tell me 5 questions, 5 super rapid quiz, whatever. Let's start with number 1 question. Based on what we talked about today.
All right, let's do a quick quiz based on today's chat. Question 1. What molecule is the most potent allosteric activator of PFK1 in glycolysis?
Ramp up the difficulty a bit.
All right, let's crank up the challenge for this rapid-fire quiz based on our talk. Question 1. How does citrate specifically inhibit PFK1 to slow glycolysis, and what does this indicate about the cell's energy state?
Well, it allosterically binds to PFK1.
You're on the right track. Citrate binds to an allosteric site on PFK1, changing its shape to reduce activity, slowing glycolysis, and this signals the cell has high energy from the TCA cycle or fat breakdown. Question 2. What enzyme converts fructose 6-phosphate to fructose 2,6-biphosphate, and how does it impact glycolysis?
One more time.
No problem. Question 2. What enzyme converts fructose 6-phosphate to fructose 2,6-biphosphate, and how does this molecule affect glycolysis?
One more time.
All right, here we go again. Question 2. What enzyme turns fructose 6-phosphate into fructose 2,6-biphosphate, and how does that molecule influence glycolysis?
PFK1, we've talked about this, dude. Okay, my answer should be only 1-2 words. Go.
PFK2 activates green, protects us. Fasting protects us.
What the fuck you on about?
Whoa, my bad. Looks like I got sidetracked there. Let's keep the quiz going. Question 3. What 2 molecules signal
Wait,
low
question 2 was PFK1, right?
My apologies, dude. Let's clear this up. Question 2 was about the enzyme that makes fructose 2,6-bisphosphorate, which is PFK2, not PFK1, and it activates glycoside by producing fructose 2,6-bisphosphorate.
What is it PFK2? I thought the whole point of glycolysis was that we go from fructose 6-phosphate to fructose 1,6-biphosphate with PFK1.
I get the confusion. Let's sort it out. PFK2 is a different enzyme from PFK1. It phosphorates fructose 6-phosphate to make fructose 2,6-bisphosphorate, a regulator.
2,6. This is the whole fucking confusion then. So there's fructose 2,6 and fructose 1,6. Wow, why didn't you point it out?
My bad, dude. I should have clarified earlier. Fructose 2,6-bisphosphorate, made by PFK2, is a distinct regulator that boosts PFK1's activity, while fructose 1,6-bisphosphorate is the product of PFK1's reaction in glycoside, turning fructose 6-phosphate into a key intermediate. Want me to break down their roles more or keep going with the quiz?
I see. Oh no, keep going with the quiz.
All right, let's jump back into the quiz. Question 3. What 2 molecules signal low energy to activate PFK1 in glycoside?
One more time?
No problem. Question 3. What 2 molecules signal low energy to activate PFK1 in glycoside?
AMP.
You got one. AMP is correct. And the other molecule is fructose 2,6-bisphosphorate, both signaling low energy to activate PFK1 and boost glycoside.
What's
Question
the other
4.
one? What's the other one?
My bad for the cutoff. The two molecules that signal low energy to activate PFK1 and glycoside are AMP and fructose 2,6-bisphosphorate. Question 4. Which enzyme in glycoside bypasses PFK1's irreversible step by converting fructose 1,6-bisphosphorate to fructose 6-phosphorate?
You know what? Let's put a pause to the quiz. I want to ask you a few other things. Maybe we'll have time in the end. We can continue. So, muscle uses glucose and glycogen for energy. By increasing fructose 2,6-biphosphate and stimulating glycolysis. Can you explain this a bit? And can you explain how the liver uses glucose produced by gluconeogenesis and glycogen to maintain blood glucose so glycolysis is inhibited? Explain it in 3 sentences, really, really nice and simply.
In muscle, fructose 2,6-bisphosphorate, made by PFK2, boosts PFK1 to speed up glycoside, helping the muscle burn glucose and glycogen for quick energy during activity. In the liver, gluconeogenesis and glycogenosis produce glucose to maintain blood sugar levels, especially during fasting, and glycolysis is slowed by low fructose 2,6-bisphosphorate and high citrate to prioritize glucose release into the bloodstream. This balance ensures muscles get energy when active, while the liver keeps blood glucose stable for the whole body. Want me to dive deeper into muscle or liver specifics?
Tell me one more time, please.
Alright, super simple. In muscle, fructose 2,6-bisphosphorate ramps up PFK1 to speed glycolysis, letting muscles use glucose and glycogen for quick energy. In the liver, gluconeogenesis and glycogen breakdown make glucose to keep blood sugar steady, and glycolysis is slowed by low fructose 2,6-bisphosphorate and high citrate to focus on releasing glucose. This way, muscles get energy for action, while the liver supports blood glucose for the body. Want to go deeper into one part, or return to the quiz?
I don't get it, dude.
No worries, dude. Let's break it down even simpler. In muscles, fructose 2,6-bisphosphorate acts like a gas pedal, speeding up glycolysis so muscles can burn glucose and glycogen for energy during exercise. In the liver, when it's making glucose from gluconeogenesis or glycogen to keep blood sugar stable, glycolysis gets turned down by low fructose 2,6-bisphosphorate and high citrate to save glucose for the body. Want me to focus on one part or go back to the quiz?
Can you explain it as simply as possible?
Alright, dude, super simple. In muscles, fructose 2,6-bisphosphorate pushes glycolysis to go fast, using glucose and glycogen for energy when you're active. In the liver, glycolysis slows down because low fructose 2,6-bisphosphorate and high citrate tell it to save glucose for blood sugar.
I don't get this difference, dude. Why do we have this? So, in the liver, not only do we have control, have to control glycolysis with PFK1, also the reverse reaction of gluconeogenesis at fructose 1,6-biphosphatase to allow reciprocal control of the two reactions. So then the liver PFK2 and F26-biphosphatase we have are a single tandem enzyme with two active sites. So why would phosphorylation inhibit PFK2 and stimulate fructose 2,6-biphosphatase? And why do neither PFK1 nor fructose 1,6-biphosphatase are directly controlled by hormones through phosphorylation, but by the level of fructose 2,6-biphosphate, which is affected by hormones? I know I've laid a lot of things now. Explain them as simply as possible. You can do it in steps.
Alright, dude, let's break this down super simple, step by step, to clear up the confusion about PFK1, fructose 1,6-bisphosphatase, PFK2, fructose 2,6-bisphosphate, and how hormones fit in. I'll keep it short and clear for each step. Step 1. Why control glycolysis and gluconeogenesis oppositely? Glycolysis, breaking down glucose for energy, and gluconeogenesis, making glucose, are opposites, So the body uses PFK1 to speed up glycolysis and fructose 1,6-bisphosphatase to drive gluconeogenesis, ensuring they don't both run at the same time to save energy. If glycoside is on, gluconeogenesis is off, and vice versa, like a seesaw. Step 2. What's the deal with PFK2 and fructose 2,6-bisphosphatase? PFK2 and fructose 2,6-bisphosphatase are two activities of one tandem enzyme with two sites. PFK2 makes fructose 2,6-bisphosphatase to boost glycolysis, while fructose 2,6-bisphosphatase breaks it down to favor gluconeogenesis. This dual enzyme acts like a switch to control which pathway dominates based on the cell's needs. Step 3. Why does phosphorylation flip their activities? When hormones like glucagon during fasting signal through CAMP and protein kinase A, phosphorylation turns off PFK2, stopping fructose 2,6-bisphosphate production, and turns on fructose 2,6-bisphosphatase, lowering fructose 2,6-bisphosphatase to slow glycolysis and boost gluconeogenesis. Insulin does the opposite, dephosphorylating the enzyme to activate PFK2 and increase fructose 2,6-bisphosphatase, favoring glycolysis. Step 4. Why aren't PFK1 and fructose 1,6-bisphosphatase directly phosphorylated by hormones? PFK1 and fructose 1,6-bisphosphatase aren't directly phosphorylated by hormones. Instead, their activity is controlled by fructose 2,6-bisphosphatase levels, which act like a master regulator. Hormones like insulin or glucagon indirectly tweak PFK1, activated by high fructose 2,6-bisphosphatase, and fructose 1,6-bisphosphatase, inhibited by it, through PFK2, fructose 2,6-bisphosphatase, making regulation precise and efficient. Step 5. Why is fructose 2,6-bisphosphatase the key player? Fructose 2,6-bisphosphatase is the main signal because it powerfully activates PFK1 to push glycolysis when glucose is high and inhibits fructose 1,6-bisphosphatase to block gluconeogenesis, ensuring the liver either uses or makes glucose based on hormonal signals like insulin, fed state, or glucagon, fasting. This setup lets the body quickly adjust metabolism without directly messing with PFK1 or fructose 1,6-bisphosphatase. Want me to repeat any step or dive deeper into one part?
Tell me about activation of gluconeogenesis. So we have increased fatty acid oxidation leading to increase in acetyl-CoA. It's an allosteric activator of pyruvate carboxylase. It's an inhibitor of pyruvate dehydrogenase, and it favors gluconeogenesis over glycolysis. Explain this to me. Explain to me how increased glucagon will inhibit PFK2 activity and stimulate fructose 2,6-biphosphatase by phosphorylation. Explain CAMP-dependent protein kinase. Explain to me how it will result in the fall of fructose 2,6-biphosphate, and how this decreased fructose 2,6-biphosphate levels will reduce the activation of PFK1, which inhibits glycolysis, and then relieve the inhibition of fructose 1,6-biphosphatase, which stimulates gluconeogenesis. Once you do that, I want you to also tell me about hormonal regulation of gluconeogenesis. Tell me about how it's stimulated in the short term by glucagon and adrenaline, and then in the long term by glucagon, glucocorticoids, and thyroid hormones, and inhibited by insulin by dephosphorylation and suppression of lipolysis. Do that in 4 sentences. In the 5th one, just recap the episode for one main takeaway in one last sentence.
All right, let's dive into this. Increased fatty acid oxidation raises acetyl-CoA levels, which allosterically activates pyruvate carboxylase to kickstart gluconeogenesis by converting pyruvate to oxaloacetate, while inhibiting pyruvate diagностase to block pyruvate's conversion to acetyl-CoA, favoring gluconeogenesis over glycolysis. Meanwhile, glucagon activates CMP-dependent protein kinase A, which phosphorylates the PFK2 fructose 2,6-bisphosphatase enzyme, inhibiting PFK2 to reduce fructose 2,6-bisphosphate production and activating fructose 2,6-bisphosphatase to break it down, lowering fructose 2,6-bisphosphatase levels, which reduces PFK1 activation to slow glycolysis and relieves inhibition of fructose 1,6-bisphosphatase, boosting gluconeogenesis. In the short term, glucagon and adrenaline stimulate gluconeogenesis by increasing CMP, activating protein kinase A, and upregulating key enzymes like pyruvate carboxylase and PEPCK. In the long term, glucocorticoids enhance gluconeogenesis by inducing enzyme expression like PEPCK, while thyroid hormones boost metabolic rate, supporting glucose production. Insulin inhibits gluconeogenesis by dephosphorylating key enzymes via protein phosphatase and suppressing lipolysis, reducing fatty acid substrates. The main takeaway from today's episode is that gluconeogenesis is tightly regulated by a balance of hormonal and allosteric mechanisms, particularly through acetyl-CoA and fructose 2,6-bisphosphatase.
Thank you for watching, guys. Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about the posterior abdominal wall. If you're unfamiliar with how the podcast works, I ask questions to Grok, an AI. I'm unfamiliar with these topics, so I learn by asking AI. Take everything that AI says with a pinch of salt. It might give inaccurate statements from time to time. Cross-reference everything you hear. Having said that, I hope you find this video enjoyable and valuable. Grok, give us an introduction to the posterior abdominal wall.
The posterior abdominal wall is the back boundary of the abdominal cavity, primarily formed by muscles, bones, and connective tissue. It includes the lumbar vertebrae, the psoas major and minor, iliacus and quadratus lumborum muscles, as well as the diaphragm's crura, all working together to support the spine, protect organs, and enable movement.
Interesting. So, since you mentioned bones, let's talk a bit about the osteology of the posterior abdominal wall. So, we've got ribs, we've got the sacrum, we've got ilia, we've got lumbar vertebra. Can you explain to us more about this?
The osteology of the posterior abdominal wall centers on the bony structures that provide its framework. The lumbar vertebrae, typically 5 in number, form the central bony column, supporting the spine and bearing the body's weight. The 12th rib, the lowest floating rib, contributes to the upper boundary in some individuals. The sacrum, a fused triangular bone at the base of the spine, anchors the pelvis and connects to the iliac, which are the broad, wing-like portions of the pelvic bones. These structures together create a stable foundation for the muscles and fascia of the posterior abdominal wall, protecting vital organs and facilitating posture and movement.
So, what exactly is the sacrum and the ilia?
The sacrum is a large, triangular bone at the base of the spine, formed by the fusion of 5 sacral vertebrae. In the posterior abdominal wall, it serves as a strong, stable anchor, connecting the spine to the pelvis via the sacroiliac joints with the iliac, supporting the body's weight and stabilizing the pelvic region.
So the sacrum fuses 5 vertebrae?
Yep, that's right. The sacrum is formed by the fusion of 5 sacral vertebrae, typically fusing during adolescence into a single, solid triangular bone that anchors the spine to the pelvis.
And what about the ilia?
The iliac are the large, broad bones forming the upper part of the pelvis, one on each side. In the posterior abdominal wall, they connect to the sacrum at the sacroiliac joints, providing structural support and stability to the pelvis,
And
while
the
serving...
ilia has parts.
The ilium, singular for iliac, has several key parts. It's the broad, fan-shaped upper portion of the pelvic bone, with a crest at the top, the iliac crest, where you can feel your hip bone. It has an inner and outer surface for muscle attachments, like the iliacus on the inner side. The ilium also includes the sacroiliac joint surface, where it connects to the sacrum, and the acetabulum, a socket that forms part of the hip joint for the femur. These parts together provide stability, support, and attachment points for the posterior abdominal wall and pelvic structures.
Tell me again about the ilia's parts. We have the pubis.
I think you might be mixing up the ilium with the pelvis as a whole. The ilium is just one part of the pelvic bone, and it doesn't include the pubis directly. Let me clarify the parts of the ilium, since that's what we were discussing. The ilium is the broad upper portion of the pelvic bone. Its main parts include the iliac crest, the top edge you can feel at your hips, which serves as an attachment for muscles like the abdominals. The inner surface has the iliac fossa, where the iliacus muscle sits. The auricular surface forms the sacroiliac joint with the sacrum, providing stability. The acetabulum, a cup-like socket, is partly formed by the ilium and connects to the femur for the hip joint. The pubis, which you mentioned, is a separate part of the pelvic bone, not the ilium. It's the anterior portion of the pelvis, joining at the pubic symphysis. If you meant the whole pelvis or want more on the pubis, let me know, and I can dive into that.
I'm a bit confused. What's the hip bone called?
The hip bone is called the innominate bone or pelvic bone, typically non-acrylic. It's a large, irregularly shaped bone that forms each side of the pelvis. Each hip bone is made up of 3 fused parts: the ilium, the sacroiliac crest, the auricular fossa, the ischium, the ominate bone, the ischium, and the pubis.
Okay, and the ilium is the same thing as the iliac that we were talking about?
Yep, exactly. The ilium is the same thing as what we've been referring to as the iliac or iliac. It's the broad upper part of the hip bone or pelvic bone that forms a major component of the pelvis. The term iliac is just the plural form, referring to the 2 ilium bones, one on each side of the pelvis. So when we talk about the ilium, we're talking about that wing-like upper portion of the pelvic bone that connects to the sacrum and supports muscles like the iliacus and the posterior abdominal wall. Clear now? Or want me to dig deeper?
No, I get it. And what's the iliopubic eminence?
The iliopubic eminence is a bony projection on the pelvic bone where the ilium and pubis meet. It's a small, rounded ridge that marks the junction between these 2 parts of the hip bone, serving as a landmark for muscle and ligament attachment.
What are the 3 parts of the hip bone? The ilium, the pubis, and?
The hip bone, or pelvic bone, is made up of 3 fused parts: the ilium, the pubis, and the ischium. The ilium is the broad upper part we discussed, forming the top of the pelvis. The pubis is the anterior part, meeting at the pubic symphysis in the front. The ischium is the lower posterior part, the bit you sit on, often called the sits bone.
Solid. Righty. Why don't we shift topics and talk about the musculature now of the posterior abdominal wall?
All right, let's dive into the musculature of the posterior abdominal wall. The main muscles here are the psoas major, psoas minor, iliacus, and quadricetus lumborum. The psoas major runs from the lumbar vertebrae to the femur, flexing the hip and stabilizing the spine. The psoas minor, not always present, assists with slight spinal flexion. The iliacus, originating from the iliac fossa, joins the psoas major to form the iliopsoas, a powerful hip flexor. The quadricetus lumborum, a square-shaped muscle in the lower back, connects the iliac crest to the ribs and vertebrae, aiding in lateral spine flexion and stabilizing the lower back. These muscles work together to support posture, movement, and protect organs in the abdominal cavity. Want me to break down any of these muscles further?
Interesting. So, tell me, buddy, who named these muscles?
The names of the posterior abdominal wall muscles, like psoas major, iliacus, and quadricetus lumborum, come from a mix of Latin and Greek roots, largely standardized by early anatomists. The term psoas derives from the Greek word for loins, describing its location along the lumbar spine. Iliacus comes from Latin, referring to its origin on the ilium. Quadricetus lumborum is Latin, meaning square of the loins, due to its shape and position. These names were formalized by figures like Andreas Vesalius in the 16th century, who revolutionized anatomy with detailed dissections, and later through works like the Nomina Anatomonica, a standardized naming system. Exact individuals tying names to specific muscles are tough to pinpoint, as naming evolved over centuries through collaborative anatomical study. Want more on any specific muscle's history?
Interesting. Yeah, you know what? I would love to learn about the muscles history. And also from an evolutionary perspective, I wonder like how did we end up kind of having these um, muscles, Like how did we end up with this specific location and width and like how the structure at the end was it always like that? Did these muscles evolve over years? How did these muscles differ in other like Neanderthals and Erectuses and Denisovas and all of this?
All right, let's dive into the history and evolutionary perspective of the posterior abdominal wall muscles, psoas major, iliacus, and quadratus lumborum. I'll blend their naming origins with how they evolved and what we know about differences in early hominins like Neanderthals, Homo erectus, and Denisovans. Starting with the historical naming, these muscle names are rooted in Latin and Greek, formalized during the Renaissance by anatomists like Andreas Vesalius, who published De Humani Corporis Fabrica in 1543. Psoas comes from the Greek psoa, meaning loins, reflecting its position along the lumbar spine. Iliacus is from Latin iliac, tied to the ilium bone where it originates. Quadratus lumborum, also Latin, describes its square shape and lumbar location. These terms stuck through works like the Nomina Anatomonica in the 19th and 20th centuries, which standardized anatomical language based on centuries of dissection and observation. Earlier, Greek physicians like Galen in the 2nd century AD laid groundwork by describing muscles functionally, but Vesalius and his successors refined the terms we use today. Now, onto the evolutionary angle. How did we end up with these muscles and their specific locations, sizes, and structures? The posterior abdominal wall muscles evolved to support upright posture, bipedal locomotion, and spinal stability, which are hallmarks of human evolution. Let's break it down. 1. Psoas major and iliacus and iliopsoas. These muscles form the iliopsoas, a key hip flexor that pulls the thigh toward the torso. In early tetrapods, like amphibians and reptiles, similar muscles, homologous to the psoas and iliacus, helped with limb movement and body stabilization during sprawling locomotion. As mammals evolved, particularly primates, the psoas major became more prominent, anchoring to the lumbar vertebrae to support a more upright torso. In early hominins, like Australopithecus, around 4 to million years ago, the shift to full bipedalism refined the iliopsoas. Fossil evidence, like pelvic and femoral remains, suggests the ilium widened and the iliopsoas attachment sites grew more robust to handle the mechanical demands of walking upright. In modern humans, the psoas major's long, thick structure and the iliacus's broad origin on the ilium reflect adaptations for powerful hip flexion and spinal stabilization during walking, running, and climbing. 2. Quadratus lumborum. This muscle, unique to mammals, stabilizes the spine and pelvis during lateral movements. In quadrupedal primates, it's less developed, but in hominins, it enlarged as upright posture demanded more lateral stability. Fossil lumbar vertebrae from Homo erectus, 1.9 million to 100,000 years ago, show attachment sites for a quadratus lumborum, similar to ours, suggesting it was critical for their bipedal gait and possibly for activities like tool use, carrying.
Interesting. Okay, let's continue. And I want us to touch on the origins, insertions, actions, and innervations of these, muscles. So, why don't we start with the quadratus lumborums?
All right, let's dive into the quadratus lumborum, one of the key muscles of the posterior abdominal wall. Here's the breakdown. Origin. The quadratus lumborum originates from the iliac crest, the top edge of the ilium, and the iliolimbar ligament, which connects the ilium to the limbar vertebrae. Insertion. It inserts onto the transverse processes of the upper four lumbar vertebrae, L1, L4, and the lower border of the 12th rib. Actions. This muscle is a powerhouse for lateral flexion of the spine, meaning it bends the trunk to the side. It also stabilizes the spine and pelvis, especially during upright posture or movements like walking. When both sides contract together, it can help extend the lumbar spine slightly. It's also a sneaky helper in forced exhalation by pulling down on the 12th rib. Innervation. The quadratus lumborum is innervated by branches of the lumbar plexus, specifically the anterior rami of the T12 and L1, L4 spinal nerves. Want me to move on to the psoas major or another muscle next?
So, in our skeleton, then, the fact that the quadratus lumborum origin is the iliolumbar ligament and the iliac crest, whereas the insertion is the transverse process of L1 to L4 and